attributed to the immunocompromised state that has been seen in diabetes, and also because of the bacterial pathogens, then impaired neutrophil function, altered collagen metabolism, and microangiopathy. Commonly encountered oral manifestations in diabetes mellitus include xerostomia, that is the dry mouth, oral dysesthesia, the burning mouth syndrome, dental caries, periodontal disease, poor wound healing, oral infections, and dry mucosal surfaces. So in this session, the main emphasis will be laid on periodontal disease. Periodontal disease has now been recognized as the 6th complication of diabetes. And according to a study conducted in 2018, wherein the healthy individuals were compared to the diabetic participants, and it was seen that the diabetic participants showed a higher prevalence of periodontitis. Another study conducted in 2019, wherein the study population, all the subjects had HbA1c levels more than 8%, and they were grouped into 3 groups based on their oral hygiene status as good, fair, and poor oral hygiene. The maximum prevalence of periodontitis was seen in poor oral hygiene patients. Justified the correlation between periodontitis and diabetes mellitus. Now, before I proceed to the relationship between periodontitis and diabetes mellitus, I would just quickly throw some light on what a periodontium is and what does a periodontal disease look like. Periodontium is nothing but a tooth-supporting complex which comprises of 4 components: gingiva, or what we commonly call as gums, the periodontal ligament, which forms the shock absorber for the teeth. Now, periodontal ligament and gingiva, it forms the hard tissue compartment. Now, the main etiological factor behind periodontal disease is dental plaque, which is a highly variable and structural entity that comprises of microorganisms, food debris, mucin, desquamated epithelial cells, and all of them are embedded in the gelatinous matrix. Plaque is mostly found on the tooth surface and in periodontitis, the dental plaque, which is a soft entity, it calcifies and becomes calculous, which migrates apically, leading to deepening of the gingival sulcus, leading to formation of a periodontal pocket and beginning of the bone loss. Even now, if the condition is not addressed, then it further advances and the progression of the bone loss increases and it ultimately leads to shedding of the tooth. Now, this is exactly what a clinical picture looks like in gingivitis. Here we can appreciate the inflammation of the marginal gingiva caused due to accumulation of the dental plaque. Now, this condition is reversible. Once the etiology is removed, the health is restored back. And the main advantage with gingivitis is that it is only confined to the soft tissue, that is the gingiva. Again, if it remains untreated, then the disease progresses, as we can appreciate the deepening of the periodontal pocket here, and there is swelling of the gums and loosening due to accumulation of the plaque, and there is also recession of the gum due to bone loss. The confirmed diagnosis can be made by the radiographic examination, because many a times the clinical features are masked due to some deleterious habits like tobacco smoking, etc. When we say periodontitis, what exactly happens in it, or the pathogenesis? As I already described, the dental plaque, which comprises of microorganisms, is the main etiological factor. So when the microbial plaque accumulates in the subgingival environment, it poses a microbial insult to the host by releasing antigens, lipopolysaccharides, and its other virulence factors. Now, in order to combat this insult, the body releases antibodies, PMNs, and the monocytes. But in an immunocompromised state, the first line of defense often fails, leading to progression of disease caused by release of cytokines and prostanoids, and MMPs, the matrix metalloproteinases, which causes destruction of the connective tissue and disrupts the bone metabolism by increasing the osteoclastic activity. And this is when the clinical signs of the disease initiation and progression appears. Now, the entire pathogenesis is influenced by the environmental and the acquired risk factors, like diabetes is one of the major risk factors, and then various genetic factors due to different types of gene polymorphisms. Now coming on to the interplay between diabetes mellitus and periodontal disease. It is basically like a double-edged sword. So firstly, I'll be describing about the effects of periodontitis on diabetes. A patient who is diabetic and is suffering from chronic periodontitis tends to have a shift in the subgingival microflora from aerobic microflora to anaerobic microflora. As the disease progresses, in the apical region, the oxygen level decreases and the virulent microorganisms, they get the conducive environment to become even more virulent, and it invades the host defense, which inflammatory cytokines, especially IL-1 beta, IL-6 and TNF alpha. And due to hyperactivity or the impaired chemotaxis and phagocytosis of the PMNs, an oxidative stress is created, which causes an increase in the reactive oxygen species, leading to an increase in the Rankel-OPG ratio along with a compromised immunity. All these factors causes an non-enzymatic glycosylation of the connective tissue proteins and other intracellular proteins, and leading to formation of advanced glycation end products, which are however formed in normal scenario also, but in case of hyperglycemia, they are formed in excess amounts. And due to increased amount of AGs, the glucose transport 4 receptor transcription signaling, which causes a hyperglycemic state, which is seen in diabetes. Now the other side of the coin is the pathogenesis of diabetes in periodontal disease. Various mechanisms have been proposed. Mainly there is delayed wound healing, altered extracellular matrix metabolism, formation of AGs, hyperactive monocytes and PMNs, and shift in the subgingival microflora. Now the growth factors and fibroblasts, which are very important for for healing, are reduced due to the decreased chemotaxis and phagocytosis of the PMNs. Then once the AGs, they combine with their receptors, they tend to form a cross linkage with the collagen fibers that are present in the extracellular matrix, and it increases the collagenolithic activity and decreases the collagen synthesis, thereby affecting. So when the ground substance present in diabetes is there, this oral health, and you should refer back to us so that we can have a look in the initial stages also. Normally people don't revert back, they consider it normal, and if you examine the oral cavity, just even by seeing, you can see there is a asymmetry in the gingiva. So it is then, and the deposits are present. So it is then you can, yes. If the patient is a clinical health, because the teeth are already mobile.
Very nice presentation. Just one question. Like we see a lot of fungal infections, oral fungal infections in diabetic. So do they also have some role in periodontal disease?
Yes. Sometimes the main fungal infection that has been seen in the diabetics is oral candidiasis. And various studies have also, advocated that there is an increase in the Candida albicans in the subgingival plaque. Rather, studies are still going on. No confirmatory evidence has been taken. But yes, if we tend to culture Candida in the subgingival plaque, there is a possibility patient is suffering from diabetes and is unaware.
Flossing, regular flossing. So is it advisable for all the patients, or there is some
it is advisable. It is advisable, but in a proper manner, because excessive flossing will definitely lead to gingival recession. Thank you. Excessive brushing of teeth is not at all advised, because it will cause cervical abrasion, and ultimately teeth will be abraded and worn off.
One point for flossing, when you said, actually as a routine we should do before going to bed, because whatever we are eating gets stuck inside. That should be done. One more, that's a clear question. Another question came to my mind. Hyperplasia of the gums. Generally, which is iatrogenic, we as physician prescribe some drug. Most common are the calcium channel blocker. How you differentiate clinically from the periodontitis and gum hyperplasia induced by the drugs? Clinically.
Yes, the gingival enlargement that is mainly medication induced may not necessarily have accumulation of dental plaque. So if especially calcium channel blockers, the most commonly nifedipine, that causes gingival enlargement. So the patient will present with a gingival enlargement. We do take the history because the enlargement in a non-idiopathic state has accumulation of dental plaque. But here we do not have accumulation of dental plaque and there is an enlargement. So in order to rule out, a medical history is required, and the main clinical feature, the highlight is that there is no dental plaque or less dental plaque, which is enough to cause inflammation of the gingiva.
It's a good topic. Thank you, Garima.
Thank you.
And I would invite Dr. Gautam for next talk. His topic is metformin, the extra glycemic benefit. And he's ex-registrar, MAMC, New Delhi, and now he's a professor of medicine in GSVM Medical College, Kanpur.
Good morning, everyone. Thank you, Chairperson, for your kind introduction. And at the outset, I'd like to thank the organizer for giving me opportunity to speak on this topic. Especially thankful to Dr. Anupam Prakash sir inviting me here for deliver a talk. So the next 15 or 20 minutes, I'll be talking about the old molecule, and it's a gold molecule also, about the metformin. So metformin, the extra glycemic benefit. As we all know, that metformin we are using since last 60 to 65 years as a hypoglycemic agents. But if you see the other properties of the metformin, so there are a lot of indication of using the metformin apart from the diabetes mellitus. It has a role in the anti-cancer, as an anti-cancerous. It has a anti-aging role also. It has a anti-inflammatory role. It has a antibiotic property also. Even it has an anti-tubercular property also. So let's see one by one extra glycemic benefit. So here is the metformin. Metformin is always being in the front, leading like a troop in the front line, a soldier troop in the front line. So metformin is also be a frontline warriors in the management of diabetes mellitus. So if you talk about the guidelines, different guidelines like American Diabetic Associations, EASD, NHS, Indian Diabetic Federations, Canadian guidelines, and even the guidelines of American College of Physicians, they all say this still the metformin is the first line of treatment in the management of diabetes. So these are the newer mechanism of action which we can use. We can use the metformin apart from lowering the blood sugar levels. So metformin in the women health like GDM and polycystic ovarian diseases, metformin in the metabolic disorder like non-alcoholic fatty lipidemias, metformin in cardiorenal aspectal cancer, endometrial cancer, GI cancer, pancreatic cancers, and metformin in the aging related comorbidities, and of course metformin role in tuberculosis also. So we'll take one by one in the short. So metformin in the women health, like gestational diabetes mellitus, we are using the insulin, but metformin still have a, the studies shows the metformin has a comparable efficacy with the insulins that reduces the miscarriage, this decreases the neonatal hypoglycemia in spite of decreasing the weight of the pregnant females. So here we have a certain advantage of metformin over the insulin. And if you talk about the polycystic ovarian diseases, it is metformin is having the mild anti-androgenic effect reduce the risk of miscarriage, second line ovulation induction agents, decreases the ovulation hyperstimulation syndrome in intra vitro fertilization. So metformin act at each stages in the polycystic ovarian syndrome. If patient pregnant female having GDM and along with having polycystic ovarian syndromes, so metformin is always on the first line treatment. So PCOS with the menstrual irregularities, improve the menstrual irregularities and hirsutism, and anovulatory PCOS again improve the ovulation and increase the pregnancy rates. PCOS with the who is undergoing the IVF that prevent the ovarian hyperstimulation syndrome, increases in live birth rate. Pregnancy with PCOS again significantly reduces the miscarriage rate, reduce the risk of gestational diabetes mellitus, and in metabolic syndrome with PCOS, metformin improves the dysglycemia and other metabolic dysfunctions also. So studies was conducted by Avdesh Kumar Singh. Again, the several randomized controlled triad meta-analysis and observational studies have largely supported the outcome with the metformin. Use of metformin acceptability is the important factor in the patient. Significantly less maternal weight gain and less maternal hypoglycemia is there, as evident in these studies. Moreover, 2-year follow-up also shows the offspring reassures to no anticipated harm, and in fact suggested a beneficial effect in the offspring also. Now talk about the use of metformin in obesity. So feature of obesity, as we all know, hyperleptinemia and leptin resistance. So leptin associated with fat mass and regulate the food intake and energy consumption process. So hyperleptinemia is harmful to the body tissue. So how does it act to overcome the leptin resistance? Metformin may enhance the leptin sensitivity, it reduces the leptin secretions, and as a result decrease the expression of the neuropeptides during the causing hungers and increased feeling of satiety, and leading to the appetite suppression and decreased food intake. Another aspect of obesity, having the insulin resistance. Metformin again an important role to decrease the insulin resistance. There is a relationship between the increased insulin sensitivity and decrease the liver volume in a patient who are on metformin therapy. So mechanism of how does metformin work in insulin resistance? It effectively controls the blood sugar level and improving the insulin sensitivity, and metformin induced a significant decrease in the total LDL cholesterol levels, and this decrease in the total and LDL cholesterol level is again related to the weight loss. So again, this study, diabetes prevention program study, in which says 29% of the subject metformin group have lost greater than 5% of their normal body weight in 1 year, while subjects in the metformin arm experienced a mean weight loss of 2.1 kg, reduced their incidence of developing diabetes around 31%. If they reduce the weight around 2.1 kg, and they reduce the developing the chances of diabetes to 31%. Again, this study shows metformin was found to be safe and well tolerated, and also produced a highly significant and durable weight loss over the duration of follow-up. Mean weight loss from the baseline in the metformin group was 2%, and those subjects who were highly adherent to the metformin lost 3.5% from the baseline also. So next we'll talk about the dyslipidemias. So role of metformin in lipid lowering agent. So counter the derangement in the lipid metabolism in type 2 diabetes through several pathways. Need not to discuss in the detail of about these pathways. So it just increases the insulin sensitivity, reduces the rate of lipolysis, and slow the conversion of free fatty acid into the lipoprotein precursors in the liver. So improve the dyslipidemia by reducing the weight loss in people with the impaired glucose metabolism. Again, the studies shows about the dyslipidemia associated with the poor glycemic control in type 2 diabetes mellitus. So increase in the triglyceride level in the type 2 diabetes is accompanied by pro-atherosclerotic functional changes in the HDL and LDL particle. So the result was metformin affect a reduction in the LDL cholesterol as well as the triglyceride level in the blood, and hence could be protective against the effect of dyslipidemias. Now, next is the non-alcoholic fatty liver disease. Role of metformin in non-alcoholic fatty liver disease. Again, the metformin reduces the blood sugar and improves the insulin sensitivity, including the decreased gluconeogenesis in the liver, increased glucose uptake in the periphery, and of course, increase the fatty acid oxidation. So, metformin promotes the weight loss, lipid parameter benefits, and long-term source safety and tolerability of the metformin. This is again one of the study in which they make the forearm. They have given metformin, pioglitazone, statins, and the hepatoprotective agents like silymarin and vitamin A. They found the metformin could be a beneficial role in the patient with NFLD, improving the liver biochemistry and metabolic syndrome feature. So it can be safe in mild liver diseases. Cardioprotective, again, metformin has a lot of role in the cardioprotection also. If we talk about the myocardial infarction, several mechanisms are there to cardiovascular protections like endothelial dysfunction in MI and myocardial label decreases the apoptosis, helpful in the MI. If you talk about the cardiohypertrophy, cardiac hypertrophy again decreases the protein synthesis, decreases the transcriptions, and heart failure improves by decreasing the endothelial dysfunctions, and cardiomyopathy also decreasing the endothelial dysfunctions, decreasing the apoptosis, increasing the autophagy, and other, again, increases the insulin sensitivity. So these are the cardioprotective effect of the metformin. Metformin also exhibit antithrombotic properties, reduction in the platelet aggregation in the patient with insulin-dependent diabetes, and affect the cardiomyocyte function, and has been associated with improvement in the diabetic cardiomyopathy also, and having the extra cardioprotective effect against the ischemia perfusion injury following MI. These are the, again, one study, a systemic review of the 17 observational study. They found that the metformin associated with reduced all-cause mortality in type 2 diabetes mellitus patient, whether it is of CKD, CHF, CLD with hepatic impairment, their mortality was decreased with the using metformin. Heart failure and diabetes. So again, the patient with the pre-diabetic or diabetic are at increased risk of developing the heart failure. So patient with the diabetes have a greater risk of heart failure with a reduced ejection fraction heart failure or a preserved ejection fraction heart failure. So conversely, heart failure increases the risk of diabetes also. So first line in the treatment of the heart failure should be include the metformin, and again the SGLT2 inhibitor also. So talk about the CKD, kidney diseases. Previously we were thought, oh, metformin is contraindicated in kidney disease, we should not use the, but a lot of studies were there which shows it's not contraindicated until unless the eGFR is less than 30. So if it is more than 60, we can use no contraindicated, monitor renal function annually, but it is if less than 60 to 45, then we can use, but we have to monitor the renal function 2 to 3 monthly. But if it is less than 45 and more than 30, use with a cautious. And 2 to 3 monthly, obviously, you should monitor the renal function. And less than 30, we should not use. So another interesting article I found in literature, the role of metformin in tuberculosis. So it is having antibacterial effect, antimicrobacterium tubercular effect. So metformin has attracted attention as a host-directed therapy. Host-directed therapy means it enhances the immune system of the body, it decreases the inflammatory markers, decreases the inflammation in the lung, and decreases the Mycobacter tubercular viral bacterial loads also. So this effect include the augmenting macrophages effector, reducing the inflammation and preventing the lung damage. All the studies in metformin source promote macrophages autophagy affected by AMPK activation, reduction in the mitochondrial reactive oxygens, and inhibition of the mycobacterium growth. Another study by Singhal et al. Demonstrate that the AMPK activation by metformin inhibit the mycobacterium tubercular growth, and also shows in the mice that treated INH with the metformin had decreased bacillary load in the lung as compared to the INH alone. So again, a study which favors the use of metformin that increases the efficacy of the drugs, other drugs with first-line ATTs. Now come to the cancer therapy. Role of metformin in the cancers. A lot of cancers have the role of metformin as an anti-cancer property. Like when we take metformin, it's absorbed, it goes in the portal circulation, in the systemic circulation. In portal circulation, the hepatocyte decreases the oxyphosphorylation and energetic stress that lead to decrease in gluconeogenesis, decrease hyperglycemia, decrease hyperinsulinemia, and decrease the proliferation of the insulin responsive cancer cells. And cancer cells again decrease the oxyphosphorylation and antineoplastic action that vary with the genetic characteristic of the cancer, such as LKB1 status, complex 1 mutation, and with co-treatment such as oncogenic kinase inhibitor also. So these are the mechanisms used in metformin may influence the cancer biology. Again, a lot of studies were there which shows clearly the evidence in the role of metformin in the different type of cancers. Meta-analysis of 6 cases studies exhibit a lower risk of developing lung cancer if patient is on the metformin therapy. Another meta-analysis shows the reduction in the incidence of prostate cancer in patients who were on metformin treatment. And meta-analysis 35 observational study reported a considerable correlation with using metformin to reduce the risk of developing the all cancer like liver cancer, GI cancer, colorectal cancer, gastric cancer, esophageal cancers. And the last is aging. The role of metformin in aging. This study shows the differential effect of the metformin on age-related comorbidities in older men with type 2 diabetes. So metformin shows age-related comorbidities development in old men with the type 2 diabetes. This is the most recent article talk about the beneficial effect of the wonder drug metformin against the many other age-related comorbidities such as obesity, metabolic syndrome, cardiovascular disease, cancer, even in the cognitive decline, mortality. So these are the proposed mechanism of as anti-aging property. Metformin has the microbiome modification, enhanced insulin sensitivity, reduction in the hyperglycemia, emulation in the liver. A lot of mechanisms are there to enhance the proper anti-aging property of the metformin. Enhance the mitochondrial biogenesis, autophagy. So these are the function which. So just to conclude my talk here, so over last 65 years we are using metformin. So there are a lot of indication now we can use the metformin other than the diabetes also, like PCOS, cancer, aging, inflammation, diabetes, NAFLD, even diabetes, pregnancy, PCOS, and in tuberculosis also. So here I stop my talk. So thank you for the patience hearing.
Any question from audience?
Preferably give only insulin, don't give metformin.
There are a lot of studies are there, which, they favor the metformin over insulin also because number one, it decreases in PC, especially I'm talking about the PCOS, it decreasing the weight loss, weight, and it having the increases the insulin sensitivity also. And the one thing which people are having some fear about using metformin, it causes the stillbirth and it just decreases the gestational age also. But these are not very much significant if you see the lot of randomized control studies in which they advocate the use of metformin sensitivity and efficacy is as far as with the insulin therapy. So, and sometimes patients are apprehensive also to accept the insulin. In that case also, metformin is doing very well.
Neither is given that really consent of patient, that legal aspect, why it should be.
That's why I said it's my last line, sir.
When we know it is safe, PCOS can go through it.
Yeah.
And patients, you just watch our scenario. well-to-do people can afford the hygienic situation.
Yes.
What about poor people? Where can they afford to take injection and take the aseptic precautions?
Obviously, this is
So that
again.
I thought it should be given with impunity unless there are real contraindications.
Obviously, sir, this molecule is again good for the patient who are not affording and having apprehension. Even they don't have the refrigerator and all this to keep in insulin, then that set of patient, again, the metformin is good for them.
You've done a very nice review of metformin with its various
Thank you,
effects. Recently, I'd read an article that metformin used in men.
Using?
Men. If the husband is using metformin, the male child has a higher likelihood to get genitourinary abnormalities. And there's been a fairly big meta-analysis which showed that a higher incidence was found. So I just wondered if anybody else has any views on that.
In my clinical experience, I don't find any such
We are using small,
obviously,
fewer
the study,
people.
as you're saying, ma'am,
But
study was
which I was also surprised, it's in the last, I think, February journal.
maybe there, but I don't think we're using the metformin as a molecule for the last 65.
Not the gestational mother, but in the husband, the beta gets the high incidence of genitourinary abnormalities. So,
okay, that I'm not aware of why the having the
and
effect
why
on.
it should happen, because maybe it does go into the molecular level. And of course, that aging is very interesting because there's a study going on in UK on 20,000 people where they are using it and studying their cognitive effect.
Obviously,
So
ma'am,
that's a
cognitive
good,
decline is a very much common in
Very
the
much
old
common.
ages. So
So
metformin has a
it's being
property
used.
to
Even
decrease
non-diabetics, they are using it.
Obviously, ma'am, even non-diabetic. That in PCOS
That
also
was,
in
yes.
non-diabetic patient we are using
or
the metformin. There are
pre-diabetic.
a lot of indication in which using the metformin in the non-diabetic patients
Yes,
also.
yes.
So there is a role.
So it's very good drug.
Thank you.
Sir, can you elaborate the timing of metformin intake in view of postprandial hyperglycemia? For example, half an hour, 1 hour, if we take half an hour before, it will better reduce the postprandial, or at the time of meal, or just after the meal. What is the best time to take it?
So according to the guidelines, it is the best time is just take 30 minutes before the meals. So sometimes with the metformin, some patient develop the some gastric upset also. In that cases, I will recommend with the food also. But the ideal recommendation is.
Normally, this has got dominant effect on the fasting. But if you are very keen in that, then you take the plain metformin, not take the sustained release.
Yes, sir.
Because sustained release has got different effect and take longer time. For postprandial plain metformin is
It's
ideal.
better than at least you should use the 3 times metformin.
Drugs.
Rather than using the sustained one, you can use the 500 3 times a day or increase the dose.
Okay, thank you, Dr. Gautam, for that enlightening talk on this wonder drug. Now I invite
thank you.
our next speaker, Dr. Nirupam Prakash. He's a consultant physician working in CGHS Lucknow. And he is almost the hub of diabetes to learn from Dr. Nirupam. Over
Thank
to
you. Thanks for the kind introduction. And I move on to my topic, which is COVID and diabetes. A lot of people here in the audience would think that it is perhaps not the right time to discuss about diabetes and COVID now, being the spate already over. But I would say that COVID is yet not gone. It is such an unpredictable disease, and we are still having surges of COVID-19. And definitely, if it was over, we wouldn't see them. Moreover, this interim period has given us time to learn and re-strategize to fight other illnesses and perhaps other surges like this. So definitely it is much more relevant to discuss diabetes and COVID-19. And the outline of my presentation would be first to discuss the epidemiological link between diabetes and COVID-19, the pathogenic link which exists between these two diseases, what the general practice measures should be for treating diabetes and COVID, and who are the high-risk groups of type 2 diabetes patients who are at risk of developing COVID complications, how to ensure a good glycemic control in patients with COVID and diabetes, and later monitoring and follow-up. So moving on further with my talk, the first and foremost question anyone would ask is, are diabetics prone to get COVID-19 more, or is there any evidence in this regard? I would say that diabetes mellitus is definitely a major comorbidity in most of ailments, and especially as we consider COVID-19. And while the pooled prevalence of diabetes and COVID-19 is not greater than that in the general population, so that goes on to deny the high incidence of COVID-19 in type 2 diabetics, but definitely there is evidence to prove that the diabetics have more severe and prolonged illness and worse outcomes with COVID-19. So diabetics are not prone, but they are prone to severe disease and complications of COVID-19. So they are especially the group which needs to be controlled and looked for. When I talk about severe COVID-19, what are the things I would like you to pay attention is that the greater severity of COVID-19 means that they'll have more incidence of high-grade fever, fatigue, cough, dyspnea. So this is something which they'll present with, and there would be high incidence of biomarkers of inflammation, whether it be CRP, IL-6 levels, D-dimer levels, or coagulation marker levels. So this is something which would also entail the complications which might arise in patients with diabetics and COVID-19. Furthermore, they'll need more of ICU admissions, more of oxygen supplementation, and the frequency of comorbidities like the cardiovascular comorbidities, renal comorbidities are more in patients who are diabetics and having COVID-19. So this is a double conspiracy between COVID-19 of new onset diabetes, increased hyperglycemic complications in the form of diabetic ketoacidosis, and that goes on to show that perhaps patients with COVID-19 are at more risk of having hyperglycemia. And if we were to see how fasting plasma blood glucose would translate into as a predictor of mortality and worse outcomes in patients with COVID and diabetes. So if we were to see the blood sugar levels, so if we were to see the blood sugar levels, the fasting plasma glucose, in case it is more than 126 milligrams per deciliter, the risk of worse outcomes of mortality is increased to 4. The odds ratio is nearly 3.99. If the fasting plasma glucose is below 126 milligrams per deciliter in the range of 110 to 125, the odds ratio of a worse outcome or a mortality is to the tune of 2.61. So that gives us the increased risk, the ratio of bad predictors of mortality in patients with uncontrolled glycemia and diabetes and COVID. To talk about what are the benefits of a good control, patients who are hospitalized with COVID-19 and are diabetics, if we have their glucose levels within the range of 70 to 180 milligrams per deciliter, the mortality is reduced 10 times. So it is 1/10 what a patient with uncontrolled glycemia would encounter in comparison to patients who are euglycemic or perhaps better controlled. Considering that India has a huge burden of diabetes, of which half of them are until now yet undiagnosed, the implications would translate out to be huge. Talking about the pathogenesis, I would just like you to recapitulate that COVID-19 works on the ACE2 receptors. I believe this marker would work. Yeah. So the COVID-19 works on the ACE present on the pneumocytes, and thereby it causes pneumocyte 2 damage and produces ARDS, systemic inflammation, and multi-organ dysfunction. Apart from this, ACE receptors ACE2 receptors are present on the kidneys, the cardiomyocytes, thereby increasing the risk. It also affects the immune effector cells. It causes an increased proliferation of neutrophils, but this proliferation of neutrophils is not beneficial because these are dysfunctional neutrophils. They have less amounts of granules. There's impaired chemotaxis amongst these neutrophils, so they are not beneficial. And apart from this, there is an increase in the CD4 helper cells, which further are pro-inflammatory and release a lot of cytokines. Furthermore, the macrophages also convert into SARS-2 virus, these ACE2 organ dysfunction syndrome. Furthermore, hyperglycemia, as we all know, is known to inhibit neutrophil chemotaxis, inhibit granular release, and also augment pro-inflammatory macrophages, which serves as a background for COVID-19 virus to launch an attack on the humans. Talking about COVID-19 and how it augments the ACE2 receptor, it leads on to utilization of this ACE2 receptors in its pathogenesis, thereby removing the ACE2 receptors. But ACE2 receptors are known to convert angiotensin 2 into angiotensin 1. Angiotensin 1 to 7 is also known to increase the expression of GLUT4 receptors on the pancreatic cells as well as other tissues, so it improves insulin sensitivity. So removing ACE2 receptors from the body or utilization would decrease angiotensin 1 to 7 levels, thereby causing a deterioration in insulin secretion and also increase in insulin resistance. Furthermore, because angiotensin 2 is not broken down into angiotensin 1, there is an increase in angiotensin 2 levels, which would lead on to pro-inflammatory oxidative damage and increased coagulopathy and endothelial damage. So apart from this coexistence and co-complementing of COVID-19 these patients, talking about now coming on to what the general practice measures should be amongst diabetics, because diabetic patients find it difficult to contact the physicians or their treating physicians or healthcare givers during the COVID times. It is essential that they inculcate a habit of exercising regularly, follow a religious regular meals, which as per the diabetic diet and instructions given to them, it should be balanced as far as quantity of fibers and proteins is concerned. And further, it is very important to take their pills regularly. They should keep a stock, and a supply of medicines should be ensured, whether it be with the help of healthcare providers. And apart from this, self-monitoring of blood glucose and BP monitoring should be emphasized. They should follow a daily routine of observing their own feet, because feet are the most neglected part of the body and very much affected in patients with diabetics. And they should have a knowledge about warning symptoms and emergency situations and whom to contact. So this is what a layman or a diabetic patient and his accompanying person should know about for treating properly diabetes in COVID times. Talking about what a doctor or health care provider should do for the betterment of diabetic patients, definitely they should provide a holistic advice as far as diabetes management and comorbidity management is concerned, but they should also prepare the individual for management of intercurrent illnesses. They should be talking about avoiding infections, avoiding trauma, avoiding fall, which would need an emergency treatment. So this is what a healthcare provider should look out and perhaps prevent in patients with diabetes. Talking about treatment measures which a healthcare provider should provide, first and foremost, he should try to use drugs which do not cause side effects in the form of hypoglycemia. So pills which do not increase the risk of hypoglycemia should be provided to the patients. Furthermore, he should be instructed to properly and periodically assess his glycemic and blood pressure controls. This is the perhaps best time to emphasize the need for vaccination, apart from not only COVID, but other vaccination like influenza and pneumococcal vaccination. And we should always remember that every COVID patient with diabetes does not need a hospital admission. So mild COVID patients can be managed at home with isolation, and we should try to stratify the risk of every diabetic based on the presence of whether he's a type 1 diabetic or he's insulin receiving type 2 diabetic, any diabetic with age more than 65, or who smoke or have multiple comorbidities or have unstable HbA1c, they can be classified as high-risk diabetic patients. Coming on to the management, first and foremost, every COVID patient should be screened for glycemic control or glycemic status, because COVID patients are at risk of new onset diabetes, not only because of increased inflammation, stress hyperglycemia, but also because many of them are undiagnosed and first time come to a hospital because of COVID-19, and they should be screened because of the worst prognosis associated with hyperglycemia. So basic fasting and random and postprandial and glycosylated hemoglobin should be done. Coming on to patients who merit a oral drug therapy of diabetes, patients who have mild COVID illness and have somebody who can manage them at home or look after them should be managed at home with oral therapies, and mild degree of hypoglycemia, they can be very well managed at home. Amongst the drugs which can be given to a patient, especially DPP-4 inhibitors and metformin and are probably the safer drugs. SGLT2 inhibitors, because they run a risk of dehydration and euglycemic ketoacidosis, should be watched for. Similarly, pioglitazone also carries a risk of fluid retention and perhaps should be avoided. Coming on to insulin therapy, the ideal drug for management of COVID-19 would be an insulin, because these patients might suddenly deteriorate and require use of steroids. So herein, basal bolus regime is the ideal drug, but individuals should be put on IV infusion whenever they have unstable glycemic or have hypoglycemic emergencies or have sepsis. Patients who are to be put on steroids, if they are to be put on single dose steroids once in a day, perhaps a single dose of NPH once in the day, or a postprandial for short-acting insulins for postprandial control would be sufficient. But in case the patient has to be given twice a day steroid therapy, perhaps the basal bolus would be the ideal drug. While discharging any patient, we should remember that patients who were on oral glucose lowering drugs can be safely prescribed and discharged on the same medicines. Rest, it depends on for those who are receiving insulins, in case their insulin dosage was less than 0.5 units per kg per day, they can be safely transferred to oral agents like DPP-4 inhibitors, metformins, or cardio-safe sulfonylureas. On the other hand, those patients who have high dose insulins being given to them, they have to be discharged on basal bolus or twice daily NPH dosage. Defervescence and follow-up, these patients need to be strictly monitored after discharge, because they run the risk of developing long-term diabetes and other metabolic complications. Apart from that, they have high risk of cardiometabolic diseases and may have arrhythmias or cardiac failure, so they should be strictly watched for and followed up in the OPD. Coming to my summary slide, the take-home points are that diabetes definitely is a risk for severe COVID illness and should be managed carefully, especially because not only there is an increased expression of ACE2 receptors, there is a dysregulated immune response and endothelial dysfunction. Apart from that, the chronic conditions like obesity, CVD and CKD further augment the damage of COVID-19. Hyperglycemia at diagnosis portends a worse prognosis, and it should be strictly controlled in patients with diabetes and COVID. And insulin should be initiated as an ideal drug for management of patients who are hospitalized. The safe drugs would be DPP-4 inhibitors, and the drugs which need to be used with caution would be SGLT2 inhibitors and glitazones. A comprehensive preventive measures and medical care and follow-up should be followed in pre and post-COVID states, and definitely all these patients merit a long-term follow-up. With that, I end my talk. Thank you.
Thank you, Dr. Nirupam, for that comprehensive talk on COVID and diabetes. I now invite any audience, if they have any questions.
Compared to the
All complications or severe complications of COVID-19 are more in patients with diabetes. So I would say not only thromboembolic, but ARDS, need for ICU admissions, all are more in patients with diabetes and COVID-19. So they have a higher risk, they should be watched for and strictly monitored for all inflammatory parameters.
I think, ma'am, your question was very valid. There are a lot of thromboembolic complications being seen nowadays, especially in diabetics and if they've had COVID. In fact, I don't think any of us would have been exempt from COVID. I don't know. We've all gone through it, either symptomatically or asymptomatically, and especially people who have comorbidities, there is a dangerous trend. Although the COVID mutation right now is not so dangerous as it was in the Delta times, but I think the after effects are continuing and we should be careful.
Thromboembolic episodes. Should we give prophylaxis for it in a COVID patient?
If the patient is hospitalized, in that case, he has a moderate COVID, and that entails that every patient should be not thromboembolized, but he should be on prophylactic low molecular weight heparins. So any patient who is hospitalized would have moderate COVID-19 and would merit a low molecular weight heparin.
Secondly, in any acute infection, we will prefer patient to be on insulin.
Proven post-COVID. And also not only type 1 diabetes, there are other autoimmune signals which were increased, like there were few documented case of Graves' disease. There was documented thyroid function which was normal 1 month prior to that, and then just after COVID infection they had Graves' disease, full-blown Graves' disease when there is orbitopathy. So like it not only happens with COVID, with other viral infection also there might be aggravation of the
increase in the function, as he said, toxicity has been more often because of the subacute thyroiditis. So if you do a technetium scan, you find nothing over here. While in Graves, it should be a hot spot. So more often which has been seen, because few of the cases which I have seen, there was no TSH receptor antibodies. I can't say that it was done in not many, but TSH receptor antibody was not there. So it is most often thyroiditis.
So I thank all the speakers.
There are people who want to refute on it and won't go with it. So
You're right. The last word is not yet said, actually. It will continue.
that's why COVID is still unpredictable. Nobody knows.
Thank you all the speakers for their wonderful presentations, and the topics were very relevant. We had good discussion and interaction from the audience.
At Atal Bihari Vajpayee Institute of Medical Science and RMR Hospital, New Delhi. So I request the chairperson to invite a speaker and start the session, please.
Insulin delivery system is there, an algorithm to link blood glucose level with insulin delivery is there. Here we can see this electronic controller is there, sensor is required, pump is there, and then the insulin is delivered to the tissue. Here we have insulin pump, that is external and implantable device, which was earlier can provide better comfort for patient since it is fit in well and no infection at site catheter junction is there, and can be used generally as implantable drug infusion devices even for other than insulin. Advantages are it is safe and effective, refills are practical and safe, improved metabolic control, hypoglycemia can be lessened, and limitations are catheter and insulin are vulnerable point, and batteries that require the power can be limited in that. There are open and closed loop system devices. These are newer ones. So open loop system include glucose sensor. Doctor or the user decide to the amount and time of insulin that will be given. A manual control is applied. User needs to know about insulin dosing, when and how much is to be given. Insulin is infused of mealtime bolus insulin requires data entry or a series of calculation before delivery of an appropriate dose can occur. Pump can accurately deliver small increments of insulin compared to an injection. Electronic control permits shaping of bolus over time to match the insulin profile required for a given situation. Pump controlled manually by the blood glucose level and an estimate of a gram of carbohydrate that has been consumed by the patient. Once the bolus has been calculated and delivered, the pump continues to deliver its basal rate insulin in the manner that has been programmed in the pump control based on the predicted insulin requirement of the user. As we can see in the graph also, that bolus dose is given in breakfast, lunch, supper, and maybe in bedtime, and the basal rate is continued to be delivered by the system. How to do bolus calculation? So insulin to carbohydrate ratio is multiplied by gram of carbohydrate. Number of gram of carbohydrate is estimated by measuring food. Bolus calculator device are available to ease out the bolus calculation. The user enters the gram of carbohydrate to be consumed and the device calculates the number of unit of insulin needed. It adjusts for the most recent blood glucose levels and the insulin on board, and then suggests the best insulin dose to be used to approve an bolus. This is a picture of artificial pancreas where the patient, this sensor is attached to the patient and the readings are sent to the controller device, and then according to that the insulin dose is adjusted and it is delivered through the pump. Coming to the closed loop system, it is a computer control. There it was manually controlled, here it is computer controlled. The amount of insulin delivered by a portable insulin infusion pump on the basis of reading obtained by glucose sensor so as to keep the patient's glucose at the near normal level all the time. The computer calculates the required insulin dose using a feedback algorithm. The computer system must be able to sample, filter and interpret the glucose sensor data, compare the reading with allowable normals and accurately order just enough insulin to maintain normoglycemia. Must operate correctly all the time because error could lead to severe hypo or hyperglycemia. Closed loop system are made up of three parts: a insulin pump, a continuous glucose monitor and an algorithm. A continuous subcutaneous insulin infusion pump is a digital device that delivers a steady stream of insulin under the skin through the day and night. A continuous glucose monitor is a device in skin that automatically checks the glucose level every few minutes, 24 hours a day, and it uses a wireless transmitter to send reading to a device. The control algorithm is intelligent technology either embedded in the pump or on a control unit like a smartphone. It communicates with the CGM and the pump and allow them to work together to manage your diabetes. How does it work? So a sensor under the skin is automatically measures the blood glucose level. Readings are sent wirelessly to the pump which calculates the amount of insulin required, and user can monitor reading on a smartphone which also allows them to input the amount of carbohydrate being eaten at the meals. Here also we can see the picture of artificial pancreas where the sensor is attached to the body and the readings is taken and insulin pump delivers the insulin which is required by the body. So closed loop system is fully automated glucose monitoring and insulin delivery system. No user acknowledgement for insulin using and adjustment is required. However, open loop system is a semi-automated system where requires the acknowledgement prior to the insulin. Dangerous hypoglycemia. It reduces the work and stress because managing diabetes take time and work and concentration of the patient as well as the physician. Lifestyle flexibility. It improves the quality of life of the patient. It improves the well-being. Challenges that are faced in closed loop system device. The primary barrier is the development of long-term reliable blood glucose sensor. Glucose sensor reading will include random error and will drift over time. The computer must be able to decide whether to accept or ignore an extreme sensor reading. This is important because the sensor reading is used not only to determine the amount of insulin infused, but to continuously recalibrate the basic equation establishing how much insulin is required to reduce blood glucose by the given amount. Insulin dose response relationship varies by body weight and metabolic function and must be constantly recomputed using the latest sensor data. Computer must also recognize the sensor malfunction because that can also lead to hyper or hyperglycemia. There are dual hormone artificial pancreas also available. Single benefit with the dual hormone artificial pancreas for reducing the risk of hypoglycemia event overall and during a specific situation like exercise overnight and during the prandial period. Difference between pancreatic insulin and the insulin replacement by artificial pancreas. This improves the quality of life of the patient as well. Thank you very much.
Thank you, Dr. Subbalakshmi. You have given a very lucid and informative talk on artificial pancreas. It's a need of time. What I have imbibed, it's a upgraded form of the insulin pump.
Yes.
So I just want to know, because we are living in a constrained and resource limited country. So how this facility is available in our country? What is the cost? What is the cost of maintenance?
Actually, this artificial pancreas is about, it costs about 5 to 6 lakhs and every, this 10,000 to 20,000 per month also is requirement for refill and everything. So it is a
20,000 per month?
Yes. So it is a costly affair for our patients and it is available on few institutes where patients are using, but the number of patients which are using is less.
Okay. And what is the current status of dual hormone artificial pancreas in our country? Is it available?
This artificial pancreas is available, but dual hormone I am not aware of.
Excuse me, I am here.
Yeah.
I just want to know what is the, how does it fare in patient develops DKA? We'll have to remove it, we have to switch over on conventional insulin therapy, or it will continue with that?
Sir, it is mainly used for chronic diabetes where we need to titre this.
I just have one question. Suppose there's a glitch in the algorithm. It's a computer control program. So we know that sometimes we have technical glitches. So what are the checks and balances in place for that?
So
because as what I understand is the patient cannot control how much insulin is going to be delivered. So suppose there's a glitch, a technical glitch, then what happens?
So that's why this newer devices are like, they can sense the glitches also. But if at all it is not, then patients should be educated. They should be aware of hypoglycemic events, whatever the symptomatology they can understand. So they should be made aware of that. That is the main thing. Patients should be educated and they should be made aware of the symptoms.
So they still have monogenic diabetes, which is the topic for today. Over to you, Dr. Pandey.
Thank you, ma'am. And it's indeed a privilege to come back to my alma mater. I did my MD medicine from this place, and I thank Anupam sir to invite me as a faculty, and I'm thankful to Jayan sir, who was my internal examiner during my MD examination. And I was fortunate to have sir as the examiner because it helped me. I chose my thesis topic during the MD exam, during the MD was endocrinopathies in transfusion-dependent thalassemia. And then I thought either I will take endocrinology or hematology. So I'll be presenting my talk about monogenic diabetes. It's a diabetes which is a clinical heterogeneous group of disorder characterized by non-ketotic, word non-ketotic is very important, diabetes mellitus, an autosomal dominant mode of inheritance most of the time, and onset which is usually before 25 years of age, and primary defect is usually the function of beta cell. So this was the definition originally given by Fajan, who is considered to be the father of monogenic diabetes. He was a PhD student then, and his teacher Tata Stahl, they first recognized this condition MODY. It was a misnomer. Why it was a misnomer? Behaving like maturity onset, wherein they were not requiring insulin, they were responding to oral agents. This case I had presented in European Association of Study of Diabetes in Lisbon. Dr. Rajiv Gupta sir was present there. We were there together. And so this is a 37-year businessman. He's having diabetes for last 19 years. So he had developed diabetes when he was of 18, 19 years. And his blood sugar was 156 and 280. He was currently taking 4 OHAs. He was taking sitagliptin, metformin, canagliflozin, pioglitazone. And still, he was a exercise enthusiastic. He was lean. He used to run 1.5 hours on the treadmill, and he was worried, in spite of taking this 4 agent, why my sugars are not well controlled. So there was no other history of deafness, lipodystrophy, renal cyst, or pancreatic atrophy, no history of any complication of diabetes. And so this was his family tree. This was our patient, and in the parents also there was diabetes. Father had diabetes. What I want to emphasize here, many times patient can be casual. They might not give a detailed history at the diagnosis. He didn't, in the first visit he said the grandfather was not having diabetes. But once before my presentation, I gave him a call, and then it took around half an hour to make this family tree. And then what we found is that even there was an involvement of 4-generation individuals who were having diabetes. And we did the gene testing for the daughter, both the daughter. One of them, she came out to be positive. So important thing, if there is no acanthosis nigricans, one should think, can this be monogenic diabetes? So examination was absolutely normal. So we had a diagnosis of monogenic diabetes in our mind. And what we did, we stopped all the 4 agents and started this patient on 3 milligram of glimepiride. And he was a person who was living near to my clinic, and I said, please come to the follow-up to the clinic daily so that we can see what is the response. And fortunately, there was a good response to the therapy. His sugars were well controlled. His A1C came to, which was 9.2, came to 7.3. We sent the sample for genetic testing to Christian Medical College, Vellore, and what it came out to be positive for normal, likely pathogenic variant for HNF1 alpha, and this was confirmed by Sanger sequencing. The offspring, if we see, one of the offspring was carrier, and the carrier, she had a fasting which was normal, postprandial was raised. This typically happens in case of monogenic diabetes wherein pancreas is involved. The fasting will be normal, but the postprandials would be in the higher side. So because there is secretory defect in this patient. And there are other forms of monogenic diabetes wherein fasting would be abnormal, but the postprandial would be normal. So if suppose there is some discordance, that can also give us an idea that this could be monogenic diabetes. So this patient came out to be monogenic diabetes involving HNF gene. If you see the graph, one of the carriers, she was having impaired glucose tolerance, but the fasting sugar was normal. So we presented this paper in ESD, wherein Rajiv Gupta sir was present there along with us, and we had a good time there. And now, so this came out to be HNF1 MODY. And these individuals, they are extremely sensitive to sulfonylurea, and they'll respond to oral agents. So MODY type 1 and type 3, they will respond to sulfonylurea. Even if suppose we see patient who is having long-standing diabetes, 20, 30 years, and still not requiring insulin, probably this could be patients who would be having monogenic diabetes. So now coming to a case 3, this is an individual who is having diabetes for 17 years, 52 years of age is current. Again, I'll say many times patient would be casual. They'll say randomly, Doctor Sahab, 10-12 saal se, 15 saal se. But, and when the gene testing came out positive in this patient, when I asked, he said, Doctor Sahab, I had diabetes when I was 22. So he was having diabetes at very young age. So we should be carefully interpreting the duration of diabetes which patient might have. So he was actually having diabetes for last 30 years. His BMI was not very raised, 25. He was on premix insulin. His A1C was 8.6. This was his family tree, which was again an autosomal dominant pattern of inheritance was there. Many of the type 2 diabetes will also have autosomal dominant pattern of inheritance. But what's more important is lean, no acanthosis nigricans. One should consider there's no history of diabetes ketoacidosis. This one should think that this patient might have monogenic diabetes. So this patient was refusing insulin. I said there is a possibility if suppose we send the gene testing, it comes out to be positive for one of the monogenic diabetes, then probably there would be benefit. So this patient, till the time we were waiting for genetic test, we started him on regular and glargine and vildagliptin. And again, this came out to be a novel variant of HNF4 alpha. What's important in India, probably gene testing is done very less. That's why any monogenic diabetes which we do, it comes out to be a novel variant many a times. And seeing that this was a monogenic diabetes which could respond well to sulfonylurea, he was shifted on glycoside 90 mg, sitagliptin and metformin twice a day. Now again his fasting sugar was 124, 145 and A1C was 7.3, which was better than he be rewarding in such kind of patient wherein he was suffering with A1C of 8.6, 9, and now we have a better control. Diabetes, monogenic type 1, and there was no features of macro or microvascular complication. All the 3 daughters, they were having normal glucose tolerance, but the genetic testing was not done for them. He said he'll do it later. So our case was a novel variant of MODY type 1, and it's very important in our part of world wherein it is monogenic diabetes is diagnosed infrequently. We should keep it in a differential diagnosis even in older individuals. So this was an individual who was of 52 years and still we could diagnose this thing and give the prize for this. Now again, a new term which we have learned is this was a 69-year male, lean, 23 BMI, and L was 142 and A1C was 7.2. If we see the 14 genes. So there would be people who would satisfy the criteria of monogenic diabetes, but still they might have gene test negative, and one should keep in this mind. So the Tata Stahl was the first person and Fajan was the first person to talk about this. There are 14 genes which are affected. Onset is usually in childhood, adolescent and young adults. It has autosomal dominant inheritance. Primary defect is usually insulin secretion. Why one time GCK MODY, they won't require any treatment. And also, there is 50% genes currently which has shown to have monogenic diabetes positive. So to conclude, monogenic diabetes, it causes diabetes in around 1 to 5%. So there are lots of individuals who are in India, they're having monogenic diabetes. Many newer mutations are detected. Around 80% or even 90-95% they are misdiagnosed to either type 1 or type 2. Clinical feature and institution can help to diagnose monogenic diabetes. It can help in treatment, prognostication and genetic counseling. So we have a big list of monogenic diabetes, which around 15 mutation and 3 cases. There are few patients who are carrying dual mutation. And this is the list of the patients which we have. And except for GCK MODY, almost all kinds of MODYs are there. And GCK MODY it is more common in the Caucasians, not in our setting. But there are few case reports from the south. And we have sent this paper to European Society of Australia and New Zealand Society of Endocrinology, and we have acceptance of this paper. And we'll be presenting this paper about this case series on 14th November. So my acknowledgement to CMC Vellore, they were the person initially doing the gene testing, and also to my team. We have a team of few doctors who have also contributed to the cases, and my educator who have helped me to compile the data. Thank you for your patient listening.
Thank you, Dr. Pandey. It was very educative and talk. In fact, this concept has always been very confusing for the last so many years and decades. Many people, definitely, it's very difficult to diagnose whether they are treating their patient for type 1, type 2 or MODY. And you have made it very clear. Before I open the house for questioning, I have a question. Is there any serological marker short of, no, it can be diagnosed by genetic testing, but is there any serological markers by which we can diagnose this condition in our day-to-day practice?
So what's important is that if suppose there are lean individuals who have diabetes, there is no history of ketosis, no acanthosis nigricans, but I'll say there are few monogenic diabetes who have been reported to have ketoacidosis. So if these features are there, and if suppose we have diagnosed them as type 1 diabetes, and after 1 year or 2 years after this, the diagnosis, and if still the C-peptide is positive, then one should consider that this individual might have monogenic diabetes. Normally, C-peptide will become almost like zero or undetectable after 1 year. So the one marker which will help is C-peptide, but it depends upon patient to patient, and depends upon our conviction. Sometimes what I do, I have not shown the series. In some patient, what we do is we do the C-peptide antibodies, and then if that comes negative, then we go for the gene testing. In some patient, when the conviction is strong, why to waste the money on C-peptide and antibodies, directly go for the gene testing. So a single test is C-peptide, which will mostly help, and the antibodies. Okay. If they are negative, then one should consider.
You said that there is overlap of MODY and type 2 diabetes as well. So C-peptide will be present in both the cases?
Yes, sir. Yes, sir. So like I said, if we have diagnosed them as type 1 diabetes, in type 2 diabetes, then there would be a problem. C-peptide won't help.
Okay. Thank you very much. Do you have any questions? The house is open for discussion. If you have any question, Dr. Pandey is here. He is very educated and learned person to answer all your questions, queries.
I would like to make a couple of points. Yes, we're missing this. So this one point is well taken, as you said, 1 to 5%, maybe more. So if we don't know, we don't diagnose, and we think it is not there. So that should not be. So a lot of patients are there. Now, important point is, one is a 3-generational. So that is clinical history which we miss. Even if they don't agree, we can do simple blood glucose testing for the relatives. Yes. We may not, go. Generally, they are missed for type 1 rather than type 2. So generally, when they are, as misdiagnosed for type 1 on insulin, no features. So C-peptide, very rightly. I think, we are underutilizing C-peptide. In type 2, C-peptide would be high, except when flatbush diabetes. Otherwise, C-peptide are generally high. And in type 1, it is almost very, very negligible. And autoantibodies. So history, C-peptide and autoantibodies, I think, will clear everything.
Yes, sir. Yes, sir. Very well.
I'm just quoting your study. International group had assembled in 1989, where subsequently Dr. Das has read paper that what is the peculiarity of diabetes in tropics. They found they were more in the thin people, where they have ruled out only malnutrition and all. And they had taken BMI as 19 or below, but it is thin diabetic. And they're responsive to sulfonylurea. That time pioglitazone had not come. Pioglitazone, subsequently when we started thinking of acanthosin aggregans, if you are ruled out diabetes, the liberty was, as against the type 2 diabetes which is seen in obese, you find the lipid profile of thrombogenetic type.
Differential diagnosis should be FCPD, fibrocalcific pancreatic disease. This is more common in tropics, and this will happen in malnourished individual. One of the mechanisms they have proposed is protein deficiency, and one of the genes which they have proposed is PINK mutation. So these patients, they may initially respond to sulfonylurea. Later on, they will require insulin. So they could be monogenic diabetes and also FCPD. FCPD is, I think, more diagnosed in our setting as compared to monogenic diabetes. So these are the two possibilities I think of in that case, sir, which you are talking about.
Yeah, Dr. Pandey.
Yes, sir.
CMC Vellore, you said gene testing. Anywhere else it has been done? What is the cost involved?
Yeah. So CMC Vellore, they do gene testing in around 13,000, and they will do 31 gene. And in fact, yesterday we had a talk, Dr. Nihal Thomas, the head of CMC was there, and I had a talk after him on the same topic. He said now a DBT grant is available to him, and they are doing now 62 genes. So initially they were doing 13 genes, now routinely they are doing 31 genes. If suppose we are suspecting MODY X, that this 31 genes are negative, he is ready to do the 62 genes, we have to inform him. So this is in the institute setup. There are other private labs like MedGenome, and of late I have been sending the sample to MedGenome. The reason for that is the cost is similar. They will also charge around, although they'll say 17,000, something like that, but if we'll bargain, they'll do it in 12 or 13,000, and there is good fixed turnaround time. They'll give the report in 3 weeks. Many times that becomes a problem in CMC Vellore. They will have to chase after them कि इस patient का कब report आएगा, इस patient का कब report आएगा. So CMC Vellore and MedGenome are the 2 labs I am sending their samples. But there are other labs also, they are doing genetic testing, and I think bargain with them. They'll reduce the cost.
One more question. Are there any sporadic mutations which are associated with this, except for the monogenic and the autosomal dominant? Are there any sporadic mutations?
So there are some suggestion of mutation which were not present in the parents, but they were in the kids. So there are some reports, isolated reports of sporadic mutations. So but they are not that common.
Dr. Arun.
Yes, sir.
This side.
Yes, sir. Sorry.
Another thing which is very crucial, I would like to know, is in genetics that siblings which are asymptomatic, should they be tested or not? It's highly controversial, I understand, but I would like to get the answer.
So that's a very good question, and it will better to do what has Sir told, कि better to do good fasting and 2-hour postprandial glucose or post 75 gram glucose. If that is abnormal, then probably the input to output ratio would be better. But it will also depend upon the type of mutation which is like MODY type 1 and type 3, they have 95% penetrance. So if suppose somebody is carrying that gene, there is 95% chance that they will manifest the disease. But there are some genes wherein the penetrance is less, where they might have penetrance of around 50-60. So there are case reports of kids developing diabetes, mother not developing diabetes in spite of they both carrying the gene. So like I was recently reading this article, 40-year male, he had diabetes, but mother was well controlled on, she had well controlled diabetes just on diet. She was of around 62 years of age. So it will better to do a good fasting PP, and what kind of gene mutation we are suspecting. If there is good penetrance, then probably go ahead. If there is lesser penetrance, 50-60%, then probably even asymptomatic individual should also be screened.
My question probably could not be placed properly. In younger children, siblings who are very young are not likely to express the frank glycemic variations. Should they be tested or not?
Better to test them, sir.
And what is the genotypic and phenotypic correlation?
So it depends upon the penetrance. So many times they might carry the mutation, still they might not manifest the disease. But few of them, they have very high penetrance, they might manifest the disease. So better to do test. And what's important is that if we send the second sample wherein we know the focus gene, the cost is very less. So they will charge only 4,000-5,000 as compared to the first test, which is around 13,000.
Okay, so before closing the session, I have a small question for you. In type 1 and type 2 diabetes, in comparison to this monogenic diabetes, the microvascular complications are very less in monogenic. So what is your say for this?
So that's an important question. So that's one more reason why we should diagnose monogenic diabetes. There is a monogenic diabetes which is called as GCK MODY. And there is now data for almost 30-40 years right from the diagnosis. And what was seen is that after 40 years of diagnosis, they were not having any increased chances of complication of diabetes. There was some chances of increase in background retinopathy. But same is not true for other forms of MODY. Like MODY type 5, they develop very florid nephropathy, and they might have anatomical defect. And also MODY type 1 and type 3, they might develop complications of diabetes. So there are few forms which might not develop complication. There are few forms which can develop even worse than the usual garden variety diabetes which we see.
Thank you, Dr. Pandey. A rather interesting and confusing topic. Further questions can be taken later on with him personally. We're running out of time. Thank you so much, Dr. Pandey, for
thank you very much.
Excellent presentation.
Thank you, chairpersons and speakers. For next session, I'd like to invite Dr. Sunil Kohli, Professor and Head Department of Medicine, Hamdard Institute of Medical Sciences, Dr. Adarsh Kumar, Senior Consultant Physician at National Heart Institute, Dr. Rupali Malik, Professor Medicine at Safdarjung Hospital, and Dr. Vivek Suman, Professor Medicine at LHMC.
To proceed further for the day, I would like to invite our next speaker, Dr. Ashwini Nigam, for deliberating his talk on an important topic of managing diabetes, managing obesity in diabetes. And Dr. Ashwini has done MD Medicine from SN Medical College, Agra, and Senior Residency from LNJP Hospital. Presently, he is working as a professor in Department of Medicine in SN Medical College. He is a life member of various national bodies such as API, IACM and RSSDI, and has published more than 40 research papers in national and international journals. Sir, over to you.
Thank you for nice introduction, sir. And first I thanks to Dr. Anupam Prakash and whole organizing team to invite me as a speaker in this prestigious conference. So my topic is so managing obesity and diabetes, the tickless issue. According to Benjamin Franklin, is an American scientist, writer, and philosopher. One said, the few die of hunger, many die of eating. Man evolved through various stages, the most primitive man, Neanderthal man, Homo erectus, Homo sapiens, but nowadays some men are Homo obesiticus. And diabetes is a global emergency. There are currently 537 million people of working age 20 to 64 years with diagnosed and undiagnosed diabetes in 2021. The 10th edition of IDF Atlas confirmed that the diabetes is one of the fastest growing global health emergency of the 21st century. If this trend continues, the 780 million adults will have the diabetes by 2045. India ranked number 2 in the list of countries with largest number of adults with diabetes in 2021 and is anticipated to remain so high 2030 and 2045 as well after the China. In spite of lower BMI, the South Asians have the more abdominal fat, the thin, more insulin resistance and hyperinsulinemia, higher level of C-reactive proteins, lower level of adiponectin, characteristic dyslipidemia, that is the low HDL, high triglyceride, high levels of small dense LDL, and increased susceptibility to type 2 diabetes and coronary artery disease. India is the third most obese country in the world after US and China. The Indian scenario of obesity, India has to grapple with both over and undernutrition at the same time. The prevalence of obesity in India is increasing, ranges from 13 to 50% in the urban population and 8 to 38% in the rural population. Obesity is more commonly seen in the women as compared to men and nowadays increasing in the children as well as the adolescent. According to National Family Health Survey, the ever married women aged 15 to 49 years who are overweight or obese increased from 11% in National Family Health Survey 2 to 15% in National Family Health Survey 3.
The state-wise prevalence of obesity in India, the highest prevalence of obesity is Punjab followed by Kerala, but the least prevalence of obesity in Gujarat followed by Maharashtra. So more than 75% of the type 2 diabetic patients are overweight and obese as shown by this diagram. Weight gain often associated with increased risk of the diabetes. How much risk? The 5% weight increase is associated with 33% of increase in the diabetes prevalence, and 1.5-fold body mass index increase is associated with 90-fold increase in the diabetes incidence in women, and 40-fold increase in the diabetes incidence in men. This is due to the ectopic fat make a big difference. Obesity and diabetes is a diversity. Diabetes, obesity, hypertension, dyslipidemia are grouped under one name, that is called the metabolic syndrome. The rising prevalence of these lifestyle disorders in India is one of the concerns as a singly or in combination, which act as a major risk factors for coronary artery disease. Increased predisposition to diabetes and premature CAD in Indians has been attributed to the Asian Indian phenotype characterized by less generalized obesity as measured by body mass index, greater central obesity as shown by greater waist circumference and waist hip ratio. So, many diabetic drugs and insulin increase the weight gain as shown by the many study and trials like Wikipedia's study. The insulin increase the around 10 kg weight. In DCCT advanced accord trial also shows the increase in the weight gain. Every 1 kg of weight gain due to diabetes treatment lead to 7.1% relative risk of the heart failure. This is shown by the ADAPT trial, PROACTIVE trial, RECORD trial, and EXAMINE trial. The relationship between the weight gain and perceived achievement of glycemic control in type 2 diabetes, the every 3 kg weight gain offset the benefits of 1% HbA1c reduction in terms of quality adjusted life year. Obesity management for treatment of type 2 diabetes is standard of medical care in diabetes 2022. The strong and consistent evidence that obesity management can delay the progression from pre-diabetes to type 2 diabetes and is beneficial in the treatment of type 2 diabetes. Obesity is very easy to catch, but they can't run very fast. And weight-related complications caused or exacerbated by the excess obesity increase the blood pressure, increase triglyceride level, decrease the LDL cholesterol, increase the chances of osteoarthritis, depression, obstructive sleep apnea, obesity, hypoventilation syndrome. And other the reactive airway disease, non-alcoholic fatty liver disease, gastroesophageal reflux disease, and chances of male hypogonadism, male infertility, polycystic ovarian disease, and stress urinary incontinence. And treatment option for the overweight and obesity in type 2 diabetes is mainly a diet, physical activity and behavior therapy, pharmacotherapy and metabolic surgery. The diet, physical activity, behavior therapy is usually indicated when the body mass index is more than 25 and pharmacotherapy indicated when the body mass index is more than 27 and metabolic surgery body mass index more than 30. The goals of therapy, the weight loss of 8 to 10% over 6 months with lifestyle modification, pharmacotherapy and surgery. The lifestyle modification include the diet therapy, physical therapy and behavior modification. Diet therapy, The primary focus in the diet therapy to reduce the overall calorie intake. The calorie deficit of 500 to 750 kilocalorie per day with habitual diet results in 0.5 to 1 kg of weight loss per week. Alternatively, the diet of 1200 to 1500 kilocalorie per day to women and 1500 to 1800 kilocalorie per day for men also consistent with the loss of the weight. Calorie develop the cholelithasis and nephrolithasis. The mean weight loss over the 1 year is around 3.4 kg and HbA1c reduction is around 0.7. And other drugs are the suppress the appetite. One drug is the lorcaserin. Lorcaserin is the serotonin receptor agonist which act on the 5-hydroxytryptamine 2C. And topiramine, the mode of action is the release the norepinephrine and gamma receptor modulator. That should not be used in case of the acute angle closure glaucoma. And naltrexone and bupropion is the opiate antagonist and decrease reuptake of norepinephrine. The side effect is constipation, nausea, headache, and insomnia. And this drug avoid in case with the uncontrolled hypertension and renal failure. The weight reduction, again the dose dependent. The low dose, the weight reduction around the 4.1 kg. The HbA1c reduction is 0.6. Liraglutide is the GLP-1 receptor agonist. Side effect is the mainly hypoglycemia. Sometimes the patient may develop the suicidal ideation. And the weight loss is 4.5%. The weight loss medication, the topiramate has the advantage and disadvantage, and lorcaserin, orlistatin, naltrexone, and bupropion, and liraglutide. Every drug has the advantage and the disadvantage. Weight loss, some drugs are expensive, some drugs are inexpensive. So GLP-1 and GIP therapy is based medication for primary developed for treatment of type 2 diabetes, has some extra glycemic effect which include the reduction in the body weight. Currently there are 6 GLP-1 based medicine currently approved by US FDA: exenatide, lixisenatide, liraglutide, semaglutide, dulaglutide, and albiglutide. Incretin system and incretin based therapy in response to the food. The GLP-1 is secreted from the L cells of the intestine which increase the insulin secretion, decrease the glucagon secretion, and decrease the gastric emptying, thereby lead to the increased satiety, decreased appetite, and decreased food intake. And in addition to GLP-1 is also increase the GIP secretion which secrete the insulin secretion and increase the glucagon secretion and increase lipogenesis. GIP receptors and agonists and antagonists are under investigation for the weight loss. These are the metabolic action of the GLP-1 agonist, and GLP-1 and central suppressive effect on the appetite control. In response to the food, the GLP-1 is secreted from the small intestine and act on the alpha cell to decrease the glucagon secretion and act on the beta cell to release the insulin secretion. And GLP-1 in addition to directly act on the GLP-1 receptor in hypothalamus, GLP-1 receptor in the hypothalamus, thereby decrease the food intake or increase the satiety. And GLP-1 also delays the gastric emptying, thereby reduce the food intake and increase the satiety. Is the last slide. Peripheral and central mechanism behind the glucagon-like peptide-induced weight reduction is the leptin and ghrelin. Leptin increase the stimulation of the pro-opiomelanocortin neurons in the arcuate nucleus of
Dr. Nigam here. What is the ratio of importance of exercise with regards to diet management?
Exercise is very important part of our lifestyle modification is very important in addition to pharmacotherapy for weight reduction. The first is the only a lifestyle modification.
Yes. Actually,
Diet and exercise. And
that is
also
true.
behavior therapy to maintain the exercise or physical activity or diet. By a trained interventionist.
Yeah, see, what I wanted to say to the House was that diet reduction is 70% and 30% exercise. That should be focus of our intervention with regards to, because we don't
Monjero, which is yes, which is under, you know, it's already Monjero, which is yes, which is under, you know, it's already under the trials are already going on, and that will have the maximum benefit among all these. So practically, you know, these are 3-4 medications, not so many medications.
Thanks.
I'll just differ with Dr. Sanjay what he said. Diet reduction is not the absolute one thing. What is required is diet modification. Yes, exercise has its own role, and intermittent fasting has been proven very effective for weight reduction. The only disadvantage is that because of 14 to 16 hours of weight reduction, it has been found to have some deficiency. So that is not, we run the program what we call is snacks to fitness, that what diet modification will definitely add. And it's not the calorie what you have to take alone. It's a basically metabolic rate management. If you manage that, the weight reduction is possible. Thank you.
I may here add that even the diet constitution, the way you
Exactly,
eat a diet.
Absolutely.
Say, for example, a patient is eating rice and fish. If he takes rice first and fish later on, the PP is high. But if he takes fish first and rice later, the PP is less. Probably it is because of the fish, because of protein intake, there is a gastric stasis. So there is a decrease, more time for insulin to form, and other ghrelin and other byproducts they help. So order in which you take and the consistent of the diet. Protein followed by carb. Yes.
Sir, I have got one question. Sir, in food we know protein, fat and carbohydrate. Is carbohydrate good or bad?
Pardon?
In the food we know we classify.
Next up.
One more question.
Diabetes is nutrition. Abhi next.
One more question is the fat we see in the abdomen, that is white fat. How to reduce white fat and to bring it to brown fat? Is there any medicine?
No, I have no idea at present.
Yes.
White to brown, and there are some more medication, but then otherwise Ayurvedic, like, you know, all this fenugreek seeds and all, and exercise. White to brown.
Thank you, sir. Now I would like to request sir to invite our next speaker for nutrition and diabetes.
She is a MD from Army Hospital. She is also a postgraduate in diploma in clinical endocrinology and diabetes. Presently, she is secretary of the API Ghaziabad branch, and she has number of publications and written books, chapter for the books. And she has presented posters and papers in state and national conferences. Over to Dr. Bansal.
So without wasting any time, I'm really happy that the audience is truly intrigued by knowing about nutrition. Lot of questions coming up. At the outset, I would like to thank our organizers, especially Dr. Anupam Prakash sir and Dr. Ashok, for giving me this opportunity to speak over here. So can I have the presentation? So the topic has been introduced by our previous distinguished speaker. All right. And how do I change the slide? Okay. So the topic given to me was nutrition and diabetes. So let's start by, everybody knows Hippocrates. He said that let food be thy medicine and medicine be thy food. and the illness does not come upon us out of the blue, but they are developed by small daily sins against nature, and when enough sins have been accumulated, illness will suddenly appear. So what are these sins? Actually, thanks to the food industry and Zomato, we can now eat at 3 a.m. And actually, that is what is wrong. This is not natural, and a sedentary lifestyle and a bad eating habit is actually the sin that is leading us to diabetes, and India being the capital now in the world, now it's a major problem. So the global clinical practice guidelines, be it ADA or ACE or IDF, everybody says that medical nutritional therapy in the management of diabetes is the first line. And I think not just the first line, it is the baseline. It needs to be catered to even when the patient is on pharmacotherapy, on insulin or whatever. So in 2019, the ADA published a consensus report which said that one size fits all. Now this kind of a eating plan definitely does not go in the management of diabetes. Why? Because you know, in our OPD settings, हम patient देखते हैं और patient पूछता है कि डॉक्टर साहब क्या डाइट हमें फॉलो करना है, हम लंबा सा पर्चा पकड़ा देते हैं पेशेंट को, जिसकी हेडिंग होती है डाइट चार्ट, और एक वो डाइट चार्ट एक सिडेंट्री लाइफस्टाइल जिसका है उसको भी दिया जाता है, वही सेम डाइट चार्ट एक विगरस एक्टिविटी करने वाले को या एक रिटायर्ड पर्सनल को भी दिया जाता है. तो क्या ये सही है? Let's see. So when you design a diet for an individual, you definitely need to take into account the work profile. As I said, you need to know the food preference. हम पेशेंट से बोलते हैं आप अपना चीनी आलू चावल ये तीन चीज़ें हैं, आई थिंक एवरीबडी एडवाइसेस द सेम, छोड़ दीजिए. आपने कभी पेशेंट से पूछा कि वो ईस्ट इंडिया में रहता है, वो साउथ इंडिया में रहता है, क्या वो चावल छोड़ सकता है? 30 साल से वो चावल खा रहा है, आपने सडनली बोला अब आप चावल बंद कर दो. हाँ बोल के जाएगा आपसे, घर जाके फिर वही करेगा और बोलेगा पता नहीं कैसे डॉक्टर साहब है, इन्होंने बोल दिया चावल बंद करो. सो यू नीड टू नो कि पेशेंट की विलिंगनेस क्या है, क्या वो उसे कर सकता है. और हम I'll come to carbohydrates, but you have to consider the religion, the ethnic profile, and while making these choices, the patient should be willing and the practitioner should be aware कि हम force नहीं कर सकते patient को, हम विकल्प दे सकते हैं, options दे सकते हैं, आप कैसे अपनी diet improve करो. So now, what should be the goal? This everybody knows. You have to maintain a metabolic outcome, a good glucose control without any hypo or hypers, as close to normal as possible. Complications कम करने हैं, lipid profile, blood pressures ये control करना है कि cardiovascular risk ना हो. So now हम carbohydrate के बारे में ज़्यादा बात इसलिए कर रहे हैं क्योंकि in India और maybe in Southeast Asia, carbohydrate is the staple. कार्बोहाइड्रेट के बिना कोई डाइट पॉसिबल नहीं है. 70 to 75% ऑफ द इनटेक ऑफ डाइट कम्स फ्रॉम कार्बोहाइड्रेट, बी इट एनी पार्ट ऑफ इंडिया यू गो, एंड आफ्टर दैट कम्स द फैट्स एंड ऑयल्स एंड देन द प्रोटीन. So how do you count the carbohydrate or monitor them? You can do it by carbohydrate counting, that is simply calculating the number of grams of carbohydrate in a diet. Glycemic index, everybody is aware. Glycemic load is basically glycemic index multiplied by the amount of carbohydrate into the frequency of the meal. So roughly it gives you the total amount of carbohydrate in a diet. And then experience based estimation, which all of us have been doing since many years. So now what are the evidence based recommendations? Here I would like to point that mostly हमारे खुद के knowledge में ही misconception है. हम खुद अवेयर नहीं है कि न्यूट्रिशन कितना इंपॉर्टेंट है और पेशेंट्स को क्या एडवाइस देनी है. नंबर वन रीज़न इज लैक ऑफ टाइम. ओपीडी इतनी बिजी होती है, हमारे पास टाइम बिल्कुल नहीं होता कि पेशेंट को बैठ के हम डाइट समझाएं. उसके पहले मरीज की खुद की डाइट समझनी पड़ेगी, उसका खुद का लाइफस्टाइल समझना पड़ेगा. तो इतना टाइम अगर आप नहीं दे सकते हैं तो आपका डायबिटीज़ एजुकेटर, न्यूट्रिशनिस्ट, यहाँ इनका रोल इज़ वेरी इंपॉर्टेंट. आई थिंक ऑल क्लिनिक्स, be it in government setups or in private setups, we should have a diabetes educator who can cater to the need of the patients. And definitely अगर हम ऐसा करते हैं तो आपकी ड्रग का रिजल्ट भी बेटर होगा. Ultimately patient has to come to you to show the result of a good blood glucose control. So that is important. So the ADA says that food containing carbohydrate should come from whole grains, fruits, unprocessed vegetables and low fat dairy. अगेन यहाँ पे एक लाइन और बोली गई है कि द टोटल अमाउंट ऑफ कार्बोहाइड्रेट इन अ मील इज मोर इम्पॉर्टेंट देन द सोर्स और टाइप. तो बेसिकली मुझे ऐसा लगा कि देयर शुड बी अ बैलेंस, क्योंकि थोड़ा कॉन्ट्राडिक्टरी थी ये दो स्टेटमेंट्स. For sucrose, they said that sucrose does not increase the glycemia to a greater extent than isocaloric amounts of starch-containing foods, but so they don't need to be restricted. But of course, अगर आपका खाना majorly sucrose-driven है, तो आपको OHA बढ़ाने पड़ सकते हैं, इंसुलिन भी बढ़ानी पड़ सकती है. As far as non-nutritive sweeteners are concerned, you can ask your patients to take them in a safe amount. So now, what does the Indian guidelines say? They again say that carbohydrate content should be limited to 50 to 60%. जैसे मैंने पहले बताया कि डाइट में इंडिया में अराउंड 75% तक एक नॉर्मल इंटेक होता है, तो थोड़ा कट डाउन करना पड़ेगा. और कार्बोहाइड्रेट की क्वांटिटी को कम नहीं करना है, उसकी क्वालिटी को इम्प्रूव करना है, उसके ग्लाइसेमिक इंडेक्स को बढ़ाना है. तो वो हम हाई फाइबर डाइट देके इम्प्रूव कर सकते हैं. जैसे आप एक वाइट राइस जिसका GI 73 होता है ब्राउन राइस से, उसको सब्स्टिट्यूट कर सकते हैं. एंड फाइबर इनटेक ऑफ कोर्स शुड बी अराउंड 25 to 40 grams per day. So this was a study done in southern India. It was done by Narsimhan and Lakshmi Priya. It said that comparison of dietary profile of a rural South Indian population with the current dietary recommendations for prevention of non-communicable diseases. तो क्या मिला इनको? Let's see. They clearly said that अगर हमारी डाइट में refined grains जो मोस्टली हम कंज्यूम करते हैं रोटी या फिर राइस के फॉर्म में, अगर वो ज़्यादा लेते हैं तो इट हैड अ पॉजिटिव कोरिलेशन. इट शोड अ हायर अमाउंट ऑफ वेस्ट सर्कम्फ्रेंस, ब्लड प्रेशर्स, फास्टिंग ब्लड ग्लूकोज, हाई सीरम ट्राइग्लिसराइड्स एंड लोअर अमाउंट ऑफ HDL वैल्यूज, एंड ऑल द वैल्यूज वर स्टेटिस्टिकली सिग्निफिकेंट. सो अब एक मैम ने क्वेश्चन पूछा था कि हाई कार्बोहाइड्रेट डाइट वर्सेज अ लो कार्बोहाइड्रेट डाइट. So there were a lot of studies, ma'am, that said that in India, if you go for a high carbohydrate, high fiber diet, along with a low fat diet, that had exceptional results in controlling the blood sugar values, because that diet was sustainable. It could be followed for long. Patient के लिए कोई क्रैश डाइट नहीं थी कि आपके पास वो आया, उसकी 300 शुगर है, वो बहुत मोटिवेटेड है कि मुझे अपनी शुगर कंट्रोल करनी है, मैं 1 महीने चीनी छोड़ देता हूँ, गेहूं छोड़ देता हूँ, मैं सीधे जो है वो फिश पे आ जाता हूँ, एग पर आ जाता हूँ. पर क्या वो जीवन भर कर पाएगा? उसे डायबिटीज तो उसे जीवन भर रहेगी. दैट इज नॉट पॉसिबल. सो इट्स बेटर कि आप पेशेंट को बोलें कि आप अपना गेहूं के आटे के अंदर यू ऐड योर मिलेट्स, यू ऐड हाई फाइबर कंटेनिंग लेग्यूम्स, जैसे बेसन का आटा. दीज आर एक कॉमन एडवाइसेस दैट वी गिव टू द पेशेंट, तो विच आर मोर प्रैक्टिकल. सो दैट वॉज फॉलोड थ्रू आउट अ लॉन्ग टर्म. So what happened when we did a low carbohydrate ketogenic diet? So this diet basically means high fat and protein in the diet. And obviously the source of fat will be MUFA and PUFA. And the amount of saturated fat and trans fats had to be less. Now the effect was here in our previous talk we discussed about obesity. So agar obese individuals isko karte hain for whatever amount of time they are following it, there were good results in weight loss, and obviously weight loss ensured a good glucose control also. But long-term association, it led to ketosis, adverse lipid profiles and adverse renal effects. So this is not advised to be done throughout life. And basically it's not practically possible also. So coming to pulses and pulse incorporation, again the same thing. आपको grams and pulses को incorporate करना है wheat based starchy high glycemic index diets में. So that जैसे सर ने पहले बोला था कि pulses जो है वो satiety कम करते हैं. They have a decreased amount of absorption. They stay in the gut for longer amount of time, and thus भूख भी कम लगती है, calories का intake relatively कम रहता है. For vegetarians, another option is intake of nuts. Now for fiber, everybody knows ADA said that you take around 5 grams of fiber per serving or around 14 grams of fiber per 1000 kilocalories. Here I would like to tell you about a study that was maybe old, 2017. It was done in 56 healthy individuals, a randomized cross-sectional study that said that efficacy of fiber addition to a flatbread flour mix for reducing post-meal glucose and insulin responses in healthy Indian subjects. तो इसमें उन्होंने पाया कि अगर हम फ्लावर के अंदर चिकपी या गॉर्गम, दीज आर द सोर्सेज ऑफ फाइबर, अगर हम ऐड करते हैं So we found a significant reduction in postprandial glucose and postprandial insulin values compared to जो लोग सिर्फ मैदे की bread खा रहे थे. So this was a very easy step that we can advise our patients in day-to-day practice, and it had good results. So coming to resistant starch. Now what is resistant starch? So a starch that is physically enclosed within an intact cell structure, such as a legume, a starch granule, or for example ना raw potato. तो इसका क्या फ़ायदा है? Normally हमारी diet में भी बहुत सारे high resistant starch food items होते हैं. For example, are tuberous vegetables and potato. So we saw that if you heat it prior और कुक करने के बाद अगर नेक्स्ट डे कूल करके आप उसे यूज़ करते हैं तो उसका ग्लाइसेमिक इंडेक्स बढ़ जाता है, कम हो जाता है कहीं ना कहीं, तो आपका एब्जॉर्प्शन भी कम होगा एंड यू कैन गिव इट टू द पेशेंट्स विदाउट गिल्ट. पेशेंट पोटैटो खा सकता है. So the next most important things was fat and oils. Saturated fats and trans fats were the principal determinants that caused a high LDL value. So saturated fats were advised to be taken in 7% of the total energy as far as ADA is concerned, and minimal amount of trans fat consumption, cholesterol intake around 200 mg per day, and high carbohydrate diet in this is one thing I want to say. बहुत सारे patients हमारे पास आते हैं blood sugar के साथ, obviously हम lipid profile कराते हैं, and most common association is a high triglyceride. और पेशेंट कहता है कि डॉक्टर साहब मैं तो तला भुना खाता ही नहीं हूँ, मैंने तो आज तक कभी पकौड़ा नहीं खाया, समोसा नहीं खाया, मेरा तो कोलेस्ट्रॉल ही कंट्रोल नहीं हो रहा है. सो यू नीड टू नो दैट इट इज़ नॉट जस्ट द अमाउंट ऑफ ऑयल, high amount of carbohydrate also and majorly coming from a refined source will also lead to a high triglyceride value. So ये बताना है हमें मरीजों को. So what are the now RSSDI recommendations? They say that you replace the refined cooking oil with the oils that contain higher percentage of monounsaturated fatty acid, mostly canola and olive oil. Although I'll come to these two oils also later. For non-vegetarians, fish is a very good source of alpha-linolenic acid. So you can take 2 to 3 servings of fish in a month, in a week. And for vegetarians, what you can do is add some kind of seeds like sesame, peanut, flaxseed, poppy seeds and all. This thing everybody I think knows, but we require to tell the patients, repeated heating and frying is not to be advocated. तो जितने भी रोड पर हम fast foods खाते हैं, that is detrimental because the oil that easily degrades into toxic components, it makes free radicals, trans fats, which are potentially mutagenic. तो ये avoid करना है. Now why I have highlighted sunflower oil, because अभी recently बहुत hue and cry थी, government ने बोला कि तेल के प्राइस बढ़ गए हैं, everybody was protesting कि इतना इन्फ्लेशन हो गया है, why is the amount of oil has increased. So majorly हम अपनी cooking में use कर रहे थे sunflower oil, thanks to the food industry again, because this was the only thing that was advertised. So you can see there are multiple studies that said that sunflower oil that has high N6 polyunsaturated fatty acid is used as a main cooking oil. If it is used, it is associated with higher metabolic risk compared to the traditional oils. ये हमारे native oils हैं, groundnut oil and sesame oil, जिसके बारे में कोई बात नहीं करता है. तो another study that said that synergistic effect of sunflower oil along with refined grains, अगर हम लेते हैं तो again significant association है metabolic syndrome को worsen करने का. Now आप देखिए कि 2020 में India was the highest importer of sunflower oil. But the question is हम कर क्यों नहीं इसे import? Why are we not telling our patients that it is actually useless? We don't have to use it and we have to rely on our native oils जो हमारे खुद के India में produce होते हैं. So 90% cultivation Chanda he did from Gangaram Hospital. He did a study on selecting healthy edible oil in Indian context. Not much of the studies are available of late regarding oils. So this is a table I've taken from that study. I want you to just go through the sunflower oil, and here you can see the ratio of N3 versus N6, that is linolenic and alpha-linolenic acid. Now if the ratio is on the higher side, the risk of metabolic side effects is high. So sunflower oil, safflower oil, you can see 120 and 140, or obviously there is no point in buying it and there is no point in blaming the government for high prices. And one more thing, if you see number 1 and number 3, ghee. सदियों से बदनाम रहा है, क्लिनिशियंस ने तो शायद रोटियों पे भी लगवाना बंद कर दिया मरीजों का, और अब तो ये स्थिति है कि अगर हम बोल भी दे पेशेंट को कि घी खा लो तो वो बोलते हैं इन डॉक्टर साहब को कुछ नहीं पता, ये तो हमें घी खिला रहे हैं। तो एक्चुअली अगर आप देखें कि इसका रेशियो इज जस्ट 4 एंड वेदों में और आयुर्वेदा में किसी वजह से घी की इतनी इंपॉर्टेंस थी। तो आई थिंक द टेक होम मैसेजेस, कुछ अमाउंट ऑफ घी आप प्लीज अपने पेशेंट्स को खाने दीजिए, इट विल नॉट डू एनी हार्म। सो ओके, अगेन घी एंड कोकोनट ऑयल की रेलेवेंस यहाँ भी है बिकॉज दे आर स्टेबल ड्यूरिंग फ्राइंग। ये कंपोज नहीं होते हैं, सो इट्स अ गुड मीडियम फॉर फ्राइंग। एंड देयर वर स्टडीज ऑल्सो टू इंडिकेट दैट oils that were high in short and medium chain fatty acids like coconut oil, they did not have any adverse effects. और इतने समय से साउथ इंडिया में इसीलिए कोकोनट ऑयल प्रेवलेंट है क्योंकि इसके कुछ बेनिफिट्स हैं। Apart from that, mustard oil and cold pressed mustard and rapeseed oil, they also have a favorable LA-ALA ratio, and of course they are also relatively stable, so they should be the preferred choice. तो oil के लिए आप पेशेंट्स को जरूर बोलिए कि सीजन के हिसाब से according to the harvest you can change the amount of the choice of oil, क्योंकि जो उसका tocopherol values, जो उसका amino acid profile है वो different होता है, and change करने से you can have a the good assimilation of overall amino acids. So now coming to plant sterols and stenols, so these are also proven to be taken in an amount of 2 grams per day. So they have shown to lower the plasma cholesterol and LDL cholesterol. Rich sources are sesame oil, wheat germ oil, and olive oil and nuts. Coming to olive oil, I just said that even RSSDI mentioned that you take a Indian Mediterranean diet. I am really not aware कि Indian Mediterranean diet क्या होती है. This is the first line that is mentioned in the guidelines, and they advocated taking canola and olive oil. Now canola and olive oil both are not native to India. Again, they need to be imported. So what is the relevance? And if many dignitaries are sitting over here, I would really like in the updated RSSDI guidelines, please take this into consideration कि आप mustard oil को थोड़ा promote करना चाहिए हमें locally. So as far as proteins are concerned, a number of studies in healthy subjects said that done in those with controlled type 2 diabetes, they demonstrated that glucose from ingested proteins do not appear in the general circulation, and therefore increasing the plasma glucose concentration was not associated. So such diets that were high in protein, they were definitely associated with short-term satiety, weight loss, and improved glycemia, but there have not been much of the studies that in which the people use long-term high protein diets, so the effects could not be assessed. So diabetes and obesity, sir has discussed in detail. Only I would like to, ma'am, just 1 or 2 slides. I would just like to say that slow eating and stimulus control. आजकल सब लोग अपना tabs, TikTok videos, WhatsApp देखते हुए खाना खाते हैं. This is a strict no-no. You don't have to do that. Brain doesn't know when to stop, when to start. So आपको stimulus control is the key. You have to eat peacefully. And improved quality of sleep, definitely it will help in diabetes and obesity. So last and not the least, अपना खुद का योगा जिसको अब हम एक बड़ी एंटिटी की तरह देखते हैं, thanks to our government who is promoting that. हम पेशेंट्स को हमेशा बोलते हैं कि आप वॉक करो, सिर्फ वॉक करते रहो, पर क्या सिर्फ वॉक एडिक्वेट है कैलोरी कंट्रोल करने के लिए या मेटाबॉलिक बेनिफिट्स के लिए? यू हैव टू ऐड ऑन टू स्ट्रेंथ ट्रेनिंग. एक किसी ने somebody asked the question कि क्या करना है हमको, तो you have to add strength training to walk. That will actually give you the desired benefit as far as any kind of non-communicable disease is concerned. And there are multiple studies that say that 45 to 60 minutes of yoga, if you practice, it was better than any other kind of exercise in terms. किसी को कुछ भी समझ में नहीं आया तो एक टेक होम मैसेज है कि इतने साल से जो आपकी दादी नानी आपकी ग्रेट ग्रैंड मदर्स अपने एरियाज में जो खाना बनाती थी, दैट वाज कन्वेंशनल एज पर सीजन. आप पेशेंट को बोलिए वो सीखो और बनाओ, चाहे वो मेल है चाहे फीमेल है. ये जो अभी फैशन चला है इंस्टाग्राम पे ना, इटालियन क्विजीन, चाइनीज क्विजीन, दिस हैज़ नो रेलेवेंस बिकॉज हमारा जो एनवायरमेंट है, हमारी ईटिंग हैबिट्स आर नॉट the same as Chinese or Italians. So thank you so much.
Thank you, Dr. Bansal, for your illustrative talk. Now I would like to add here that there is a great demand for the packed food. The packed food is nothing but has a preservative, permitted colors, and it is processed. What is processes? Processing means the food is heated to 200 degrees centigrade and it is packed. So all the nutrition value is gone. Many of us will agree that we are eating olive oil. Now, if you see the recommendations, it is only the extra virgin olive oil which has got the good properties. Whatever we are getting in the Indian market is probably not extra virgin. So we are spending the money and getting probably chapati or my puris in the olive oil. Another thing is that the what is called boiling point or the vaporization of the olive oil is very low, temperature wise. If you compare with the mustard and other oils, smoking point of the olive oil is very low. So actually olive oil is not meant for cooking. It is meant for either applying or just using some flavoring. One Bihari dish in which they use potato, and I was really fascinated. They do the potatoes in the chula or in the tandoor, and what happens is the caramelization of the sugar takes place. It forms an outer crust on the top of the potato. And actually that potato is baked and is very tasty and is almost as good as a normal, you can say, good substitute to the people who want to take potatoes. And as far as my IQ says, whatever I have seen, the combination of mustard oil and the soybean oil is the best combination in our present scenario.
We can take one more question from the audience since we are going short of time.
Can I just...
Carbohydrate should be classified in category or bad category.
Ma'am, you're not clear. I'm sorry.
Carbohydrate, the protein, fat and carbohydrate. Carbohydrate should be included in which category? Good or bad?
Which category? Good or bad? The body can't work without carbohydrates. We know that. It's the energy food that we require, and obviously the amount is more than proteins and fats for the same reason. So we are not talking about whether to add or not. Carbohydrate needs to be taken, but you have to improve the quality of carbohydrate. If you take it from unrefined sources like grains, अगर आप लेते हैं pulses ज़्यादा लेते हैं, unprocessed vegetables or fruits लेते हैं, you are still taking carbohydrates, but the glycemic index will reduce.
I'll just like to make small point. There's a marketing strategy with regards to safflower oil and sunflower oil. They say that no cholesterol, zero cholesterol.
Right.
But it is to be remembered that cholesterol, as per se, it's not present in the plant seeds at all. It is an animal product, animal oil. So that is not present in any of the other oils as well. So marketing strategy is there about the cholesterol, no cholesterol, it is not there. And there was a study done by the AIMS people with regards to the oil, which is the best oil. And they said that majority of the diet should contain 80% should contain mustard oil and 10% olive and 10% groundnut oil.
So this was in some particular ethnicity or overall?
Indian only.
Which part of India? There is a whole lot of variation.
Yeah.
North Indians might require something different, South Indians different.
No, maybe it's in the north only, because
Okay.
South Indians, they are taking groundnut oil. So that is that we should take more of the
right.
Yeah, this mustard oil as compared to
Local को promote करना है थोड़ा.
Thanks speakers for this session, and now I would like to over to the
Thank you so much.
Thank you, chairpersons and speaker, for the wonderful presentation.
I request speaker and chairpersons for this session to collect their mementos and certificates from the faculty reception area. Thank you.
Chair, Finance Secretary at DDR.
केवल एक और आ जाती है ना जगह माइक भी यहीं से बजा रहे हो क्या इंस्ट्रूमेंट यहाँ से बजा रहे हो है इससे ऑडियो चली जाएगी इससे ऑडियो चली जाएगी वही चेक करके बुझा तो रही है कनेक्ट है स्पीकर में बात बोला देखो
बस ये वाला बैकग्राउंड दो ना बस ये दो बस और क्या कुछ और लगाओगे क्या नहीं कुछ नहीं हाँ ये लगा वो तो बाद में करोगे वैसे करोगे वो तो अब करिए अभी तक वहाँ से सोफा ठीक कर बस हो गया अब करिए बोलना नहीं से निकाल के डाल दो A very good morning to all of you. On behalf of Delhi Diabetic Forum, I welcome you all to this DIABCON 2022 and we proceed with the inaugural ceremony. I would like to invite on the dais our past president and patrons, Dr. S.P. Kalra sir, Dr. Rajiv Gupta sir, Dr. Jeevan Prakash sir, founder member of Delhi Diabetic Forum, Dr. L.H. Gotekar sir, Director, Professor and Head of Department, Department of Medicine, Lady Harding Medical College. I would like to call upon the chairpersons for DIABCON 2022, Dr. Sachin Jain, former head, Lady Harding Medical College, Department of Medicine. Dr. Vinod Mittal, sir. Our organizing chairperson and president, Dr. Anupam, sir. And organizing secretary and general secretary of Delhi Diabetic Forum, Dr. Ashok. I will request the dignitaries on dais for the lamp lighting ceremony. I would request Dr. Umesh, one of the senior DDF members, to please help with the lamp lighting ceremony. Sir, please be seated. Now I request our organizing chairperson and president DDF, Dr. Anupam sir, to please give the welcome address.
Well, thank you, Dr. Piyush. In an academic program, we keep the inauguration to a minimum, and as has been the tradition, inaugural function has always been from those who have been erstwhile DDF members. So it is a privilege to be here and have the senior faculty, founder members, past presidents on the dais, gracing the occasion and lighting the lamp of knowledge to have this DIABCON like others, the previous ones. And today again, I would just take a couple of minutes to say that last couple of years have been very tumultuous, not only because of the COVID pandemic, but otherwise also many organizations have changed shape, changed the ways they function, and today in 2022, 2019 we were at Meridian, 2020 we had an e-conference, 2021 we had a hybrid conference last year with minimum persons with all COVID restrictions. Today in 2022 we have come back, but we have shifted to an academic environment. And academic institute, which is more than 100 years old, and it has always been that there are hardly in any conference you go, there are 50 persons who are dedicated, who are only interested in academics more than the food or the ambience. The ambience here, obviously, I understand that it is as good as any, that was the feedback yesterday, as any other 5-star probably. And with a few hiccups because it's a very new auditorium and this is probably the first function which is continuously there. So yesterday morning we were having some few hiccups. But I am glad that we have 50 dedicated audience even now, as has been the norm for academic events. And that is a very good thing, and I take pride in it, and I understand that by word of mouth, if people will be satisfied at the end of the day, probably next year DIABCON, we will have much more numbers, and we would be, obviously this academic feast would continue. We don't have people, most of the speakers also you would understand, they are all from academic institutes. And whatever is being discussed is hardcore data, and there are very few sponsored or talks which has never been there in DIABCON. You would all understand we always have academic environment for whoever is attending and whoever is speaking. Well, thank you for being there and thank you so much. Thank you.
Thank you, sir. Now I would request Professor Sachin Jain, the scientific chair, to say about, enlighten us about the scientific program.
Thank you, Dr. Piyush. Good afternoon and a very warm welcome to DIABCON 2022. As a scientific chairman, it is my proud privilege to be here and present the scientific program to you. The scientific program has been planned with an eye on day-to-day diabetes management with the aim to simultaneously cover the newer advances and technological. It has been our endeavor to cover the comprehensive management of diabetes and newer drugs, newer indications. Scientific program covers topics like COVID and diabetes, periodontal health, clinical inertia, hypertension, gut and diabetes, cognition and diabetes, and musculoskeletal manifestations of diabetes, infections, etc. Apart, newer as per the needs, artificial pancreas, which is coming over a period of time and it will be available to more people, time in range, and other issues like obesity, immunity, nutrition, diabetes, distress have been included. A panel discussion, quiz and paper presentation completes the floral bouquet of this scientific feast. It has been a great endeavor and hope the delegates will find it and they will go back happy and satisfied. The very hard work put by Professor Anupam and Professor Ashok is very visible, and 3 cheers for them. Jai Hind.
Thank you, sir. I would like to now call upon Dr. Vinod Mittal as scientific chair to tell about the scientific program.
Good morning, everyone. And first of all, I welcome all of you to this great scientific event. And this is first post-COVID, live conference. Scientific program has already been covered. I would say I'm founder member of Daily Diabetic Forum, and I was also General Secretary 2012 to 2015. DDF has traveled a long distance, under the able leadership of Dr. Anupam, Dr. Ashok, and many others. And we have tried our best to make the scientific program in a manner that it benefits everyone, right from general practitioner to the high-end academicians. So we have tried our best not to leave anything, unturned regarding diabetes. Thank you.
Thank you, sir. We all have been talking about this venue, and Lady Hardinge Medical College have been very generous in providing DDF this auditorium for this conference. I will request upon the Head of Department of Medicine, Lady Hardinge Medical College, Dr. Gotekar of the host institute, to give a message to the delegates.
Good morning to one and all, respected dignitaries, chairpersons, panelists, speakers, residents, my colleagues, faculties. It's our privilege of this institute to have a program, this academic feast in this institute, and we really feel Daily Diabetic Forum and Lady Hardinge Medical College that we are here on 30th academic event. And I also congratulate chairpersons and the scientific chairperson to conduct such an academic feast, which will be absolutely very essential for the growth of a person. Education is the kindliness of flame and not filling the vessels. It has to be raise the inquisitiveness of the person so that he understand and change the accordingly. And the very purpose has been solved by this. I know every faculty has taken enough pain. Every speaker has put his best, barring me only. I can't praise for myself. So we have been benefited by this program, and the program will continue like this. Today, the administration has helped us to have this program here. And the dynamic team under the Anupam Prakash, Dr. Ashok, and team has doing excellently well, and they'll continue to do well. We know that. We must congratulate and applause for them. Naturally, the force is always behind them is like dignitaries and stalwarts like Dr. Jivan Prakash sir, Dr. Kalra sir, Dr. Mittal. So these are the force which actually what you are saying is today is that. And I definitely only feel it bad because now it is a YouTube available, it is there. So many of the residents, in spite of telling, do not want to take an advantage of it. And being a Sunday, probably they wanted to enjoy more than what they wanted to be here. 6 days, they are already pressurized for having academic something. But I think this is the best way, and we have none less than any 5-star hotels. The food is excellently good. So we could have enjoyed much more, and I believe, and I absolutely congratulate all of you to be here. Let's applaud for yourself. I thank you, each and every one of you, and will continue to ignite such type flames in future. Thank you so much.
Thank you, sir. I would now request upon Dr. Rajiv Gupta, one of the founder members of Delhi Diabetic Forum, to give us some blessings.
Good afternoon to all of you. I am really proud to see that today, after 30 years of this organization has been doing very well. And the first lecture that we did was on GDM, and we are now back to Lady Hardinge Medical College, again doing full academic work. And it's been really heartening to see that it's not the people sitting out here only. We are on the YouTube also. And so it's a kind of a hybrid kind of a conference. So one should not get discouraged by the number of people sitting out here. There will be an equal more number probably watching on the YouTube also. I am really congratulating Dr. Anupam and his team for a wonderful job. Thank you so much.
Thank you, sir. Now I request upon Dr. S.P. Kalra, sir, the senior member of Delhi Diabetic Forum, to give us blessings.
Dear colleagues, dignitaries on the dais, and delegates and friends, I feel very happy to be here, where I have seen the knowledge is disseminated. The aim of our Delhi Diabetic Forum has been knowledge enhances by dissemination. And that part has been being done. With the every passing year, I noted there is a tremendous improvement in this regard. And the present team, under the presidency of Dr. Anupam Prakash, has done human service properly. It was not a physical conference. This time it's fully physical conference. And the venue was so beautiful, and credit goes to Dean and the team of this medical college, which has given this opportunity for us. It's one of the best venues we had. Probably it will improve further with the passing of days and with the newer team. I congratulate Dr. Anupam Prakash and his team for doing their wonderful job. Thank you.
Thank you, sir. Now I request another founder member, Dr. Jivan Prakash, sir, to please come.
Well, we started from a very small organization. We sat in the barracks of Safdarjung Hospital behind Dr. M.P. Agarwal. We should not forget Dr. M.P. Agarwal because he was very instrumental in getting the DDF established. We started from a very small organization, and we begged and borrowed and started from Safdarjung Hospital. We had these, we used to take diabetic lectures in the afternoon, and from there we started, and we went from one college to the other, Maulana Azad. We performed this annual function. I have been coming to this annual function since 1992 every year. Only in the last 2 years when it was not held because of the corona. We were right in the roots of this DDF organization, and we could only build up a small branches in it. But now the buds and the flowers have blossomed it very well, and the younger team has done it very well. With the new team has done very, very well. I am very grateful to them. It has lasted for 30 years. Other organizations have finished. They have gone away somewhere, but it has been continued by the efforts of Dr. M.P. Agarwal, V.K. Gujral, Dr. Rajiv Gupta, and now Dr. Anupam Prakash and the newer team. This young team is very, 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 very laborious. They have built the things very well. I congratulate them, and I congratulate them for today's successful program also. We prefer such lectures and such chairpersons to be here who spread the education to everyone. Thank you.
Thank you, sir. Now I request Professor Ashok sir to deliver the vote of thanks.
Thank you, Dr. Piyush. It is my proud privilege to give you the vote of thanks for the inauguration program. And I'm I become very emotional that I have very senior members over here. For the founder member who lead the, जिन्होंने यहाँ इस डायबिटिक फोरम की नींव रखी है और हमें यहाँ तक पहुँचाया है. I'm thankful to Dr. S.P. Kalra sir, Dr. Rajiv Gupta sir, Dr. Jeevan Prakash sir, and Dr. Umesh Kansra sir. They are the founder member and the founder member of the Delhi Diabetic Forum. They always shown us the vision how to proceed and always given their support and motivation to organize the conference of such level. I thank Professor Dr. Director and Professor Dr. L.H. Gotekar sir, Professor and Head Department of Medicine, Lady Hardinge Medical College, for their words of encouragement and support from the medical college here. I thank you very much, sir. Also thank Dr. Sachin Jain, sir is scientific chairman of the DIABCON 2022 and former director and head of the Department of Medicine, Lady Hardinge Medical College. Thank you very much, sir, for being here with us for this wonderful scientific program. I also thanks Scientific Chair, Dr. Vinod Mittal, sir, for your kind words regarding our conference and flow of the events which are occurring here. Thank you, sir. And in the end, I would like to say thanks to our dynamic president, Dr. Anupam Prakash, sir. Sir is very highly motivating for us to organize the things in the manner the which things should be. Thank you very much, sir. And also thank all the senior members, faculty, and delegates who came across all over India to join this DIABCON 2022. And thank you very much to all of you. And we are also having many lectures and programs. I think you're going to enjoy further. Thank you very much to all of you.
Thank you, sir. With this, we come to the end of the inaugural ceremony. Now I request you to stand up for the national anthem. Thank you. Thank you, sir. We continue with our scientific program of session 5.
Now moving to the next section, I would like to invite Dr. UC Kansara, sir, Senior Consultant Medicine and Dr. UC Kansara, sir, Senior Consultant Medicine and founder member of Delhi Diabetic Forum. Dr. Naresh Kumar, sir, Professor Medicine, Maulana Azad Medical College. Dr. Ritesh K. Gupta, Professor Medicine, Ram Manohar Loya Hospital. Dr. Ritika Sood, ma'am, Professor Medicine, Lady Hardinge Medical College.
We are once again back after the inaugural session. So we all understand that managing diabetes is not easy. So we have the next talk by Dr. Vinod Mittal on the topic pitfalls in the management of diabetes. Call upon Dr. Vinod Mittal, sir.
Good morning, everybody. Well, we all are busy in managing diabetes, but we rarely look upon the psychological aspect. Often this is neglected or sometimes missed. So to talk on that, we have got Manishri Gupta. I request Dr. Manishri Gupta to come on the dais. He is Associate Professor in the Department of Psychiatry at Vardhan Mahavir Medical College and Safdarjung Hospital. He was a former faculty at GTB Hospital and posted in Institute of and Maulana Azad Medical College. He is a member of National Expert Committee for Guidelines for Treatment of Substance Use Disorders, Ministry of Health and Family Welfare. He is on the editorial board of and member of 2 international and 1 national journal. He has got special interest in addiction psychiatry, depression, HIV and diabetes. He has got a number of national and international publications in reputed and 5 page journals. He is General Secretary of Delhi Psychiatric Society. He is a member of Institute Ethics Committee, Vardhan Mahavir Medical College, Safdarjung Hospital, New Delhi. I request Dr. Manishri Gupta to kindly continue his talk, Diabetes, Distress and Depression.
So very good afternoon to the distinguished audience, the members of the DDF and the chairpersons. Thank you for inviting me for this session as a speaker on diabetes, distress and depression. I would like to begin this talk with a small story that kindled my interest in diabetes and depression. How did this come about? Dr. Anupam took me to meet Dr. Munjal once. I was not supposed to be there. I'm missing the presence of Dr. Munjal here, maybe due to his poor health. And out of the blue, he suddenly mentioned that you being a psychiatrist, why don't you work upon diabetes and depression comorbidity? And that kindled my interest. I searched the literature and was amazed by the absolute amazing evidence that has been generated over the last 15 years in diabetes and depression. And that resulted in 2 book chapters of API, 1 review article on diabetes and depression, 1 thesis, ongoing thesis on diabetes and depression, and this current talk on diabetes and depression. Now, to begin with, I would like to take you back in the history. I'm sure that you all know Osler, all the physicians present here. Osler is considered the father of modern medicine. He wrote a book in 1892 by the name of Principles and Practice of Medicine. And there he mentioned, I think more than 200 years back, he mentioned that diabetes, one of the risk factors for diabetes is neurotic temperament. And before that, Willis, the famous Dr. Willis of the Circle of Willis mentioned that diabetes is caused by prolonged sorrow or prolonged sadness. Now, from that observational analysis to the current evidence that we have right now on depression and diabetes, it is now well established from meta-analysis, 2 meta-analysis that have taken place recently, that diabetes leads to depression. It causes twice, the risk is twice as much, and depression leads to diabetes. So it's a bi-directional relationship. We'll come to this later as we establish the relationship between the pancreas and the brain. I'm sure that you know how pancreas malfunctions in diabetes, but what is its relation or connecting link with diabetes, or brain? To begin with, diabetes distress. This is an often discussed entity in diabetologists conferences and conferences like this. What is diabetes distress? Can I begin with a short poll amongst the audience? All those who suffer from diabetes can please raise their hands. Anybody? Thank you, sir. All those who suffer from any chronic medical illness can please raise their hands. Or maybe a partner or a parent who suffers from a chronic medical illness or diabetes. Thank you, sir. So I think we all experience and we all know what distressing emotions go through our mind when somebody is diagnosed with diabetes. In fact, the person who is diagnosed with diabetes, the stigma is much more than, say, a psychiatric disorder, or for example, a chronic medical illness. Because the society or the immediate family members do not understand that it's not their fault. The patient who's undergoing this experience of diabetes, it's not totally their fault. There are genes at play. But no matter how hard you try to change the exercise, no matter how hard you try to change the oil or the carbohydrate intake, that does not happen. Because the blame game keeps on going. The person is demotivated to change. He has a low self-esteem, and this talk is about how to address that. So I'll be limiting my talk mostly to the techniques of how to address that in your patients. Now, diabetes distress was first, it's a term coined by psychologists from Joslin Diabetes Institute in Boston, US. It is a psychological reaction to the threat of diabetes. Now, a diagnosis of diabetes is a threat to anybody, integrity of anyone. So what happens? Our coping resources, when we are presented with that news that your HbA1c is above 7, or your fasting blood glucose is above 110 or 120 for more than 3 readings, and you are diagnosed as diabetes, it's a label that you put on the patient. What happens? The coping resources of a person gets overwhelmed. He's not able to cope with that diagnosis. So this gives rise to distress. And distress comes from 3 domains. Diabetes distress comes from 3 domains. First is the diabetic regimen. When you suddenly tell the patient that from tomorrow onwards you have to start exercising, increase your physical activity, when we all know our default mode, in fact my default mode is lying on the bed with a remote in my hand and watching Netflix. So how would I accept that recommendation from my physician? Secondly, you have to decrease carbohydrate intake, your fat, and you have to then also cope with the emotional burden that comes with the diabetes diagnosis. you are overwhelmed, you are misunderstood, and the family sometimes blames you for not restricting your diet. So these are the emotional burden that goes on with the patient. And then there are interpersonal issues with your partner, with your friends, after you are given a diagnosis of diabetes. So these are the domains of diabetic distress. And then the second major category is the severity of distress. When it becomes more severe and over a period of time, it becomes depression. Diabetes distress might change into depression. Now this study, the DAWN, I'm sure that most of you would be aware of or have heard about the DAWN study. This DAWN study was first sponsored by Novo Nordisk in 2001. This was the first DAWN study. Then the second DAWN study, which came in 2015. So this was a very large trial. The DAWN 2 study especially, it involved more than 15,000 participants, more than 900 participants from India, more than 17 countries. And what did it study and what were its key findings? What are the psychosocial factors behind diabetes management? Now, there are a number of drugs which have come into the anti-diabetic regimen in all of your armamentarium recently. There might be SLP, agonist. There is a recent, I am forgetting the name of that drug, approved just in May 2022, the once-a-week injection for diabetes. Tirzepatide, I think, if I'm pronouncing it right. So, thank you, sir. Tirzepatide, right? Okay, thank you, sir. It's still difficult to pronounce. But even after all these advances in medical armamentarium, what happens if your patient does not take it? If he does not adhere to it? What happens to the diabetes? It cannot be managed even after all these advances. If it does not stick to the lifestyle modification that you have recommended, what happens? The diabetes will not be controlled no matter how advanced the treatment is or how accurate your recommendations are about lifestyle changes and your diet changes and increase of physical exercise that you recommend that 30 minutes karna hai aapko kal se. It won't happen because the adherence is not there. So the key findings from this study was that the proportion with likely depression of diabetic population is 13.8. It's a fairly conservative estimate because by Indian studies, this estimate is much higher. 20 to 40% of the patients of diabetes have some depressive symptoms or can be diagnosed with depression. Diabetes-related distress was reported by 44.6% of the participants. Now, there is a paradoxical finding in this study. Diabetes distress but not depression was associated with poor glycemic control. It's diabetes distress which is adversely affecting the glycemic control more so than the depression. So diabetic distress is a real entity that we somehow forget to ask to our patients. The overall quality of life was rated poor or very poor by 12% of the patients. Diabetes had a negative impact on all aspects investigated, ranging from 20% on relationship with family. As I mentioned, the interpersonal issues are very, they lead to adverse outcomes in diabetic self-management. Although as physicians, we do not have the time nor the training to delve into the interpersonal issues. And then you might take help of a psychologist or psychiatrist for delving into that. Now, depression in diabetes, I presented earlier in DDF as well. And as I said, it has led to 2 review articles. So there is a large number of papers available for why depression occurs in diabetes. What is the link between the brain and pancreas? So first of all, the bidirectional relationship between diabetes and depression is well established. It's diabetes, if the primary disease is diabetes, it leads to the risk of depression in such patients. If the primary disease is depression, it leads to a 1.5 increase in the incidence of diabetes. Depression leads to 1.5 increased risk in to diabetes. Now, why does this occur? Why this bidirectional relationship? There are a large number of pathophysiological mechanisms that have been hypothesized, but can some responses from the audience enlighten us? Why does this occur? Why depression and diabetes are linked together? The audience, please. Any idea? Dr. Rupali, Dr. Piyush? why diabetes and depression are interlinked. Right. Yes. So it has more to do with our behavior change, right? If we are suddenly given a diagnosis of diabetes, we are first of all the denial phase comes, then we bargain, मेरे को ऐसा क्यों हो गया diabetes, मैं तो बहुत exercise करता था. Yes, sir. Yes, sir.
Not many restrictions.
Yes.
And then it can be passed on to your some children and all. So there are not many things come and,
Right, sir.
And affects his age outside. He has to restrict himself. He'll be controlling diet. That आपको क्या problem है? So we see find everywhere that this disease has
limited my freedom. Right, sir. So it has restricted our behavior. That is one very important aspect. Any other mechanism by which diabetes and depression can be linked?
But can be autonomic system involvement. Hello, I am here.
Sir, sir.
Autonomic nervous involvement, especially when the patient develops erectile dysfunction.
Right, sir.
So they have a lot
so
of
the complication of diabetes.
Yes.
Right, sir. That is very important. Anybody else? The students who have read about diabetes? Right, madam. Yes. So first phase is denial for everybody. कि मुझे नहीं हो सकता, फिर से चेकिंग कराता हूँ, हो सकता है कि लैब की रिपोर्ट गलत आई हो, या मे बी डॉक्टर चेंज करके देखता हूँ, उसको डायग्नोसिस करना नहीं आया. सो दिस इज द फर्स्ट यूजुअल रिस्पॉन्स ऑफ आवर पेशेंट्स, डिनायल. उसके बाद धीरे धीरे एक्सेप्टेंस आता है, जब रिपोर्ट्स HbA1c कंटिन्यूसली 7 के ऊपर आती रहती हैं, वो नेट पे भी पढ़ के आता है, गूगल पे सर्च करके, देन ही अंडरस्टैंड्स कि डॉक्टर सही बोल रहा था, आई हैव डायबिटीज. सो दिस एक्सेप्टेंस टेक्स 3 to 6 months टू कम. पहले डिनायल रहता है. अनदर मैकेनिज्म नाउ, all the three audience, I'm thankful to them that they have highlighted very important points of the stigma attached or the distress attached to diagnosis of diabetes. तो उसका जो freedom खत्म हो गया है, तो of course it will lead to distress, and in vulnerable patients it will lead to depression. Now there is a common soil hypothesis. I'd like to draw your attention to that, कि diabetes और depression एक ही बीमारी हैं. They come from a common soil. डायबिटीज की जो पैथोफिजियोलॉजी है वो भी कॉमन एक ही है और डिप्रेशन की भी कॉमन है. इसका एक बहुत इंपॉर्टेंट, एक बहुत ही फैसिनेटिंग आपको मैं एग्जांपल देना चाहता हूं. व्हाट इज द मॉडल ऑनसेट, यूजुअल ऑनसेट ऑफ टाइप 1 डायबिटीज? एज अप्रोक्सीमेटली यंग एज, एडोलेसेंट में पहली बार डायग्नोस होती है, राइट? सेकेंड टाइप 2 डायबिटीज, अच्छा टाइम तो नहीं होना सर, थैंक यू. सो टाइप 2 डायबिटीज का क्या ऑनसेट होता है? मिडिल एज, राइट? डिप्रेशन का भी ऐसा ही ऑनसेट होता है, बाई मॉडल ऑनसेट होता है. एडोलेसेंट टू यंग एडल्टहुड में पहली बार डिप्रेशन होता है, दैट इज एक पीक तब आती है, और सेकेंड पीक आती है आफ्टर द मिडिल एज. इट्स सो देयर इज अ प्यूटेटिव मैकेनिज्म दैट वन थिंग इट्स लीडिंग टू द अदर. पहले डायबिटीज आई, फिर डिप्रेशन आया, सेकेंड भी पहले डायबिटीज आई, फिर डिप्रेशन आया. So what is the putative mechanism that actually happens? So this is the common soil hypothesis. अभी तक मिली नहीं है. I am sure इस हॉल में कोई रिसर्चर ऐसा होगा तो कॉजल लिंक ढूंढ पाए. सो डॉक्टर पीयूष, डॉक्टर रूपाली और द एनी ऑफ द यंग ग्रेजुएट्स, क्योंकि इसमें बहुत टाइम लगेगा. सो कॉजेटिव मैकेनिज्म इज स्टिल ऑन द सर्च ऑफ गूगल. सो burden of chronic disease management, as we first pointed out, hyperactivity of the HPA axis. HPA axis, you all know why it's chronically upregulated in any chronic medical illness, जैसे डायबिटीज में. So ये एक बहुत ही एवोल्यूशनरी कंसेप्ट है HPA एक्सिस. फ्लाइट और फाइट रिस्पॉन्स हमने सबने पढ़ा है. इट केम फ्रॉम दैट कि द एनिमल और एनीबडी हु इज फेस्ड विद अ थ्रेट, तो HPA एक्सिस एकदम से एक्टिवेट हो जाता है. पिट्यूटरी एड्रिनल एक्सिस एक्टिवेट हो जाती है, कॉर्टिसोल बढ़ने लगता है, एड्रिनलिन आने लगती है. सो इट्स एन एक्यूट मैकेनिज्म. बट विथ क्रोनिक मेडिकल इलनेसेस लाइक डायबिटीज, इट फोकस होता है, वो स्विच ऑफ हो जाता है 5 मिनट में, 10 मिनट में. But in chronic medical illnesses or chronic stress, it fails to switch off. So chronic stress leads to HPA axis overactivation. Then overactivation of innate immunity, cytokine mediated inflammation भी बढ़ता है. And in type 1 diabetes, the burden of a lifelong disorder with an onset early in personality development. Now personality development takes place between 8 to 25 years of age. हमारी जो personality है और the brain का formation है, that finishes by 25 years of age. सो यहाँ पे अगर टाइप 1 डायबिटीज की डायग्नोसिस आ जाती है तो इट लीड्स टू फॉल्ट इन पर्सनैलिटीज. नो डिप्रेशन एंड डायबिटीज आर डबल वैमी. Okay, sir. Fine. I'll make it quicker, sir. So there is decreased self-care. Depression leads to greater body mass index, higher hemoglobin, microvascular complications. एक accord trial का I'd like to point a fact that in accord trial, you all know that it was an action to control cardiovascular risk in diabetes. Even after controlling for all the risk factors of cardiovascular risk, tobacco, aspirin use, age, sex, lipids, सब कुछ कंट्रोल करके भी depression was the only outlying risk factor that increased mortality if it is concurrently happening with diabetes. So depression was an independent risk factor which increased mortality two times. So diagnosing depression in diabetes, clinical interview still remains the gold standard, but there are certain tools which are often used. PHQ-9 आप लोग बहुत familiar होंगे. It's a very short and precise screening tool which you can use in the OPD, PHQ-9. It was first developed in a collaboration with Pfizer. I'll now come to the managing of psychosocial diabetes. How do you manage? So screening instruments are PHQ-9, anxiety के लिए GAD-7 use कर सकते हैं आप. Eating disorders are less frequent but still growing phenomena हम देख रहे हैं अपनी OPD में भी, psychiatric OPD में कि eating disorders बहुत आ रहे हैं, especially in the adolescent. So all of that talk that going back to our roots, जो दादी नानी के वाला खाना खाते थे, that is not possible now, because the world has changed, the world has moved on. जो भी आप जितना भी advice करोगे, that will not going to be happening very anytime soon. Cognitive function के लिए MMSC, diabetes distress scale, it's a very elegant instrument. Fear of hypoglycemia scale, hypoglycemia fear survey. So we have discussed diabetes distress, psychological insulin resistance. I think for the lack of time, maybe we can discuss it after this session, during lunch maybe. So I had a few slides for motivational. Give me 1 minute, sir.
1 or 2.
1 minute, just I'll take 1 minute. So I'll introduce you to the concept of motivational interviewing. You can read about it. The wide literature is available. Any behavioral change, this is the best technique. If you want to introduce your patients to physical exercise, this is the best technique. If you want to stop alcohol or reduce alcohol, this is the best technique. If you want to change his diet, oil कोई भी introduce करना है, motivational interviewing के through कर सकते हो आप. This is the only validated, not the only validated, but the best evidence इसके लिए है motivational interviewing कैसे होती है. So when the patient comes to you, he might be in a stage of pre-contemplation, contemplation, preparation, action और maintenance. हमारा कोई भी habit change होती है, behavior change होता है, हम इन stages के through ही जाते हैं. First we think about it कि मुझे change करना है, मुझे exercise करनी है. Then contemplation के time वो आपके पास आएगा, how to do it. Contemplation stage में he will come to the physician. Then prepare for changing the habit. Then he takes action and then he maintains. So these are the stages of change for any habit. आपको अगर personal habit भी change करनी है, you will have to go through these mechanisms. So it's a patient-centered counseling style to elicit behavior change by helping patients explore and resolve ambivalence. I'll come to an example and I'll finish then. So what you do, for example, you want to introduce a statin to the patient, and he has read on the Google that statins are not beneficial to the health and it might cause some kind of side effects. So he will say, I don't want to take a statin because they cause too many side effects. What will you do? You will reflect his core concern. It sounds like that you are saying that a statin medication might make you feel worse, so you don't want to start taking it. जो वो कह रहा है, उसको अपने words में आपको फिर से rephrase करना है. Here you saying that a statin medication has the potential for causing side effects, which might be more important to you than the benefits of taking statin. तो आपने एक discrepancy वहाँ पे add कर दी कि आपको statin नहीं लेना है because जो उसके side effects हैं वो आपके लिए ज़्यादा important है rather than the benefit that the statins are giving you. So आपने discrepancy उसके thought process में add कर दी. Would it be okay if we talked about this for a minute? You take the permission to explore further. As we have been doing, paternalistic style will no longer work. You would not say, well, statins are very effective at preventing a future heart attack or stroke and the side effects are usually mild. Most of my patients do very well taking statins. हम सब यही करते हैं. We have a paternalistic attitude because of the lack of time, or maybe we do not know better कि what is the alternative method. तो आप बस patient को दवा दे के ये बोले कि आपके लिए अच्छी है, he will not accept it. He will go to another doctor, especially in a metro like Delhi where doctor shopping is so prevalent. The key is not to oppose or confront, but to roll with it. Patient के साथ roll करिए, उसको resist नहीं करना है, confront नहीं करना है. So with this, I think my time is up, and I'll end, and I'll be happy to answer any questions of yours. Thank you, sir. Thank you for your patience.
Thank you so much for generating so much of interest in the psychological aspect of diabetes. We'll take the questions at the lunchtime.
Now coming to the next topic of the day, common pitfalls in diabetes management by none other than Dr. Vinod Mittal, sir. He is a senior consultant diabetologist and head Center for Diabetes and Metabolic Disease, Delhi Heart and Lung Institute, New Delhi. Director, Delhi Diabetes Center, New Delhi. Past General Secretary, Delhi Diabetes Forum. Past Chairman and Secretary, RSSDI Delhi Chapter. And he is a regional faculty for CCE BDM, Certificate Course for Diabetes. He has received many honors and awards such as National Award for Excellence in Diabetes Care 2018 during RSSDI. He is a regular invited speaker in various key national and international conferences. He is a principal investigator in several research products and trials and has several publications in peer-reviewed journal and chapters in various books. Over to Dr. Vinod Mittal, sir.
Very good afternoon, everyone, and just a moment. Yeah, so probably this should be a very interesting talk, and we've been doing, we've been managing diabetes day and night for last so many years. There are certain pitfalls, as per the literature, and there's so many mistakes and errors we do. So I would be just taking you through small mistakes which we do and how we overcome these. Now, if we see the diagnosis, we all know the criteria, but how many times we really look into it that, for diagnosing whether the patient was fasted, for 8 to 12 hours or 14 hours or not. So this has to be confirmed. And on the day of fasting, the patient should not have done, any exercises or taken any coffee or, other things. So this is one important thing before we diagnose, like for fasting, if we take fasting into consideration. Postprandial is not that reproducible. So postprandial is less important than fasting for the diagnosis. This is the second point which has to be understood. And the third point is HbA1c is the least important, because HbA1c varies depending on number of factors I'll be telling you. So the important thing is, for diagnosis, fasting is more important, and we have to see to it the patient is actually fasted. And then postprandial is not preferred unless until there are unequivocal values beyond, Now HbA1c, I will tell you in my next slide, is not that specific and sensitive near 6.5. I'll just show you this slide. See this. Now here, not working. So we can see here, 6.1, the sensitivity is 81 and specificity again 81, but at 6.5 it is just 65. So if we diagnose diabetes at 6.5, we would be losing many patients because it is less sensitive. So this is a point to be understood, that for diagnosis of diabetes, A1C is not that important. Now, coming to even one thing which I wanted to convey was about GDM. Again GDM, now this is as per literature, which one to follow? We have DIPSI. DIPSI says no need to fast, 2 hours value more than 140. Simple, one value. That is sufficient, and we can do the test later on. O'Sullivan criteria, 100 gram glucose, 4 values. And IADPSG, 75 gram and 3 samples. So there is a confusion. So which to follow? but probably we should follow DIPSI guidelines. And then stress-induced hypoglycemia. Once patient comes to us in emergency with infection, sepsis, more than 180, we diagnose. But do we ever confirm whether it is stress-induced or it was basically a pre-existing diabetes or which was unmasked? So we can do HbA1c, but HbA1c may not be. So after 3 to 6 weeks of diagnosis of stress-induced, we should confirm this, whether patient is having a pre-existing diabetes or it is stress-induced, which we are missing generally. Now coming to classification, yesterday also, whatever classification we have, it is really not sufficient. Type 2 means we do anything for all type 2 diabetic patients. No. There should be some clinical basis, means like there are 5 clusters as we were talking. So whether patient is having insulin deficiency predominant or insulin resistant predominant, or it is a mild age related and other clinical features. Depending on that only we can plan, because if there is a severe insulin deficiency, then the chances of CKD are very high. If there is a severe insulin resistant diabetes, then the retinopathy are very high, and if it is resistant, then CKD are very high. So if we know in the day one, it is a kind of precision medicine, based on clinical grounds, we can plan, we can prevent future retinopathy or CKD. So this is important thing to understand. Flatbush diabetes. Again, type 2 diabetic patients coming in emergency, DKA, maybe young child, and we think it is type 1. It is not type 1. It is actually type 2. Glucotoxicity, A1C is high, but C-peptide levels are low because of glucotoxicity. Try to understand. So never be in a hurry to diagnose. Even type 2 can present with diabetic ketoacidosis, and C-peptide levels may be low. So we should repeat after a couple of weeks. We should manage this patient with insulin, but this is type 2. Then double diabetes. Type 1 diabetic patients later on develop insulin resistance, and they need metformin. A lot of patients. In today's world, when they're living for a longer time, we're giving only insulin, we never bother for other features. They develop dyslipidemia, so double diabetes. MODI, again, it has been discussed today. So, basically, the clinical history taking is very, very important. Never go just one, type 1 and type 2. No, we have to differentiate further. Then clinical history. Whenever patient has, say we start a patient on metformin or acarbose, anything which goes wrong is the medicine, because patient also says, sir, it is, since when I've started, it has increased. But do we ever bother to find out whether there's an irritable bowel syndrome, whether patient has other alteration of, autonomic dysfunction of GIT? So maybe patient has other problems associated, which we are not finding out, and accordingly we should manage. We should not stop medication straight away. Then we always talk of HFpEF, but are we taking proper history? A small pedal edema, a small shortness of breath, a small fatigue, easy fatigability itself is a feature of. So these are small shortcomings and errors and mistakes which we do even in history taking. Then intercurrent illnesses, we are generally again not concerned on that, and other medications, steroids, antidepressant. We had a talk on depression. If patient has depression, patient is on antipsychotics, and antipsychotics themselves increase appetite and can lead to diabetes. So that's an important point. Thiazides. So intercurrent illnesses, other medications, very, very important. Do we take into consideration? Never. We just see sugar and start. So what I want to convey, that these are important things to be understood and to be taken into consideration. Sweeteners. Sweeteners can lead to gut microbiome dysbiosis. We just feel that they only decrease calorie, and sugar. No. Gut dysbiosis themselves, and it has been seen that excess of sweeteners can induce weight gain, can increase weight, and gut dysbiosis. So this point is another one which is to be taken into consideration. Then clinical examination. Again, very, very, subtle features of insulin resistance which we make. Skin tags. I think, acanthosis nigricans, we all, remember, understand. We never check for it, but skin tags, again, very small, and it is a sign of insulin resistance. Weight circumference is never measured. Peripheral pulses are generally missed. Carotid bruit, renal bruit, which we used to be taught examination. it's not that, do, everything, take with the instruments or tuning fork. Just inspection. Ask the patient to take out the socks and just inspect. And take my words, you will diagnose many things. Fundus is, I think, a kind of a forgotten thing. So basically, now coming to targets. Now, again, less than 7% for everybody. Is that correct? No. Young patient, less than 6.5%. Middle-aged, maybe 7%, and elderly, 8.5%. So they have to be individualized. Other important point is fasting and postprandial. All patients, 80%, 90% do only fasting, and they feel very happy, 120, 130. Postprandial is generally missed, so we should emphasize. It is not only fasting or postprandial, it is basically even glycemic variability, which we are missing today. Patients who have normal A1C will still can have cardiovascular complications. So we are missing on that, and we can do AGP, Librepro in some patients. I'm not saying, see, what I want to convey to you today is that they are not mandatory, but they can be done in patients who require it. They will be done only once we think on those. Comprehensive have to take care of other things. Diet control has to be individualized. Again, young patients, GDM, renal transplant patients, acute MI, we have to be very, very stringent and strict. Now coming to treatment, lifestyle modifications, we have, n number of 2-3 talks. I told yesterday also, Look Ahead trial was for 8 years. Intensive lifestyle modifications, 1 year, very good results. Second year, it came down little, it increased. 4 years, there was hardly any difference in the weight, in A1C. Both the things, there were not much difference. That lifestyle modifications are important, the main cornerstone. But we should not forget that there is a metabolic. Take little extra calories, you tend to gain weight. Exercise, do we ever ask the patient for cardiovascular evaluation? There's so many deaths occurring, like what I want to convey, this is very, very important. We should do a cardiovascular risk assessment in all type 2 diabetic patients before advising exercise. And then diabetic peripheral neuropathy, diabetic foot. So these are important. We just say 40 minutes, 50 minutes. Everybody is saying, 50 minutes, 40 minutes, strengthening. But do we ever look into consideration that who and in whom and how much? So that will vary. Then isometric and isotonic, both are important. Just walking is not sufficient. Strengthening is also. So excuses are there, but I think we should come out of these. Now coming to treatment. Now, this we all know, as per ADA 2022 guidelines, that if patient comes the day 1, it is lifestyle metformin, and then SGLT2, GLP-1, if CKD, heart failure, and CVD. But, and other category, if it is not there, then any of these. Now, important point is, what we're doing is a sequential treatment today. Means, lifestyle metformin, wait for 3 months, then you add another agent. Combination treatment, only when A1C is high. As per AAC, more than 7.55%, 2 agents, 9%, 3 agents. Then only, otherwise, only monotherapy to start with and add another one after 3 months or 6 months. Now, point is that in times to come, take my words, we can note it down today. In ADA 2023 guidelines, maybe we have a recommendation with lifestyle, a dual combination in all the patients, because verify study, metformin with vildagliptin, even in patients who had A1C 6.5, patients who are even having 6.5 A1C, metformin, vilda was given, verify study, and it showed robust, sustained, not only control glycemic variability, as well as a durability. We are not concerned about durability. We start, we add, we take care of durability? No. That's an important point to be understood. So ADA ESD 2013, maybe lifestyle with dual straight away. Metformin, SGLT2, DPP4 or GLP-1 straight away, because we are not targeting A1C. We are now kind of giving treatment to protect cardio-renal axis, because most of the mortality in diabetic patient is cardiovascular and renal. So that's an important thing. A1C is important. A1C we can control with a lot of agents. But are we targeting? So day 1 only, along with A1C, we have to control. And maybe, now this is maybe, that metformin may be kept way behind. Not for India I'm talking, but this is maybe GLP-1, SGLT2 or DPP-4, SGLT2. Take my words, I'm telling you, there would be some changes. There would be some changes, but today. So what I want to convey that instead of monotherapy, we can have two agents in small dose having different pathophysiological mechanisms of action. Metformin only one action. If we add DPP-4, another action, and we're giving less dose. Instead of giving metformin 2 grams, why not 1 gram of metformin and we give DPP-4 and SGLT2 also? Why not only 500 milligram of metformin and all agents? When we give less dose, we are making different mechanisms and better control and longer durability. Then ASCVD and DKD is okay, but CVA, stroke we are not concerned. Stroke is the next to CVD, like a part of CVD. So most of the deaths are because of coronary artery, but the next is CVA, and pioglitazone has shown a reduction in patients, even non-diabetic patients. Even non-diabetic patients, Irish study, pioglitazone is found to reduce the incidence of stroke. So this is one point again that we should see to it. We can use pio. We are not using. Once we know, we'll use. And then definitely FDC, sulfonyl metformin, AGI. Again, there is a controversy. Like we don't have studies. It is, giving 3 medications, 1 point. And the second is they have different, sulfonylurea to be given before, metformin after or with meals, AGI with the first bite, to be given with every meal. So I don't know how much rational we are. I don't know. And are we having any scientific data for this? We're just giving. So this point again is to be understood, well, and to be taken into consideration. Now, time of administration. AGI is first bite of meal, we all know. For around 15, 20 minutes or 30 minutes before meals. Metformin, again, say with the meal. Now, the point is, when multiple, medications are given, like, FDC, that this goes haywire. We don't know what is happening. You're giving before, after, whatever you think is correct. Now, inertia has already been discussed. I will not go into detail, but it is not inertia on the part of the doctor, even patient. So it is both the factors are there. Doctor, patient, it is both. And as per ICMR in-depth study, which has been completed by ICMR and, the Diabetes Association, the targets only 24% of patients on diabetes, having diabetes on OADs or any medication achieve less than 7%. So are we thinking on this? And are we having a good control even on blood pressure, cholesterol also, all 3? I don't think we have. So we have to, and time to review medication. Do we ever review? We should review time to time. Whether patient is responding, not responding, that is also important. Patient may not be responding to your medication. You withdraw that. Like pioglitazone, you give. Any patient doesn't respond in 6 weeks' time, 3 to 6 weeks, stop it. There's no point in continuing a medicine which is not required. Then timely initiation, beta cell preservation, we always say, and we all know. One point here I would like to say that sulfonylureas, I'm writing an article on this, there's a re-emergence on beta cell preservation, low dose. Low dose sulfonylureas also can preserve beta cell. So don't, very economical medication. It's not that whatever pharma-driven things we keep on doing. So basically we have to take away glucotoxicity. Then OADs, yes, one more point. Metformin sustained release is the best. Then fast release and extended release, because sustained release remains in the gut for a little longer time and there's an incretin effect. So sustained release is the best, but side effects wise, extended release is the best. Pio, we are less using. AGIs, yes, hypo is there, that you should use glucose. SGLT2 inhibitor, the only point which I would like to make, as per DCGI, more than 30 you can give, but if it goes less than 30, don't stop it. Don't stop it. Continue it, because cardio-renal benefits remain. This is the only point. Oral semaglutide, some of you must be using. There is no CVOT data today. So if you're giving oral semaglutide, it is only for A1C reduction and weight reduction, no CVOT data. Ozempic, which is an injectable semaglutide, so this is only a point to make you to understand that what we are using, has it got sufficient data or it doesn't have sufficient data. Insulin, again, there are many things, which one to use, even human insulin to be used. Again, insulin, human versus analogs. Analogs are not best for everyone. It's like government student versus, school versus, private, and they can perform. So it's all depends on the patient's compliance. So human is also as good. Basal versus premix, there are certain parameters. It's not that, you write basal to everyone or write premix to everyone. It is not there. Just 2 minutes, okay. And Somogi, dawn, and correction, those we never talk to the patient. So this is another thing, we should be. Then one more point for insulin. When patient comes to us with DKA, insulin infusion, straight away. Okay, fluid deficit and acidosis also we correct. But when we shift this patient to ward, we suddenly stop. We don't inject regular rapid acting before. If you are switching this patient to basal bolus, inject rapid acting 1 hour before or at least half an hour before you stop IV infusion. Try to understand this, and then you can. And once you start, taper it off. De-escalation is also important, when basal bolus doesn't mean basal bolus. You discharge the patient maybe on basal only. It's not that to, some homeopathy doses of premix. That's very common. And I see very homeopathy, 8, 6, premix and everything. What I want to say, individualization is very important. Basal plus maybe OADs are sufficient for some people, not for all. So patient-related factor, cost is only one, but stress has already been discussed, so I have also mentioned that's an important thing. Any chronic illness, it's not diabetes, any chronic illness will lead to stress. Then sleep is another important. It has been seen. Even the workers, night workers, they develop diabetes and OSA more often than people who are working during the day. So this is one point. If you are having inadequate sleep, your medications may not work. And education obviously is the most important. Now coming to just one note more, yeah, this is SMBG, basically, patient says, a lot of pain is there, but we should ask the patient to use hand which is not dominant hand. So maybe left hand should be preferred first, and then, middle, your second, third, fourth, and fifth fingers, because index finger and thumb generally we use for many. So, this is one point, can be told to the patient, practical point. CGMS for some patients. Dyslipidemia management, I don't think we need to discuss, but it is again important. We don't give importance. Hypertension, 1 point. 140/90 onwards, dual combination treatment as of today, not monotherapy. More than 140/90. So this point has to be understood. Then NAFLD is taken as a normal. It's a real dangerous condition. More than chronic liver disease, it's more for cardiovascular risk. These patients have more cardiovascular risk than other non-FLD. So takeaway messages are very clear that, the management, right from diagnosis, the day patient enters. Clinical history taking is the most important. Even for MODI, as we discussed, many things you will be revealed only in the history. It's an art. It has to be individualized. Diagnosis, don't be in a hurry. I've written the last. Don't be in a hurry. We want to be very smart and write on day 1 everything. No. Write query. Put query on day 1. Because once you put type 1, a lot of MODI will be misdiagnosed, and you put patient on insulin. Who will stop insulin? No one. Unless until you find other reasons. History examination, other medications, I've already told you. Associated comorbidities are very important. And then stress management and education. Education is the most important thing. And for that, a practical point, which I will tell you, all of you, is out of, say, 50 patients, say, suppose I see every day, 5 patients I do counseling. I don't do counseling for 50. So by rotation, you can do counseling for all, in some time. And updation of knowledge. So if you're not updated, or if we are not updated, we are outdated. So let's not be outdated, let's be updated. Thank you.
Wonderful talk on the various aspects of management of diabetes. But we will not take any questions. We will discuss it during the lunch hour. Thank you.
Thank you, chairpersons and speakers. I'd like to invite Dr. Vikas Kataria, Dr. Saurabh Srivastav, Professor and Head Department of Medicine at Government Institute of Medical Sciences, Noida, Dr. Ghanshyam, Professor Medicine at LHMC, and Dr. Ashish Goyal, Associate Professor, Department of Medicine, VMMC.
So I'm introducing the first speaker, Dr. Saket Kant. He is a colleague of mine. We have worked together in UCMS. He has done his MBBS and MD from UCMS, DM from IMS Banaras, and he has accreditation of MRCP also in diabetes and endocrinology. He has fellowship of American College of Clinical Endocrinologists. He is senior consultant and endocrinologist at Max Super Specialty Hospitals, Shalimar Bagh and Action Balaji Medical and Cancer Center, Delhi. He has published more than 35 national and international papers. He has published best paper in 14th ESI A.V. Gandhi Awards. He is reviewer of many journals. To name a few: Endocrinology, Diabetes and Metabolism, Journal of Medical Case Reports, Clinical Epidemiology and Global Health, Indian Journal of Endocrinology and Metabolism. He is also editor of International Journal of Diabetic Dyslipidemia. He has been a speaker, panelist and moderator in various conferences and member of various societies such as Endocrine Society, American Association of Clinical Oncologists and American Diabetes Association. Over to you, Dr. Saket, to speak on a
insulin resistance at the level of liver, decreases hepatic glucose output, but pioglitazone decreases insulin resistance at the level of liver, adipose tissue, and also at the level of skeletal muscle. So these are the insulin actions. Insulin has more to do apart from glucose homeostasis. It has a role in glycogen synthesis, role in lipid metabolism, DNA synthesis, gene transcriptions, amino acid transport, protein synthesis, and degradation. And this all forms a part in insulin resistance. So it is not only glycemia that is affected with insulin resistance, it is a whole lot of metabolic profile that is affected. Got a host of diseases that have insulin resistance: obesity to start with, type 2 diabetes, metabolic syndrome, cardiovascular diseases, MAFLD. MAFLD has been renamed to MAFLD, metabolic associated fatty liver disease now. Polycystic ovary diseases and a lot of cancers also can have insulin resistance. How did this all come up? You can see glucose clamp techniques. 1979, they started doing glucose clamp techniques for quantifying insulin secretion and resistance. And 1985, there was the first description of homeostasis model assessment of steady-state estimation of insulin resistance and beta cell function. Very busy slide, very complicated. I will not like to scare you with this slide, but the basic gist of the matter is that insulin is a tyrosine kinase receptor. When insulin binds to its receptor, there is a cascade of events that happen as a second generation effect of insulin binding to its receptor, leads to GLUT4 translocation and glucose uptake in a lot of cells. So you can have mutations or defects in the cascade itself. A lot of areas of this cascade can have effects, and you can see each cascade is doing something or the other. Some cascades are anti-lipolysis. Some are involved in protein synthesis, some are involved in lipid synthesis, de novo lipogenesis, some are affecting glycogen deposition in the liver. So insulin resistance may not be a uniform defect. If you have defects in individual cascades, only one part of the action of the insulin may be affected. If you have a defect in the cyclic AMP pathway, probably anti-lipolysis would be affected. And this is the target of treatment of and research for a lot of new things that are going to come up for insulin resistance. So the underlying mechanisms for insulin resistance, there may be a direct defect of insulin signaling. A lot of epidemiological factors may be involved, a lot of inter-organ metabolic crosstalk, because now you have adipokines, you have lipokines, you have skeletal muscle myokines. So they may be acting on each other and changing insulin resistance. Metabolic mediators, a lot of genetic mutations, epigenetic dysregulations of histones, non-coding RNAs and gut microbiota dysbiosis are also part of insulin resistance. The direct defect can be a proximal or a distal signaling defect. The proximal defect can be a defect in insulin resistant expression, the binding of the ligands, the phosphorylation of the receptor when insulin binds to the receptor, A defect in the kinase activity, that is the secondary signaling pathway. Distal downstream signaling and insulin resistance can be AKT activation defect. More than 100 AKT substrate defects are there. But one of the most important is the GLUT4 mediated glucose uptake in skeletal muscle and adipose tissue. If you look at epidemiology, premenopausal females have lesser insulin resistance because estradiol is protective. ER alpha activation in the brain, liver, skeletal muscle, adipose tissue, that basically also in pancreatic beta cells, that would basically lesser. Asians, especially Asian Indians, are at high risk for insulin resistance. That is the ethnicity difference that we have versus Caucasians. And a lot of modifiable lifestyle factors like diet, exercise, smoking, sleep and stress make a lot of difference. Sleep for less than 7 hours per day increases insulin resistance. So the ideal recommendation is 6 to 9 hours of sleep. Anything more than 9, less than 6 or 7 hours of sleep would increase insulin resistance. Again, a busy slide. You can see a lot of things happening in the liver, in the skeletal muscle and the adipose tissue, which are part of the insulin signaling. I'll not take you into details, but it's a complex mechanism and there is crosstalk between all these organs also. So what are the metabolic mediators to insulin resistance? You can have adipokines that may be dysregulated. Adipokines, cytokines, chemokines, all are secreted from the adipose tissue. Adiponectin we already knew for a very long time. There may be defects in fatty acid lipid metabolism with insulin resistance that lead to lipotoxicity. That may basically increase glucotoxicity also, and that basically becomes a loop that would increase both glucotoxicity and lipotoxicity. And diacylglycerol ceramide accumulation, again part of lipotoxicity, would increase insulin resistance. Genetic mutations are known in a lot of genes, primarily genes PPR gamma, which if you have a variant Pro112 ALA decreases risk of diabetes mellitus. IGF-1 variants also are known now, and they increase insulin resistance. And the insulin sensitivity gene also has been identified, that is NAT2. So 25 to 44% of insulin resistance may be heritable, and we as Indians may have more of these genes as compared to Caucasians. A lot of epigenetic dysregulation also may be there in insulin resistance, DNA methylations, histone post-translate modifications, microRNAs and long non-coding RNAs may be involved in the pathogenesis. A recent thing of interest in insulin resistance recently has been the gut microbiota. A lot of drugs also change gut microbiota. AGIs that basically we use a lot in our clinical practice also alter gut microbiota towards better microbes that decreases insulin resistance. Now, the gut microbiota is a contributor to host metabolism and immune function. They release metabolites and cytokines. Gram-positive firmicutes that are the good microbiota, and diet, sleep, exercise, antibiotics can alter this. Again, exercise, diet and medical nutrition therapies everywhere. And again, sleep 7 hours, you can increase your gut microbiota. So it is not the number that is important of gut microbiota, it is the diversity that is important. You should have all of these in your gut microbiota so that you can have better results. Lot of disorders can be associated with insulin resistance. We all know, I already discussed all of these. What are the clinical markers of insulin resistance? BMI, accrued marker, central adiposity, cancers nigricans, skin tags. In fact, skin tags more than 3 in an individual is a marker for insulin resistance. How do you evaluate insulin resistance otherwise? There are measurement methods for insulin resistance, the glucose tolerance test, ITT, that is insulin tolerance test, and the hyperinsulinemic euglycemic clamps. The surrogate markers are HOMA2, HOMA-IR, GIR, quickie. I will not go into the details because cumbersome, and you can easily calculate, and insulin sensitivity is won by insulin resistance. 2.6 is the cutoff value for HOMA-IR that basically suggests that the patient may have insulin resistance. But you have to be very careful because this data, you should have data for ethnicities, and it changes with age, it changes with puberty, it changes in the postmenopausal state. Quickie and GIR is quantitative insulin sensitivity check index to achieve a decent glycemic control, the amount of insulin that is needed. The therapeutic strategies, we already use metformin, decreases glucose production, increases glucose use. You have insulin that can circumvent insulin resistance by using high doses of insulin. That can decrease glucotoxicity, lipotoxicity. PPR gamma agonists, they increase insulin sensitivity at the level of liver, muscle, adipose tissue. You've got sulfonylureas, meglinotrides that stimulate insulin secretion, decrease glucotoxicity, GLP-1 receptor agonist, also doing the same thing, DPP-4 inhibitors. You've got some drugs acting on the brain, bromocriptine, that's a D2 receptor agonist, that would reduce hepatic glucose output, increase glucose disposal, and a combination of drugs, if you use very early, that is going to make a lot of difference. The pivotal thing is lifestyle modification. Physical exercise, blood, healthy dietary pattern are the pivotal things that you can do for decreasing insulin resistance. Pharmacotherapy comes after that. So dietary modifications have to be there that we recommend to all of our patients with type 2 diabetes. Even with pre-diabetes, they are the most important. Exercising for at least 150 minutes per week with no 2 days consecutive without exercise, and at least 2 days of muscle strengthening exercise is what would decrease insulin resistance. A recent study also said that probably we are somewhat different from Caucasians, and 150 minutes may not be sufficient for us. It is 300 minutes of exercise per week that has to be done for Asians and Indians that would benefit us as compared to Caucasians who do well with 150 minutes of exercise per week. A 5 to 7% weight loss in obese and overweight subjects would decrease insulin resistance. And in fact, if you look at the recent data, 10 to 15% weight reduction in patients with early type 2 diabetes can put them into remission. There is nothing like reversal of type 2 diabetes because you can have only a remission of glycemia. You cannot reverse the complication, you cannot reverse the bad glycemic legacy that the patient may have. So weight loss, diet, exercise are the pivotal treatments of insulin resistance. Metformin we've been using for decades and decades together. It increases insulin receptor tyrosine kinase activity, enhances glycogen synthesis, increases the recruitment and activity of glucose transporter GLUT4. That is the final pathway of glucose entry into the adipose tissue, skeletal muscle and the liver. It promotes re-esterification of free fatty acids and inhibits lipolysis, that is decreased lipotoxicity. So it is decreasing both glucotoxicity, lipotoxicity, as also enhancing the utilization of glucose. Glitazones, that is what I was talking about. De Fronzo has said that probably glitazones should be above metformin as far as decreasing insulin resistance is concerned because they alter insulin resistance in the liver, adipose tissue and the skeletal muscle. They induced altered expression of a lot of genes including GLUT4 and adiponectin. They decrease inflammatory cytokines, they increase leptin, and they enhance adipocyte lipid storage, decrease ectopic lipid accumulation, that is important for a subclinical state of hypercortisolism in a lot of patients with type 2 diabetes, and they improve insulin sensitivity in liver and skeletal muscles. Other drugs, GLP-1 receptor agonist, they suppress the inflammatory response of macrophages, inhibit decrease insulin resistance. DPP-4 inhibitors, DPP-4 enzyme is a local mediator of inflammation and insulin resistance in adipose and hepatic tissue. So when you inhibit DPP-4 with these inhibitors, you can decrease inflammation, and then SGLT2 inhibitors, because of their benefits in weight loss, would also decrease, because of the decrease in weight, as also decrease in glucotoxicity would do the trick. Sulfonylureas basically promote insulin receptor activation. You have more glucose transporters that also increases insulin sensitivity, and a PPR alpha gamma delta PPR full agonist, chigletizar sodium, is also in trials that would also induce expression of downstream target genes related to insulin sensitivity, fatty acid oxidation, lipid transport, and inhibit phosphorylation of PPR gamma receptors associated with insulin resistance. Some other drugs that may be in the pipeline and already in trials, the anti-FGFR1 antibody, short-term weight loss, increase in insulin sensitivity, chromium picolate, lowers glucose and insulin levels, salicylates, they basically decrease inflammation, improve insulin sensitivity, and symbiotic therapy or gut microbiota therapies are also in trials. A lot of clinical trials for a lot of drugs you can see in patients with type 2 diabetes and metabolic syndrome, fatty liver also, to decrease insulin resistance, including taurodeoxycholic acid, ezetimibe, dapagliflozin, pegvisomant, that is propranolol, PPR alpha gamma dual agonist. We already have the saroglitazar as the dual agonist. Look at gliptins also, muscle resistance, hypertrophy, strength training, SGLT2, heat shock proteins, insulin exenatide, lactobacillus that I was talking about, and the exercise plus the probiota are there in trials. Probably we'll have more data on this, but all of these are in rat or mice models for now. Some in obese mice, important in pathogenesis of many chronic diseases. It has got multiple mechanisms, as you can see, receptor, post-receptor mechanisms, and it can differ. It can be very varied. It can be different at the level of liver, skeletal muscle, as also adipose tissue. We'll get more insights as like metformin. You have pioglitazone, GLP-1 receptor agonists, some trials on gliflozins, and some trials on sulfonylureas. But many of the drugs are in the pipeline. But still, diet, exercise, with reduction of 5 to 7% weight loss has to be the cornerstone of treatment for insulin resistance. Decreases conversion of pre-diabetes to diabetes, and many times can put patients into remission for type 2 diabetes. Thank you very much for the patient here.
Thank you, Dr. Saket, for completing the talk very well in time. I think there must be many questions, but because of time scarcity, we will just take one question if anybody is there. Or we can ask just, like there are a lot of literature that Asians has more abdominal adiposity. So is there any specific exercise, especially for abdomen, which can decrease this thing, or any other treatment which you would like to give?
As Indians, we have more central adiposity. We've got sarcopenia, that is also a component of... we've got more central adiposity as compared to Caucasians. We have more sarcopenia. Now, a combination of sarcopenia, thinner limbs, and central adiposity is very dangerous because it induces a state of subclinical hypercortisolism. So, central adiposity is a state of subclinical hypercortisolism, and we know that cortisol, a hypercortisolic state, would basically increase insulin resistance. That can be at the level of liver, skeletal muscle, as also adipose tissue. So, no specific exercises for that, but probably weight reduction would do the trick for you. But that has to be combined with strength exercises also to increase muscle mass and increase uptake of glucose into the skeletal muscle.
Thank you very much, sir. Then I would like to invite our next speaker, Dr. Jagdish Hulchandani, sir. Dr. Jagdish, sir, is postgraduate from AIMS, and he is a private practitioner running his own center. He is an investigator in several national and international studies and published papers at RSSDI and JAPI. He also runs a non-profitable charitable trust which provides free medical care and medicines to poor people. Thank you, sir. Over to you.
At the onset, I'll thank the DDF for inviting me, and it's a privilege to be here. Dear friends and chairpersons, and the respected speakers, and all the dignified invitees, I'll just be taking about 15 to 20 minutes. I probably am standing between you and lunch. I think the session has been delayed by almost 1 hour, but try to make it interesting for you. So we are looking at a new drug, which is oral semaglutide. Many of you must have used it also, and I'm sure that this drug is a new innovation in the treatment of diabetes. However, it may be expensive, but we are here to discuss the merits of using these drugs, and wherever we can use such drugs to manage diabetes in a manner that it should be these are the financial disclosures. So we are looking at a new chapter in the treatment of diabetes, where oral GLP-1 has been innovated. It's a peptide in a pill. So my talk will be in 3 portions. One is the role of GLP-1 as such, a receptor agonist in the past, in the treatment of diabetes, pioneering a new era, which is about oral semaglutide, and then pioneering the management in routine clinical practice. That means how to actually use this molecule, where to use it. So when we are looking for a anti-diabetic drug, we know that it's a very difficult situation. Either we control almost to the very ideal control, or we let it go. So many of my patients, it will go into hypoglycemia. So most of the drugs, as we started as students, I think way back, when we had only sulfonylureas and metformin, and then add on insulin. So at least 2 of these molecules were producing hypoglycemia, and there was defensive eating, and obviously there was weight gain, and this added to the inflammatory markers, it added to the cardiovascular morbidity, and at that time the control was only about blood sugar and HbA1c. Now things have changed ever since, over the last about 1 decade or even more actually. After in our country, we were using liraglutide once a day, and we were also using the GLP-1, the dulaglutide once a week. That is, we are using Trulicity for last about 5 to 6 years. It has, various effects on the body. You can see the spectrum. And liver, it improves the glucogenesis. It has anti-inflammatory effect on the heart, and it protects your heart. It has a reduced satiety and weight reduction by working through your brain. Again, in pancreas, there is a glucagon secretion is suppressed, and there is beta cell stimulation, and gastric emptying is delayed, so that the satiety is there. And of course, there is also beneficial effect to the kidneys. There is natriuresis and nephroprotection. 12% relative risk reduction in the previous two receptor analogs, Trulicity and liraglutide, which was the leader trial. And then again in the muscles, there is also improved insulin uptake. So we see that these drugs not only in a nutshell, they decrease the HbA1c much better than compared to most of the previous molecules. They have significant weight reduction. That means they do not cause any weight gain. On the contrary, they will lead to weight reduction, and they can be given as starting with metformin and with other OADs, and you give it early, the results were always better. And only thing was these molecules have been expensive ever since their advent, so they have not seen too much of clinical experience in our part of the world, because these are the molecules which are rampantly used in the Western world. In our country, the main constraint is the cost. So we have seen that GLP-1 receptor analog, they reduce HbA1c, they reduce the weight, and they also reduce the pill burden, but also reduce the cardiovascular outcomes, as we will see. And we have seen many of these presentations before. Today we are going to talk mainly about the challenges are big. Most of the patients, till now we have a lot of presentations about insulin and about injectables, but still there was a survey done, and almost 3/4 of the patients were not in a favor of taking injectable therapy. So that's a big challenge, and if we see that it makes the life inconvenient, and the QOL, the quality of life, is a very important factor for treating any diabetic. So if we are trying to replace the injectable therapy with the oral, say let's say we replace liraglutide with the oral semaglutide, I think it will be a welcome step for many patients, and most of them will be accepting, because the cost is not very different. So the second part here, of course, the rationale for delivery of oral peptide is it improves the compliance, and also the better outcomes are there, as we see in the future slides, where we see the CVOT outcomes, and it is obviously better than subcutaneous injections. So quest for the first oral is hampered. The GLP-1 absorption was also poor, because there is enzymatic degradation. The permeability is limited in the gut, and there is a low bioavailability. So all this was tackled, and there was an innovation called SNAC, which was attached to these oral tablets, which would not only better the absorption of the pill, but it will also stop the destruction in the gastrointestinal tract. So semaglutide was there were 3 changes were made, and there was substitution at 8th amino acid and 34th, and this could actually they were given to protect against the DPP-4 tablet, and the absorption of the semaglutide will take place, although low, but sufficient enough to get the required result. So this SNAC was attached to this in a way. You can see here, this is a semaglutide which is almost similar to the human GLP-1 analog, and all that we need is that it should remain in the intestine for a long time, and it will give us the effect of insulin secretagogue through the whatever mechanism it works in the pancreas, and also it has got other pleiotropic effects. So this was a breakthrough, and what they said was a path-breaking innovation, which was worth a Nobel Prize for this innovation. And this oral peptide is one phase 2 trials and 10 pioneer trials already on. They've been finished, and a couple of them are on, and 9,500 patients are. So what we have seen practically in our own experience, whatever little sitagliptin, and it has been compared to empagliflozin, and it has been compared to liraglutide, the HbA1c reduction, the weight reduction is much superior, and cardiovascular safety has been shown in SUSTAIN 6 and PIONEER 6 trials, And again, there's another trial, SOUL trial, which is looking into a cardiovascular. But simply, tell the patient to wake up in the morning and take a 3 milligram pill to start with, and then, get rid of any side effects they started with 45 minutes. And you start with 3 milligram, then you switch on to 7 milligram dose, and then after that you give a 14 milligram, which is the full dose, which can be add-on molecule after any agent, after SGLT2 inhibitor. And if the patient is on DPP4 inhibitor, you stop the DPP4 inhibitor and put the patient on semaglutide. There's a superior weight reduction, HbA1c reduction. Oral semaglutide did not increase the CV risk, and whatever studies we have in the future, they'll tell us if there's a stroke benefit or a cardiovascular benefit. After the SOUL trial is published, then again, there's it's an oral drug, so it also doesn't have much of excretion through the kidney, so it can be used in a mild to moderate kidney disease. Summary is it is the most effective drug for reduction of HbA1c, except for insulin and sulfonylureas, which are the two potent drugs which we still continue to use because of their cost, because of the benefits with the insulin and the sulfonylurea. But if a patient is having a BMI of more than 26, patient has a high cardiovascular risk, the drug will be ideal for using. The pioneer trials 1 to 10 have actually given us a lot of insight that there is 1.5% reduction in the HbA1c, and it could be 2.5 or more. That it has a reduction, overall reduction in the CV mortality, and the reduction was also in the all-cause mortality. But the benefits of CV benefits have to be established, which we are waiting for the SOUL trial, and the efficacy of semaglutide when given early in treatment. It could be in a young patient who is actually obese and who is having a bad history of their family history of cardiovascular disease. He is having a high base circumstance, and he also has dyslipidemia. These are the patients should be initiated, with if they can afford with these kind of therapies. So I think beyond that, if there are any questions, probably they'll be taken up in the end. So at this stage, I'll hand over the mic to the organizers.
Thank you, Dr.
very much
Jagdish.
for your patient
Very
hearing.
well summarizing the new drug semaglutide. These pioneer sustained studies as well as SOUL, Lady Harding Medicine Department is also part of a few of those studies, and SOUL is also ongoing. As we have already going late by 1 hour, we'll close this session. Any question you have, you can just join sir in the lunch. Lunch is on the first floor, I think. We all can join for lunch. Dr. Ashok, we'll hand over the mic to you.
Thank you.
Thank you both all the chairperson, and thank you both all the chairperson and both the speaker. Thank you for having the session here. And now I'll request to you to proceed for the lunch, which is at first floor. Dr. Anil Chaturvedi sir. Sir is Chairman, Preventive Health and Lifestyle Diseases, Goel Hospital and Urology Center, Delhi. And sir has received a V. Parmeshwar API Lifetime Achievement Award 2019 National BCI Award for his eminent personnel, and he has received many awards to his credit. I also invite Dr. Hemant Saluja sir. Sir is Senior Consultant Physician at New Delhi and Delhi Diabetic Forum Executive Member. So I request the chairperson to kindly introduce.
Hello, good afternoon, distinguished delegates and illustrious chairpersons and speakers. We come to the next post-perennial session, and the very apt and appropriate topic has been chosen for this, and that is the post-perennial glycemia controlled by Ripaglide. And there is no other person better to speak on the subject than Dr. Amit Gupta, who is a Director, Center for Diabetes Care, Greater Noida, member of Advisory Group, American Diabetes Association, advisor to Public Health Epidemiology, Executive Council member of the National RSSDI ACP India Chapter, Joint Secretary, Diabetes India and UDPA, Executive Editor of Sadikot International Textbook of Diabetes, publications, more than 40 international and national publications. He is a program coordinator for RSSDI Save the Feet, Keep Walking. Most successful diabetes campaign, 2021 ACP India Chapter Community Teaching Award, Times of India Health Icon Award, National Health Award, Investigator of the Year Award, and Padmaka Tripathi Young Scientist Award. Let's hear what Dr. Amit Gupta has to say about post-perennial hyperglycemia, and I am sure he will keep you awake. You will not have any post-perennial hyperglycemic effect with this talk. Thank you.
Thank you, sir, for the very kind introduction. And I think organizers have very thoughtfully placed the session post-perennially so that we can discuss about the post-perennial hyperglycemia. And at the outset, I would like to thank my friend Dr. Ashok and Dr. Anupam Prakash for inviting me for this conference. And respected chairpersons, with your permission, I would like to proceed with my talk. So today we are going to discuss post-perennial hyperglycemia management with Ripaglide. So to begin with my talk, I would just like to ask, so many learned doctors are sitting here. So how many of you are exactly using Ripaglide in your clinical practice? So any show of hands here? So very less. So that is quite right also, because this is one of the molecules which is not very often used in clinical practice. Most of the guidelines, they don't talk about it. And it doesn't find any mention. And even in the textbooks, you will just find a passing remark about this molecule, and it is left to further reading. So I think organizers, they wanted me to highlight more about this drug and just to bring about the pharmacology and pharmacoscience of this medicine. So we all know that the post-perennial hyperglycemia is really a challenge in Indian context. We just had a lunch, and if you just look at it, you will find that it is always carbohydrate centric. You had so many things which were placed there, and most of them were carbohydrate centric. So our diet is inherently rich in carbohydrates. So whether it is any part of the India, and a lot of studies, they have proven that the carbohydrate content of our diet can vary anywhere from 60 to 70%. And this may be a contributing factor to the post-perennial hyperglycemia. So I would just like to highlight, clinically classify our patients into 4 categories. We know that we may be having a simple patient who is having elevated HbA1c as well as the fasting plasma glucose as well as the post-perennial glucose level or the random glucose level. The second category is that we frequently see, you will find that somebody is having a good fasting control but is not having an adequate PPG control. Opposite can also happen. Somebody may be having a good PPG control but elevated fasting glucose, and somebody may be having a very good fasting as well as the plasma, as well as the PPG control. So this slide we will go again to refer to again when I will talk about the mechanism of action of the Ripaglide, but this is how the insulin is secreted, and I think it has been discussed many times, so we will not go into detail of this. So receptor which is different from the SU receptors, and this is again ATP sensitive potassium channel. Also, there is a closure of the ATP-dependent potassium channel and the influx of the calcium leading to the exocytosis and the release of the insulin. So, one of the basic difference between the sulfonylurea and the Ripaglide is that the sulfonylurea, once given, it will cause sustained release of the insulin as long as it is there. It is not glucose dependent. But the Ripaglide, as levels tend to fall, then the Ripaglide actions also fades away. And this is how it is short acting, and the chances of hypoglycemia are relatively less than the sulfonylureas. So the action is glucose dependent, it is having high potency, elicited insulin release is rapid and brief, and taken with meals for the postprandial hyperglycemia. It is advised to take 30 minutes prior to the meals, and it also reduces the risk of the long-lasting hypoglycemia in patients. As we have seen that there is a distinct binding site at the beta cell membrane, there is a greater insulinotropic effect than with glibenclamide and or glimepiride, and a more rapid onset of the action, and the greater stimulation of the insulin release, and the effect were glucose dependent with increased insulin levels being a transient effect, whereas reduced blood glucose persisted for a longer duration. So it is a glucose and dose dependent insulinotropic effect which is seen with the repaglinide. Other benefits, because of the HbA1c improvement, beta cell function may be preserved and improved, restores early phase insulin secretion and improves PPG, and reduces lipolysis also, and there is a rapid onset of action and short-lived hypoglycemic effect. This is the pharmacokinetics of the repaglinide, and absorption, it is completely absorbed and rapidly absorbed from the GI tract, and the Tmax is 1 hour, and bioavailability is around 56%. Distribution, it is protein-bound drug, and protein binding is almost 98%. Metabolism, it is completely metabolized by the oxidative biotransformation and direct conjugation with glucuronic acid, and the CYP450 enzyme, mainly CYP3A4, plays an important role. And the elimination is most eliminated in the feces, and urine 8%. The T half is around 1 hour. So it can be used an adjunct to diet and the lifestyle modifications to tackle the problem of the postprandial glucose, or it can be combined with any other drug also which are available for the management of type 2 diabetes. So this is how the repaglinide is placed. The contraindications, it should not be used in any patients with type 1 diabetes, any patient who is having diabetic ketoacidosis with or without coma, or if there is any sign of hypersensitivity to repaglinide or its ingredient, then this drug is contraindicated. There is no fixed dosage regime. The doses can be started as low as 0.5 milligram and can be in a one single meal, it can be given up to a doses of 4 milligram. And the maximum tolerated dose in a day is 16 milligram per day. So you need to titrate the doses. One of the important thing is that whenever we give repaglinide, the dose titration, at least you should wait for a week or two before you titrate the doses. Rapid titration is not advisable. And the patient which are, as we have already seen the indications, so doses we start with 0.5 milligram with each meal. Initial dose 1 to 2 milligram with each meal if the HbA1c is more than 8%, and the starting dose and the dosage adjustment for combination therapy is required as whenever we are using it in combination with the metformin or any other drug. A special note about the renal insufficiency. If there is a mild to moderate renal dysfunction, no dosage adjustment is required, but if in patient with severely renal impairment, doses of 0.5 milligram is something which is advised. However, the patient with end stage ESRD, there are no studies which are available to support or disapprove the use of repaglinide. So it is important to note that repaglinide is a drug which can have multiple drug-to-drug interactions, so we need to keep these interactions in mind. Most of these interactions are benign in nature because they don't cause any major issues, but they may lead to fluctuations in the blood glucose level because of the up titration or the down titration of the CYP3A4 enzymes, which can lead to changes in the metabolism of the drug. But one of the indication which is important is that is with the gemfibrozil, I think, which is not available and we are not using it. So it is not a very common drug which all of us use. But this is something that itraconazole and gemfibrozil, they have a synergistic inhibitory effect. So patient taking these drugs should not receive itraconazole. These are the adverse reactions with repaglinide, and these are the adverse reporting system which almost all these kind of side effects may be seen. But the in the real clinical setting and the renal clinical world, those who are using, they know that most of these side effects are very rare and not seen very often, but still we should be aware of all these side effects of the repaglinide. So precautions, as far as pregnancy is concerned, it is not indicated in pregnancy. Lactation, it should be avoided in lactation. Children, no safety and efficacy has been established, and in elderly particularly, we should be more cautious about the hypoglycemia, and we should use the dose with precautions. In hepatic function, anybody who is having hepatic dysfunction, it is advised that the dose should not be titrated very rapidly, and at least 1 to 2 week period should be waited before you increase the dose. Hypoglycemia can happen with this drug also, but we need to be aware about that, and we need to guide the patient properly. Not many clinical trials are available, not many studies are available, but whatever is available, that one thing is that is established that it is CV safe, may not be CV beneficial, there is nothing to support that. But one Danish registry, large number of patients shows that repaglinide is associated with a lower cardiovascular risk than other insulin secretagogues. Also, if you look at the tolerability as compared to the sulfonylurea, the side effects like diarrhea, back pain, bronchitis, sinusitis, headache, URT, and hypoglycemia, so they are relatively less than with the sulfonylurea drugs. So where do we place repaglinide in the therapy? In managing hyperglycemia in patients with type 2 diabetes during the earlier stages of the disease has a more marked impact on the CV outcomes. So it restores first phase insulin secretion, potential add-on to drug after metformin monotherapy. The proportion of the patients with the primary diabetic nephropathy or with comorbid diabetes and CKD who require dialysis is increasing. So repaglinide can be used safely in patients with CKD also. And this is CVD, I will take, it is safe as long as we can only say that, but it causes CV benefit, or there is nothing to support that. If you look at the ADA goals, we know that if the metformin is given alone, then 43% of the patients ADA goals, repaglinide 42%, but when we combine metformin with the repaglinide, then the chances of achieving the A1C target, they definitely improve. There are studies where repaglinide, metformin versus sulfonylurea plus metformin combination has been seen, and the repaglinide provided more suitable alternative to combination therapy with sulfonylurea and metformin because of its reduced propensity for the hypoglycemia. This is another study where repa and metformin combination with neticlinide and metformin combination was used, and the HbA1c levels values were lower for the repa metformin combination than for the neti metformin combination. So in summary, I would like to say that it is a rapid-acting insulin secretagogue. It lowers PPG excursions by targeting early phase insulin release, having effective glycemic control, and it is well tolerated in clinical practice. Effective in treatment naive or experienced adult patients with type 2 diabetes, including elderly patients and those with renal impairment. And flexible dosing is there, and it is related to the meal time. So if the patient skips the meal, then we need to skip the doses also. So with this, I would like to conclude my talk. Thank you very much for your patience listening.
Thank you very much, Dr. Amit, for a very precise, potent, professional, practical, for a very potent, practical, and professional approach to the drug. I have just one query I think you will be able to answer, and my great friend, Dr. Karla, will throw some light. This drug is available and known to the medical profession for nearly 2 decades. Why it is so that it's not been so frequently used?
Sir, I think I may not be able to give that answer because I was also in that category almost 2-3 years ago. I was not using this drug, but of late.
Dr. Karla, your comments, sir?
Yes. So I think
The first came was the torrent they brought by the name of Urepa.
Guidelines, they don't mention about it. What kind of pharma economics goes behind it, we don't know. But as a learner, we should always be aware that this class of drug is also available and is available with us. And not all, but some percentage of your patients may find a good use of it. Yes.
Thank you very much.
Thank you.
With this, we come to this end of the session. Dr. Joshi, please introduce the next speaker.
You describe the different mechanism of action of this of repaglinide with the sulfonylurea. So can we use this with the sulfonylurea with the repaglinide?
Sir, sulfonylurea and repaglinide combination is not recommended.
Definitely not, but the mechanism of action is different. You have described also.
Sir, but ultimately they are both insulin secretagogue. Na? So adding 2 insulin secretagogue to one patient, I don't think practically that makes any sense.
Yeah.
So whatever insulin secretion we will get, we can get from one also.
Okay.
Which you can make combination is this repaglinide and alpha glucose hydrolase inhibitors. That you can use, but not with the sulfonylurea which conventionally we are using it. That can potentiate the postprandial action.
Sir, HbA1c lowering potential, that is the efficacy, has been seen from 0.8% to 1.2% when compared to the other molecules.
So now we come to the next topic of this session, time in range concept in management of diabetes, which truly represent the theme of the DIABCON, technology and innovations in the management of diabetes. This topic will be presented by Dr. Parjeet Kaur, who is Senior Consultant and Endocrinologist in Medanta, the Med City, Gurugram. And she has done her MD from AIMS and DM Endocrinology also from the AIMS, New Delhi. She has been awarded many awards like MMS Ahuja Award for Best DM Resident, A.V. Gandhi Award for Excellence in Endocrinology, ISBMR Best Research Paper Silver Medal 2018, Golden AIM Women Healthcare Leader Award Diabetology 2022. She has done research in diabetes, obesity, PCOS, and she has published more than 40 publications in index journals. So with this, Dr. Parjeet Kaur, please begin your talk. Time in range concept in management of diabetes.
Very good afternoon to all, and thank you, chairpersons, for the kind introduction, and my sincere thanks to Dr. Anupam for giving me this opportunity. So all of you are, I'm sure, must be hearing this term time in range and reading also about it through various studies, and then recent review articles, recent studies are actually started including time in range as one of their outcomes in their studies. So definitely it's not a very new concept, but we need to have a little deeper look into it, how we can use this time in range in the clinical practice. So this will be the agenda of my talk. First, talking about the importance of time in range, what exactly it is, why we need it, what's the need of the time in range, what is the correlation of time in range with the diabetes complications, and how to measure and interpret time in range and targets, and finally, how we can use this term time in range in the clinical practice. So look at the slides. We all know that HbA1c is the gold standard for the measurement of glycemic control, and this is widely used. However, we need to be aware of the certain limitations as well of this HbA1c. And this limitation is clear from this picture that this is the basically graph of three patients, patient A, B, and C. If you see, all three of the patients have similar HbA1c, which is 7%, a pretty good HbA1c. But when you look at their percentage of time they're spending in the various glucose ranges, where green represents in the target range, yellow represents above the target, and red represents below the target. Patient A is spending 100% of the time in range, which is the ideal condition. That's how we want. Patient B is having some fluctuations, where having little bit more of hyperglycemia above target and some hypo as well. Whereas patient C is completely roller coaster here. We can see that a lot of hypoglycemia is happening as well as hyperglycemia, and time in ranges, time in the target is very, very less. So there lies the fallacy of HbA1c, that we just cannot see this one single metric and be satisfied the patient is doing good. Because of course, glucose variability does happen. There are multiple factors which affect blood glucose control. So, and this glucose variability will not be visible from just HbA1c. Here you can see again two patients, two graphs, similar HbA1c of 7.8. But one patient, if you see, is having almost a very beautiful roller coaster here, going steep down, steep up, then steep down and steep up again. And there is another patient which is also having blood glucose fluctuation, although not to the tune of that extent the patient A is having. But what you need to see is here is that this part, that if you see here that in the morning time, if patient is reaching here, both of these patients are having a fasting hyperglycemia. So if, for example, if the patient is on basal insulin, there comes a clinical implication. What decision will you take in these patients, whether to step up the basal insulin or not? So if you step up the basal insulin by 20%, which patient is likely to develop treatment emergent hypoglycemia? So definitely this patient who is already into hypoglycemia, and what this patient is having a reaction to the hypoglycemia of high blood glucose. So if you increase the basal insulin in this patient without looking what's happening throughout the night, that's going to be really a big disaster. That's where lies the importance of looking at the glucose variability and not just the HbA1c. So what are the risks of glycemic variability? What if we just focus upon HbA1c, because we have enough data with UKPDS and DCCT that HbA1c reduction does lead to reduction in complications. But yes, there are risks associated with glycemic variability, and we have enough data to demonstrate that glycemic variability does lead to increased oxidative stress and inflammation, which in turn causes the endothelial cell damage. Increased cardiovascular risk and decline in cognitive function, reduced quality of life has been demonstrated in the various studies. Glycemic variability now is actually quickly becoming an independent risk factor for the cardiovascular mortality in patients with diabetes, which is very huge. And high glycemic variability may also be, of course, a risk factor for hypoglycemia. So all these implicate that we just cannot ignore glycemic variability and just focus on one parameter, which is HbA1c. Similarly, SMBG, which is self-monitoring of blood glucose, has also some limitations, although this is still definitely better when combined with HbA1c. If you ask your patients to monitor type 2 diabetes patient, even if they're not taking insulin, just if you ask them to check once in a week, 10 days, and if they get the data for you, that will give you at least some clue. But again, there is a huge chance that we're going to miss out, because as you can see here, SMBG, whenever the blood glucose is tested, it's always coming in the target range, and we are going to miss out again the hypos and the hypers here. So SMBG will also not going to cover, because at the most you can ask a person to measure 4 times, 5 times. It is not going to cover the blood glucose fluctuations. So hence in 2017, ATTD consensus came out with this, to standardize this term, time in range. It came out and defined the time in range as the percentage of the time the glucose is within a predetermined target range. I will come to that later. What is that predetermined target range? So definitely it's a more accurate assessment of glycemic stability and as well as hypoglycemia. And time in range metric is now readily available with the use of CGM. So we have many studies showing time in range correlation with the complications. In fact, even this is a basically post hoc analysis of data from DCCT. So that time CGM was not there. So only through this 7-point monitoring, when this SMBG was done, through that only this graph was plotted. And here you can see beautifully how this time in range is affecting the frequency of retinopathy. That if the person is frequency, just time in range is less than 10%, the frequency of retinopathy is 58%, and it starts coming down as the time in range increases. And when the time in range is more than 70%, the frequency of retinopathy comes down to 5%. So this correlation can be seen data back from the DCCT study. But now recently the studies have started coming up, and they have shown that this TIR is definitely correlated with microvascular complications. We have yet to wait for the robust data for the macrovascular, but yes, for the microvascular in terms of retinopathy, albuminuria, as you can again see, time in range less than 70%, more than 70%, there's significant difference between the two groups here. And also a study where it had shown that all-cause mortality and cardiovascular mortality has also been shown to be related to time in range, where you can see the topmost graph of time in range being more than 85%, and the lowest with time in range of less than 50%. So even with less than 50% time in range, the graph is going down, the cumulative survival is going down, and the cardiovascular mortality is also increasing. So no doubt this is we need to carefully look into time in range to prevent such complications. So I'm sure this talk must have been covered already as far as the regarding CGM sensors, but just a slide upon available CGM devices we have. We have Medtronic, Abbott Libre 2 and Libre Pro. We have Dexcom and Medtronic Guardian Connect. Most frequently used is Abbott Libre 2 and Libre Pro, because this give enough data for 14 days, and this is the most commonly used, easily used. We do not have to calibrate also the data in this. So who benefits from the routine use? Whom should we put CGM? So all patients treated with intensive insulin therapy, multiple doses of insulin or insulin pumps. All patients with problematic hypoglycemias, if the patient is coming out with a frequent nocturnal hypoglycemia or hypoglycemic unawareness, if you're finding. Children and adolescents, no doubt here it has a huge role to play there. Even in pregnancy, pregnant women with type 1 or type 2 diabetes, or even pregnant women with gestational diabetes, there is enough data that this CGM helps in getting a better glycemic control. And also you should consider using CGM in type 2 diabetes patients who are on less intensive therapy. Even they are on just oral agents, there also there is some role that we can use this to identify blood glucose fluctuation, keep the blood glucose in range. So coming on to how should we interpret this, let's suppose now we get the CGM. So basically 3 components of CGM data. What we call as ambulatory glucose profile report. We have CGM key matrix here, we will find it here. We have ambulatory glucose profile in the form of curves, and then we have day by day tracings, every day what's happening. So CGM key matrix are basically number of days CGM is worn. Recommended is 14 days, but many studies have taken somewhere between 12 and 14 days, which is recommended. Percentage of the time CGM should be active, at least 70% of the data should be available to interpret. We need to look at the mean glucose level. We need to look at the glucose management indicator, GMI, which was earlier labeled as estimated A1C. You must have seen estimated A1C written on CGM reports. Now this has been replaced by the term glucose management indicator. And we need to look at the coefficient of variation, which is a measure of glycemic variability, and CV of more than 36% is considered unstable. So there are 5 distinct time in range categories. One is time below range, level 2, when we call it when the blood glucose level is less than 54, which is very low. Time below range, level 1, less than 70, which is low. Time in range, 70 to 180. This is now considered as a target. Time above range, level 1, more than 180. Time above range, level 2, more than 250. So they're basically now divided the above and below also into 2 categories, but the main time in range is 70 to 80 milligram per deciliter. And these are the time in range targets in various population. If you look at type 1 and type 2 diabetes, what is recommended at more than 70% of the time, the readings should be in the range, target range, which means the percentage of time the patient is spending in those readings. So this will be the average in the 14 days where the patient is wearing that CGM. You get that reading at the final, at the end of the day, end of the 14 days, and where you will see that more than 70% of the readings are in the target range. That's what we want. And less than 25% should be level 1 of hyperglycemia, less than 5% of level 2, less than 4% of level 1 hypoglycemia, and less than 1%, which is very low. Definitely we do not want that kind of hypoglycemia. In the older population, this little bit targets are loose, as we have loose targets with HbA1c as well, where the 50% what we want is more than 50% is what we want the readings to be time in range, in the target range. In the pregnancy, type 1 diabetes, target range should again more than 70%, which is recommended. In fact, surprisingly, pregnancy, gestational and type 2, which we might think could be easily manageable, no, targets are much more strict. And in fact, if you look at the target range in pregnancy, this is not 70 to 180. This is 63 to 140. So that much more than 90% of these readings should be there in pregnant ladies with gestational type 2. So definitely it has a huge implications on the pregnancy outcomes. That's why these targets have been developed. Now, looking at the individual component, we have a report summary here. What we need to look at the report summary carefully is, first, identify the patient correctly. Secondly, look at how many days the CGM was worn and what percentage of readings are available. Third, look at the average glucose, the glucose management indicator, which is 7.6% as written, and also look at the glucose variability, as in here it's 49, it's pretty high. And you will also get this kind of a picture where you can see the target range here in just 47%, and high and lows are present. And this is the ambulatory glucose profile. This is basically, there are 5 curves. This is kind of a model developed 14 days. We have individual graphs, and together they are made a single graph, where we have a median curve, where we have a 25th and 75th centile curves. Interquartile range, we have 10th and 90th centile curves. So what we need to look at carefully in this graph is that are the readings in the target range? What is the interquartile range, whether it's in, below, or above the target range? What are the patterns of hypoglycemia? Is any part which is going below it? What is the shape? Is it steep down or up? When it is moderate down and up? When it is flat? And what is the width of this interquartile or the dark blue band? More is it's wider, that means more is the glycemic variability. Narrow it is, less is the glycemic variability. So also we need to look at the daily glucose curve, because that's very, very important to understand how individual days patient is performing, and need to look at the pattern somewhere At the red showing hypoglycemias, yellow showing hyperglycemia. So daily notes on the diet, exercise, and special situation is necessary. That is the kind of instruction you're going to give the patient. And also you need to compare the weekdays with the weekends, whether it's differing or not. So this is the ACE recommendation for interpreting the data. Use a systematic approach. First, review the overall glycemic status in the form of GMI indicator. Then you check the time in the range, below and above range. Especially look at the time below range first. It should be less than 4%. Time in range should be more than 70%. Then you look at the daily profile, and then review the treatment regime. Addressing the problematic glycemic pattern then becomes the next step. And first, we need to address the hypoglycemia. If the hypoglycemia is present, review the potential meal skips, stop or reduce sulfonylureas. Whatever the measures or the causes are there, we need to correct that, adjusting the insulin dose. And then once you have addressed this time below range, then you come to the target range and again discuss the medication adherence and the diet and the physical activity. I'm going to end this presentation with this case study. This is a 73-year-old male patient with type 2 diabetes who has multiple comorbidities, including CKD. He's on a mixed insulin 30-70 regime, 40 units in the morning, 40 in the evening. His current HbA1c is 8.5, which has come down from 12% last time. But definitely is taking a huge dose, and here should rise a suspicion why this CKD patient is requiring such huge dose, and he just complains of occasional hypoglycemia. He definitely needs a CGM, and what CGM is showing here is that percentage of the time CGM is active is perfectly fine. Glucose management indicator, if you say 6.7, is showing pretty good, but that is not what we have to look into. Look at the target range, which is just 54%, but even that is also all right, as I mentioned, in a special population. But look at the hypoglycemia. That's where the problem lies. The very low hypoglycemia are 14%. So look at this graph where the patient is going steep, low, and up, and the daily profile. Some pattern should be identified, like especially in the morning times, the patient is having hypos, and late afternoon and the evening, patient is having hyperglycemia. So the actions to be taken: first, reduce or eliminate his time below range. Preferably, a basal bolus regime will be best for him. If he is not able to carry it on, then decrease at least the evening dose to prevent morning hypoglycemia. Then focus on the postprandial elevations by the diet modifications. And this was the follow-up of the same patient when he was advised to go through all this. What you find is a much better graph. At least hypoglycemias have been eliminated. There is some rise of blood glucose levels in the evening, but what you have done is taken care of the hypoglycemias. So my key messages here is that not all HbA1cs are created equal, this is my summary slides here. And glucose variability is not visible from just HbA1c. Time range is correlated definitely with complications. You need to interpret the CGM report carefully. There are certain time in range targets which you should be aware of, and address the problematic glycemic patterns with the use of CGM. Thank you.
Thank you very much, Dr. Kaur, for a crisp talk on time in range, highlighting the use of continuous glucose monitoring. And it's an idea whose time has come. It's not a question of whether you use it or not. It's a question of how long can you not use it. So with this talk, we are empowered with the knowledge of how to interpret CGM reports and the concept of time in range. Thank you very much.
Thank you.
Are there any questions?
Misleading advertisements, and they are being placed by MDs and DMs. I'm sorry to say that. But those advertisements, they claim that the diabetes can be reversed. Is it a misinformation or is it a true situation?
I totally agree with you, sir. So what they are doing is they are saying by using CGM. No, CGM is just measured to check the blood glucose level. This is itself is not going to reverse diabetes. But if you are in a process of giving a good diet and exercise to a person who is planning to get him into remission, intermittent use of CGM once in 3 months can help to identify the patterns of hypo or hypers. But per se, CGM is not going to lead to any reversal or remission.
And sir, one more, the previous speaker said that the diabetes reversal is not possible. You can only be in remission.
Remission is the term which should be used correctly.
That's what I wanted to know, because they claim total remission.
No.
And that, as a medical man, I don't think.
it's not reversal, it's remission. Yeah.
Thank you very much, ma'am.
Thank you.
Thank you, chairpersons and speakers. For next session, I'd like to invite Dr. Atul Gupta, Senior Consultant Physician, Dr. Ram Babu, Senior Consultant Physician at Jaipur Golden Hospital, Dr. Aruna Nigam, Professor and Head at Hamdard Institute of Medical Sciences, Dr. B.K. Singh, Senior Consultant Physician at ESI Hospital.
Good afternoon, everyone. So now we start with the session, and may I call upon Dr. Piki Saxena. She is a director professor in Lady Hardinge Medical College, and her biodata is quite huge. So I can say she has a multiple number of publications, and she has edited 6 books, winner of 32 gold medals. Madam, I am going to read down till you ascend to the this podium. And award for best research work in national and international conferences. She is a governing council member of DIPSI. She's an expert group member of Drug Controller General of India. So many things to her credit, and she's also a secretary, past secretary of Delhi Diabetic Forum. So stage is for you.
Thank you, Dr. Aruna, for elaborate introduction. And I will be talking on GDM, risk of GDM converting into type 2 diabetes. And we have been hearing since yesterday morning that GDM is the mother of all NCDs, and I'm just going to start my talk. So, hyperglycemia in pregnancy is a global pandemic. It is a huge challenge. About 127 million live births are occurring every year, and 65% of these are occurring in Southeast Asian countries, including India. Only 21 million per year are complicated by hyperglycemia, and 3 to 4 million are detected during pregnancy. Even after so much of widespread notion that GDM is going to convert into type 2 diabetes, it is going to lead to long-term morbidity, metabolic syndrome, coronary artery disease, and hypertension. Still, only 3 to 4 million are being tested during pregnancy. And about 2 to 17% are going to receive postpartum follow-up and lifestyle advice. So we know that hyperglycemia in pregnancy is one of the most common medical complications. 1 out of every 6 live births occur to a woman with some sort of hyperglycemia, 84% of which are due to GDM. And we know that 80 to 90% of all GDM are going to be controlled with lifestyle modifications only. So what we are facing right now is a slow motion disaster. There is an increasing global crisis in NCDs, which are going to have an impact on maternal and newborn mortality and morbidity. 2 out of 3 deaths occurring globally are due to non-communicable diseases. Non-communicable diseases are programmed and imprinted during pregnancy. So the diagnosis and management may help us to turn the tide of diabetes and NCD pandemic. So what is the extent of the problem? GDM, we know it occurs because of pancreatic beta cell dysfunction which is due to pre-existing insulin resistance. The girl who is born weight less than 2.5 kgs or more than 3.5 kgs, who is PCOS in childhood, gets obesity during childhood, becomes GDM, gets PCOS during adolescence, and then becomes GDM during pregnancy. So this is a forerunner of the future diabetes. Prevalence of GDM has increased by more than 30% over the last 2 decades, and the rate of type 2 diabetes after GDM ranges from 2 to 70% when we detect diabetes from 6 weeks, taking it to following up till 28 years. So prevalence of GDM is increasing in India, and it ranges from 3.6% to 17%, depending on which diagnostic criteria has been used and what is the population which is being tested. So as we can see here, this is a systematic review which was published recently in 2021. The risk of type 2 diabetes mellitus after GDM. So what they did was they studied 1809 publications, including more than 28 lakh women. And what they found was that 78,893 were diagnosed at type 2 GDM. The unadjusted relative risk, as you can see here, ranges from 1.32% to 47.25, and the unadjusted relative risk is 8.9%. So that is the magnitude of problem. The other thing is that the high risk factors are that as a woman, if the woman is obese, or she gets more weight gain during pregnancy, or she is PCOS, or she is having a high dose of insulin to control her glycemic levels, or she has a metabolic complication leading to macrosomia or a fetal growth retardation. All these indicate that she has a severe insulin resistance. And this is a beautiful paper where we can see the cumulative incidence of diabetes by BMI categories. If the woman is having normal BMI, the risk of diabetes is low. As the BMI increases from 25 to 29, the risk is increasing, and it becomes very high if the woman is having a BMI more than 30. And we all know that diabetes and obesity both are twin sisters, and they run along with each other. So pregnancy gives a unique window of opportunity to provide maternal care services, not only to reduce the traditionally known maternal and perinatal morbidity and mortality, but it has a great potential for prevention of intergenerational transmission of several chronic diseases like diabetes, hypertension, cardiovascular disease, and stroke. So in the postpartum period, there are certain important things which we need to do. First of all, we have to emphasize that the woman has to come for a regular follow-up with oral glucose tolerance test. We will be coming to each factor subsequently. Breastfeeding is very important. Contraception, dietary modification, exercise, family involvement, and goals. We have to set certain targets. We have to educate the patient what are the goals, and she has to work according to that. And for this, the most unfortunate thing is that hardly 2 to 17% of women are coming back for a postpartum follow-up visit. So what we can do is we can do postal reminders, telephone, e-calls, ask the ASHA worker to visit her at home, Skype, and during COVID time we were using telemedicines and e-Sanjeevani. So for aiming for universal coverage in the postpartum period, as you can see here, the Indian guidelines, American Diabetes Association, American College of Obs and Gynae, and NICE guidelines, all have suggested that they have to come back for a follow-up visit between 4 weeks to 12 weeks. And then it has to be done every year. And all women have to undergo a WHO GTT at this time. This was a study which we did in Lady Hardinge Medical College, and we followed up women in the postpartum period who had suffered from GDM. And out of 188 women who were screened and advised to come for follow-up within 6 to 10 weeks, we gave repeated phone calls at least 2 to 3 times, and in the discharge card also we told them to follow up, so that we could get at least 150 women who followed up. 20.2% did not follow up, and they all underwent a fasting plasma glucose and 75 gram OGTT and also HbA1c. What we found was that 13% were having impaired glucose tolerance, and pre-diabetes, that is HbA1c more than 5.7% was present in 5.4% women. So what are the problems, what are the barriers which prevent these women from coming back to a postpartum visit? Though, let us discuss the barriers for the patient. The woman is busy with a small child. She has to breastfeed the child. She has to look after the household activities. So there is lack of time and assistance in managing the young child. Low perceived future risk of type 2 diabetes. They are very much concerned about the baby while they are pregnant, and they would go to any lengths. They are following the lifestyle management during pregnancy. But once the baby is born, they are not aware that the baby and herself, 2/3 of these women are going to get GDM in the next pregnancy, and nearly 50 to 70% of them are going to become diabetes. So they need to be explained and emphasized again and again that they need to come back to us and follow up so that this can be prevented. So there is lack of knowledge regarding necessary lifestyle modifications. The transportation barriers are there. Their husbands are busy. They are not able to bring them to hospital. We are not having dedicated clinics where the woman will come. The priority is the antenatal patients and the patients who are sick. So we don't have adequate time, manpower. The system barrier is there. We need to take care of them. The patient is coming fasting. She's breastfeeding the child. She cannot wait in lines for so long. So we have to take care of that system failure. Lack of continuous motivation is there, work responsibility, fatigue, concerns about fasting while breastfeeding, and long waiting time. So what we need to do is we need to involve the husband, the mother-in-law, who is the most important person. So if we do a counseling for the whole family together, she will get continuous support and she will be more free to come to the hospital for all these things. Another thing is that the kitchen is going to be controlled by the woman of the house. And if she is able to control the kitchen and the eating habits, the dietary modifications, they are all in her hand. If we are going to take care of that, then all the people in the family and especially her offspring are going to be benefited. For the doctors, most of us obstetricians, I would agree here that we are not giving enough emphasis to postpartum care. We are happy that the baby is born, mother is healthy, and our job, the doctors need to be updated that this is a most important part of a woman having gestational diabetes. There is lack of sensitizations of obstetrician regarding the impact of preventive strategies, inconsistent advice by healthcare professionals, and lack of multidisciplinary teamwork. If we find that she is having impaired glucose fasting or impaired glucose tolerance, or she is type 2 diabetes, we need to refer her to our physician friends, to a physical instructor, diabetes educator, and a nutritionist. There is lack of coordination between all of us. So the importance of breastfeeding is that when a woman is breastfeeding, she is able to lose calories, she is able to utilize her glucose, the glycemic values will come down, and it has been seen in this beautiful study which was published in Diabetes, long-term protective effect of lactation on development of type 2 diabetes in women with recent GDM. What we can see here is that progression of diabetes If there is no breastfeeding, is very high. If she is breastfeeding for less than 3 months, again it is high. But if she breastfeeds for more than 3 months, then the progression of diabetes is very high. And the breastfeeding was associated with more than 40% long-term reduction of risk of developing diabetes over 15 years if she is breastfeeding for more than 3 months. Again, contraception. Women with GDM, they can use any type of contraception, but what we need to remember is that they are going to, if they are going to use estrogen containing OC pills, or they are going to use DMPA, it will increase the risk of getting type 2 diabetes by nearly 3-folds. This is a study which was published in JAMA, and the women who are type 2 diabetes or having diabetes for more than 10 years, they should avoid these estrogen containing and DMPA injections. Now the most important thing is GDM and lifestyle interventions. When we are having interactions regarding healthy lifestyle, including diet and exercise, we need to be respectful. It has to be patient-oriented. We need to give emphasis on what are the preferences of the patient. It has been emphasized and again yesterday and today. And I think it is very easy to say lifestyle interventions, but it is very difficult to follow them, adhere to them, and continue them. So we have to take into consideration the cultural, socio-economic, and ethnic differences. So interventions to prevent long-term metabolic complications, it includes behavioral strategies, motivation, as we heard in the morning by the psychiatrist, dietary intervention, exercise intervention, and pharmacological intervention. For behavioral strategies, we need to set a goal which should be realistic, and we should be having some objective criteria. The patient should be motivated for self-monitoring, stimulus control. We need to solve the problem. Assertiveness training should be done. Patient should be instructed to eat slowly, and this has to be reinforced again and again to prevent any relapse. So the key for retention, adherence, and maintenance of healthy lifestyle is support and continuous engagement. In dietary interventions, we know that GDM is closely associated with obesity, so we need to tell the patient your target for BMI, your target for blood pressure, lipid control, and the patient has to work on that. General healthy eating habits have to be emphasized, and 2 to 5% weight reduction will improve metabolic and reproductive functions. Exercise at least 150 minutes per week of moderate exercise, or 75 minutes per week of vigorous intensity exercise, and also not just walking, but muscle strengthening, muscle resistance exercises should also be done on 2 non-consecutive days per week. Leisure time activity is again very important. We should walk the stairs, we should go walking as much as possible. When we are sitting in the OPD, after every half an hour for 10 minutes or so, we should try to stand or do something physically. Ideally 10,000 steps, including 30 minutes of structured physical activity is important. And of course, we need to reduce sedentary and screen or sitting time. So the physical activity should have SMART goals. SMART means specific, measurable, or objective. It should be relevant. If an old person is going to target that I'm going to run for 5 kilometers, that is not possible. Depending on the age of the patient, her socio-economic status, and all those things have to be taken into mind, and it has to be time limited. And every week you can increase the bout of exercise by 5%. 10 minutes of walking after each meal also helps. So self-monitoring with fitness tracking devices, technologies for step counting, and exercise intensity monitoring are useful adjuncts. Metformin I will not be deliberating upon. Not all patients are to be put on metformin, but women who have impaired fasting, impaired glucose tolerance, or any of these family history, obesity, all those patients we can refer to our physician colleagues, and they can be controlled on. Other insulin sensitizers are N-acetylcysteine, inositols, which we are using in PCOS patients. And lifestyle intervention and metformin, the effect of these two interventions on delaying diabetes among women with and without GDM. We can see in this paper that over 10 years, the woman with history of GDM, intensive lifestyle and metformin reduced progression to diabetes compared to placebo by 35%, that is by lifestyle management, and by 40% in women who took metformin. So the take-home messages are, we need to update knowledge of doctors to improve system barriers, educate the patient regarding the risks of developing future diabetes for herself and for her offsprings, and how important it is to come back to the hospital. Special timing should be there for PNC clinic, and we should devote a special nurse who should be sitting with a glucometer there so that point of care testing is done. Because one day the patient will come, the blood report is going to come the next day. How many times do you think the patient can come back? Electronic database and reminders can be there. Improving discharge instructions. I think this is the most cost-effective, most simple method. If our residents and our practitioners are able to emphasize these important points to the patient at the time of discharge, I'm sure many of them will come back. So I already mentioned about point-of-care testing by plasma-calibrated glucometer. In the villages, we can train our ASHA workers to do it. Referrals timely to the physician, nutritionist, diabetes educator, physical instructor. Linkage with immunization program. All mothers are going to come back for babies' immunization at 6 weeks. If we can have a GDM screening or the postpartum screening linked with that, we can definitely catch them there. Adoption and adherence to interventions like dietary modifications, physical activities, family support, drugs wherever indicated, emphasizing the need to lose extra weight. Patients should be encouraged to continuously feed the baby for at least 1 to 2 years, advise suitable contraception and counseling for a planned pregnancy after optimizing her glycemic and metabolic parameters, and after a thorough preconceptional counseling is very important. So we need to catch them young. This 5 to 10 year period in the pre-diabetes condition is the best place where we can go for remission or reversal of diabetes. It has to be a multidisciplinary team effort, and we should all be stakeholders. We all hold hands and pledge to curb this problem. Thank you.
Thank you, Dr. P.K. Saxena. It was very good deliberation on a very important but neglected aspect. We all know that 90% of the patients of GDM get cleared at the end of the pregnancy, but almost 50 to 60% tend to go to develop diabetes later on. That concept of having a postpartum care of the females after delivery is missing in our system, and that's the area where we need to sensitize everybody, every stakeholder, right from doctors to patients, and that has to start during ANC period itself to follow. What happens when the patient has delivered the child? She's discharged from the gynecologist side. अब तुम ठीक हो बिल्कुल जाओ अपने बच्चे के लिए pediatrician को दिखाते रहना. And that's all which is going on at the moment and everywhere. Anyway, it was a good talk.
Thank you.
And with the, in the interest of time, we won't be able to take much questions. Maybe one, that's it.
And I would like to ask, it's a general question, to my knowledge, just to say that as far as breastfeeding is concerned, how long do you recommend breastfeeding by a woman? Because you say up to 1 to 2 years.
Sir, 6 months is exclusive breastfeeding. Till 1 year is recommended for all, but now the pediatricians say it should continue till 2 years. For all women, not just for diabetics, for all. 6 months is only...
Next. Good afternoon, all, and thank you, organizing team, and especially Professor Anupam to giving the opportunity to sharing this session. introduce the next speaker, Dr. Vinod Arora. He is the associate professor in ILVS. He did the DM hepatology from ILVS, MD medicine from Lady Harding, and MBBS UCM Delhi. And he is the principal investigator and ACLS Research and Consortium, short-term observer, at Hospital Clinic in Barcelona, Spain, a membership award at European Association for Study of the Liver at Amsterdam 2017 and Paris 2018. And experience in the transplant, hepatology, critical care, medicine, and endoscopy procedures. He has been resource person under the project ECO since 2018, and 2 publications in hepatology, has several publications in national and international journals. So I request to Dr. Arora, please deliver your talk.
Thank you, sir, for the kind introduction. Thank you, sir. I'll be talking in brief about the concepts of NASH and diabetes. NASH and diabetes they intersect at many points. NASH and diabetes go hand in hand. The prevalence, this is a brief outline of my talk. I'll be defining NAFLD NASH, diabetes as a risk factor for NASH, the pathogenesis and the metabolic complication which have been associated with NASH, the evaluation and management of the NAFLD patient, therapies, the role of antiglycemics in the NASH, and summary. These are the publications which have been seen over the years. There's with the diabetes, which has increased tremendously from the years 1978 to 2017, and NASH has gradually been increasing. In the last 4 years, there's spurt in the increase publications on the NASH. This basically shows the worldwide prevalence of NAFLD and NASH. This is a normal liver. This shows non-alcoholic fatty liver. There's a balloon. There's fat in the liver, but there's no inflammation or the ballooning of the hepatocyte, which progresses if the injury continues to steatohepatitis. There's a inflammation and hepatocyte ballooning. The prevalence of NAFLD ranges up 25% worldwide prevalence, and in diabetic population it can reach up to 80 to 90%. In NASH, worldwide prevalence is 3 to 5%, which ultimately progress to cirrhosis, leading to increased fibrosis and predisposing the risk of complication of cirrhosis and hepatocellular carcinoma. And this is the spectrum of NAFLD. Initially the fatty liver, progressing to steatohepatitis, then fibrosis, cirrhosis, and liver cancer. These are the risk factors which have been associated with NASH and advanced hepatic fibrosis. The risk factors for NAFLD are diabetes, obesity, dyslipidemias, metabolic syndrome, polycystic ovarian disease. And they are the genetic risk factors in this study, which was done by Chalasani et al. And this basically showed the risk of advanced fibrosis increases in relatives with NAFLD with no advanced fibrosis by 12%, and patients who have cirrhosis, patients with the relative, the risk increases up to 18%. It was significant across the groups. What are the guidelines recommendation? Who is at the risk of NASH and advanced fibrosis? As per ASLD in diabetes, suspect NAFLD and NASH and determine the individual risk of advanced fibrosis. With the increased number of metabolic diseases, there is an increased risk of progressive disease. EASL recommends screening in patients for NAFLD in patients who are at high risk of cardiovascular disease, including the diabetes and metabolic syndrome patient. ADA recommends NASH and fibrosis screening should be done in patients with diabetes and pre-diabetes with elevated ALT or fatty liver. They have a bidirectional association. Traditionally, a disease of hepatologist, non-alcoholic fatty liver disease, has been major concern for all the healthcare providers. Endocrinologists and those caring for the patient who are having diabetes are at the center stage, as diabetes appears to worsen the course of NAFLD and the liver disease management, making it more challenging. Diabetes has been shown to have risk factor for NAFLD. This was a study from phase 3 trials of Big Lispro, and NAFLD was defined on the basis of MRI with liver fat more than 6%. In patients who are diabetic with insulin naive, type 2 diabetic, and insulin naive, and the prevalence of diabetes was 75 and 61% respectively. This was the exclusion criteria of the study, the similar study. The triglyceride more than 400 and EST-LT more than 2.5 upper limit of the normal. The mean BMI on type 1 was 28 kilogram per meter square, And this basically showed that in patients who had who are naive to insulin and who had experienced insulin, the patient who are naive to insulin had a higher prevalence of NAFLD. This basically shows the various markers which have been used to identify the NAFLD prevalence. Plasma ALT, CT, ultrasound usually do not identify many patients who are having fatty liver. It is fibroscan or MR spectroscopy which may help in identification of the patient who are having fatty NAFLD in diabetic population. Similarly, the fibro test NAFLD fibrosis score and this transient elastography will help in prediction of the population with having advanced fibrosis. These are the metabolic factors which are associated with the NAFLD, which it can be namely as decrease in the clearance of the insulin, increase in the resistance to insulin leading to hyperinsulinic state, increased production of the glucose predisposing to diabetes, increase in cytokine levels predisposing systemic inflammation, promoting atherogenesis, increase in triglyceride level, decrease in HDL, and increase in FOB promoting atherogenesis, and promoting heart disease by decreasing the ATP generation, promoting lipotoxicity, ischemia, and diastolic dysfunction, ultimately leading to increased risk of cardiovascular disease. So NASH should be a part of standard screening for everyone with diabetes. The patient should be screened for cardiovascular risk factors. They should be screened for diabetic kidney disease, retinopathy, neuropathy, foot care evaluation should be done, and NAFLD should be a part of the screening for the diabetic patient. The presentation is usually asymptomatic. Majority of the patients are discovered by chance, and mostly patients will present with fatigue. Say, often an incidental finding in abnormal LFTs, bright liver on imaging, incidental hepatomegaly. Common scenario can be during the statin monitoring, annual reviews in type 2 diabetics, lipid or hypertensive clinics, or medical insurance checkup. So if the patient presents with diabetes or pre-diabetic state, we have to initially do the ultrasound or the ALT. If it is normal, ALT value less than 30 in male and 19 in female, we usually have a lower risk for having NAFLD. They should be, unless until they are having this high risk, that is diabetes more than 10 years, evidence of steatosis, HbA1c more than 8.5, triglyceride more than 250, or if the genetic tests such as PNPLA3, TM6, SF2 mutations are present, then they show disease using the most common we use is fibroscan, that is transient elastography, or MR elastography, or fibrosis biomarker panel can be used to determine the level of fibrosis. If it is advanced fibrosis, can be referred to a hepatologist, or a liver biopsy can be considered. If it is indeterminate, liver biopsy can be done to confirm NASH, and if there is no fibrosis on fibroscan, the patient should be followed with periodic evaluation. Liver enzymes are usually inadequate for assessing the NASH or NAFLD. Normal ALT does not preclude NASH or progressive disease. Elevated ALT cannot predict NASH. They are not sensitive for NASH or NAFLD. Abnormal ALT may warrant workup for NAT, but is not sensitive or specific to characterize or rule out NAFLD. This basically shows with the varying degree of fibrosis, a change in the liver stiffness on the transient elastography. The fibroscan usually has a more negative predictive value rather than positive predictive value. Fibrosis score is usually uncommon with a low value less than 6, and higher values increase the risk of predicting more fibrosis, predicting the risk of more decompensation and complication. Overestimation of fibrosis can be noted in patients who are having very high AST/ALT, patients who are having biliary obstruction, congestive hepatopathy, obesity, or if any mass lesion are present, especially in the right lobe of the liver. They usually correlate with the portal pressure with the liver stiffness value more than 20. This basically shows a varying degree of the 0, 1, 2, and with stage 4, there you can basically demarcate the patient who are having the advanced fibrosis. So why it is important to diagnose NASH and advanced fibrosis? As the fibrosis stage progress, there's a decreased survival, there's an increased risk of mortality, and patients who are having any fibrosis, particularly more than or greater than equal to F2 fibrosis, they have been associated with increased mortality. NASH hepatic, the advanced fibrosis may quickly progress to cirrhosis in patient F3 to F4 progressing with a median time of 29 months, and the clinical event which can be in form of complication which are related to cirrhosis such as ascites, upper GI bleed, or encephalopathy or hepatocellular carcinoma. Usually 19% will progress in 31 months. So it is an integrated approach to obesity, diabetes, and NAFLD, which will be required by hepatologists, endocrinologists, and nutritionists. Risk reduction is essential. Screening for other comorbid condition is essential. Lifestyle intervention should be there for all, and we'll be talking about the same. Individualizing the anti-hyperglycemic medication, targeting the cardiovascular risk, and reduction in the body weight in patient with advanced liver disease. How to choose the drug for diabetes and weight management adequately. Is NASH reversible? This was a study which was done in patient who underwent bariatric surgery. In patient, 84% of the patient had resolution of the NASH within 5 years. They progress from F4 fibrosis. The patient had F0 to F1 fibrosis, 84% of the patient within 5 years. So NASH is reversible with weight reduction. This basically shows that they change in the inflammatory scores. There's an improvement of the fibrosis which can be noted. So coming on to therapies in the NAFLD and NASH, the benchmark basically is weight reduction, then improvement in the glycemic control, atherogenic lipid improvement, reduction in the lipotoxic fat, promotes resolution of the NASH and the fibrosis improvement. So these are the approaches which can be used. First is weight loss, which can be with the help of lifestyle, dietary and physical activity, which is the benchmark of all the studies. Anti-hyperglycemic agents which promote weight loss, such as GLP-1 receptor analog or SGLT2 inhibitors, bariatric surgeries. Other approaches which can be statins or metformin. Statin have been shown to reduce portal hypertension. Metformin have a controversial role in reduction in the risk of hepatocellular carcinoma. Treating diabetes and the cardiovascular risk factors via GLP-1 receptor analog SGLT2 inhibitors, treating hypertension, dyslipidemias, and liver-directed treatment, which are not very much proven, which can be in vitamin E or pioglitazone. So the lifestyle modification that have been recommended by the guidelines, diet should have 500 to 1000 kilocalories energy deficit. A goal weight loss should be 500 to 1000 grams per week. Exclusion of the NAFLD promoting component. Weight loss should be target around 7 to 10%. We'll be talking about the same. Bariatric surgeries, exercise which may help in preventing or reducing the hepatic steatosis, and both aerobic and resistance training can help in reduction of the liver fat. This basically shows how the things move in NAFLD with weight reduction. With a 3% reduction in the weight, we can see improvement in steatosis by in 35 to 100% of the patient. With 5%, the inflammation improves. With 7% of the patient, there is a resolution of the NASH, which can be seen in 64 to 90% of the patient. And for regression of fibrosis, you'll require 10% of the weight loss. So pharmacotherapy in NAFLD who have in NAFLD reserved for patients who have NASH and fibrosis. As per ASLD, pharmacological therapy for NAFLD should be given only to patients who have biopsy-proven NASH. EASL recommends if the patient is having significant fibrosis, the treatment should be offered. If the patient without steatohepatitis or fibrosis should receive counseling for healthy diet and physical activity, and no pharmacotherapy for liver disease. These are the guidelines which have been used to see the benefits of the drug in NASH. They have been decided on the basis of NASH resolution or fibrosis improvement, NASH resolution on overall histopathological reading or no worsening of the fibrosis, and fibrosis by more than greater than equal to 1 fibrosis stage improvement. So coming on to the diabetes therapy which have been used in NAFLD NASH to achieve the liver health. In adult with need to minimize the weight gain or promote weight loss, the guideline recommends GLP receptor analogs with efficacy for weight loss or SGLT2 inhibitors. They have may have some benefit in NASH. Semaglutide has been shown to promote weight loss. These are the various studies where trials have been done in which the various GLP receptor agonists have been compared. Semaglutide have been shown to promote the weight loss. Similarly, improvement in HbA1c and the weight has been shown more with semaglutide as compared to the canagliflozin with semaglutide. These are the trial which was done with liraglutide. NASH resolution with improvement of fibrosis have been noted with decrease in the body weight and mean decrease in the ALT values. Similarly, SGLT2 inhibitors have been shown to reduce the liver fat and help in improvement of the ALT values. These are the currently available drugs which have been used for targeting the insulin resistance: pioglitazone, liraglutide, semaglutide, exenatide, canagliflozin. They have been used for the treatment of used for the treatment of obesity, promoting the weight reduction, and these are the outcomes which have been seen in the NASH. They have been shown to improve the histological NASH, resolution of the without any fibrosis, worsening, or similarly decrease in the liver fat content. These are the various endoscopic measures which have been available in the treatment of the NAFLD and NASH. These are the balloon system which have been used, gastric emptying system, endoscopic sleeve gastroplasty, duodenal jejunal bypass. However, the guidelines do not recommend as of now. Bariatric surgery have been shown to improve the histology in the obese patients. These are the results which basically shows there's a significant improvement which have been noted in the liver fat, ballooning, and inflammatory scores. There was a study in our center only in which we have placed the patient who are having diabetes with NASH cirrhosis. 56 patients have been were placed intragastric balloon with a BMI of 35, and the weight reduction was roughly around 15 kgs. With a reduction of BMI by 10% at 6 months, and total body weight reduction more than 10% was achieved in more than half of the patient, and with a mean reduction of liver stiffness and liver fat in 10% patient, and around 3 patients of 56 required removal of IGB, that is intragastric balloon, before 3 months. So we are now moving from NAFLD to MEFLD, that is metabolic dysfunction associated fatty liver disease. It has been defined that is a metabolic dysfunction which basically leads to fatty liver disease, and any patient with liver fat in presence of obesity, overweight, diabetes, or any evidence of metabolic regulation has been defined as metabolic associated fatty liver disease. There are new terminologies which are coming and changing non-alcoholic fatty liver disease to metabolic associated fatty liver disease or genetic associated fatty liver disease.
Dr. Alwar, please try to summarize.
Done, sir. So to summarize, diet and exercise are recommended for all. As little as 3% weight reduction can improve liver fat, and up to 10% can reverse NASH and fibrosis. There is no standard FDA approved NASH treatment, but guidelines recommend vitamin D, vitamin E, and pioglitazone. Diabetic therapies that are currently under studies are GLP-1 receptor and SGLT2 inhibitors for the management of NASH and diabetes. Thank you, sir.
Thank you, Dr. Alwar, for this very nice talk on the burning topic of NASH. Nowadays, not only alcohol is the culprit for the damage of the liver or cirrhosis. It is the uncontrolled diabetes or the metabolic syndrome, which is the responsible for the NAFLD and the cirrhosis. So nowadays, if you have early intervention, inform the detailed history of obesity and the agitated liver enzymes and the ultrasound suggestive of the fatty liver, then it's early easy to diagnose by the help of the fibroscan. Not need of now then intervention liver biopsy. So if we can diagnose early, then we can treat we can prevent the liver damage from the cirrhosis of them. But Dr. Arora, you have not mentioned in the treatment of the Bilapsa seraglutazole role.
Sorry, sir.
Any role of the NAFLD and NASH the Bilapsa seraglutazole?
We are using it, sir, but there are no guidelines which are recommending seraglutazole as of now, sir.
Okay. But practically we are have the good response from the cellular vilipsa and the weight reduction as well as the reversal of the fibrosis. And
Yes, sir, we have seen, sir, there's an ongoing trial in cirrhosis in our center only, sir, with seroglitazar, sir.
Okay, thank you so much. Any question from audience?
What is your objective criteria of continuing the therapy for NSLD?
Sorry,
because here, vitamin E you can't give beyond 6 months. What about pioglitazone? How long would you like to continue?
Usually we recommend for...
because vitamin E, the risk in male is increased incidence of prostate cancer. So you can't go beyond 6 months. That's what
yes, sir,
recommended.
400 twice a day, sir, 800.
What about pioglitazone versus this seroglitazone which has come?
Sir, there is no head-to-head trial as of now between pioglitazone or seroglitazar. Sir, seroglitazar we have seen in our practical experience also has been shown to decrease the liver fat and improvement in the fibrosis. Pioglitazar has been shown to improve both the liver fat and the resolution of the fibrosis. But the side effect associated with pioglitazone, we usually don't use pioglitazone. The common drug we use in fatty liver is pentoxifylline, sir, to reduce the inflammation of the liver, sir.
How long?
Usually for 6 months to 12 months, sir.
Thank you, Dr. Rao, and thank you for organizers.
Thank you, sir. Chairpersons and faculties are requested to collect the memento from the DDF counter outside. For the next session, I would like to invite the chairpersons, Dr. Sandeep Garg, Professor of Medicine at Azad Medical College, Dr. Anil Yadav, Senior Consultant at UCMS and GTB Hospital, Dr. Alpana, Professor of Medicine at UCMS, and Dr. Amit Kumar Sharma, Professor of Medicine at Lady Hardinge Medical College. Over to the chairpersons.
So this is the second last session of the conference, and now we'll come to the complication part. The first talk would be on diabetic nephropathy, and we have Dr. Sahil Bagi from Max Saket. He's a DM nephrology, and he has been various papers to his names, and he has been co-authored many 5 chapters at his National Textbook of Nephrology. Over to Dr. Sahil.
Good afternoon, everyone. Thank you, chairpersons, for a warm welcome. So I'll be speaking about diabetic nephropathy. So at the outset, I'd like to thank Dr. Anupam and the whole DIABCON team for giving me the opportunity to come here and speak in front of most of my teachers who have a great role in making me what I am today. So let's talk, I think in last 2 days we have all had discussion about the burden of diabetes. So the prevalence of diabetes is mind-boggling, and the projected estimates are even more staggering. So if you look into 2000, the prevalence was 171 million, which rose to 382 million in 2013, and it is estimated to rise to 592 million by 2035. And this is huge number is being contributed by type 2 diabetics. When we talk about India, India is not called capital city of the world without a reason. So 26 million people were diabetics in 1990, which rose to 65 million in 2060. If we talk about the states, the southern states, Tamil Nadu and Kerala, along with Delhi, form the highest prevalence zones, followed by Punjab and Goa. And it is estimated that by 2030 we'll reach a figure of 79 million. So if we look at the data from the US, we see that the diabetic kidney disease forms the most common cause of renal failure in the US. Then comes hypertension, then the glomerulonephritis caused by various diseases, and the cystic diseases then. So why is that we always fear diabetic nephropathy as a sinister complication of type 2 diabetes? So it's from this bar figure. So if you see, when there is a no kidney disease, the 10 years cumulative mortality was just 4%. You have an advent of albuminuria, the risk rose 4 times. You have impaired GFR, the risk further rises to 6 times. you have a combination of both albuminuria and impaired GFR, the risk rises to more than 11 times. When we look at the complications of diabetes in last 2 decades, we see that with the advent in the medical science, acute MIs, strokes, amputations, the incidence and prevalence of all these diseases have come down. You look at the slope of ESRD, it has dismally moved in the last 20 years. Diabetic kidney disease shortens the lifespan by almost 16 years, if you carefully look at the figure here. So as compared to a black line, which is a reference line, red line denotes an early CKD. Someone who has an early CKD at all age groups, the life expectancy decreases by 6 years. The purple graph, the purple line shows a presence of diabetes. When someone becomes diabetic, the life shortens by 10 years, and this is applicable at all age groups. Someone who has early diabetic kidney disease, the life shortens by another 6 years. That's total in cumulative, that's 16 years. That's a huge number, and this applies to all age groups from 30 to 70. So before we go ahead, I'll just like to clarify the two terms. Often we use diabetic kidney disease with diabetic nephropathy. It's synonymously used. So I like to draw attention that diabetic kidney disease, it's an umbrella term, which is primarily a clinical diagnosis referring to all patients with diabetes having a decreased eGFR that's less than 60 ml per minute per 1.73 meter square, or albuminuria, or both. When we say diabetic nephropathy, I would believe that people want to say that it's a histological diagnosis. The units which are primarily affected would be glomeruli. Clinically, if albuminuria coexists with retinopathy, then it can still be synonymously labeled as diabetic nephropathy. But please remember that diabetic nephropathy per se should always be labeled after histological diagnosis. And the gold standard would be renal biopsy to prove that. So coming on to the question, is albuminuria an absolute criteria for DKD? So the answer is not anymore. So there have been quite a lot of studies. The reference from which I have taken was published in Diabetes Care 2010. It showed that type 2 diabetic had a non-albuminic cohort of 39 to 52% as compared to type 1 diabetic, which had a cohort ranging from 7 to 24%. This group differs from the classical diabetic nephropathy patients, which we used to say initially. So in this group of patients, there would be less retinopathy. There would be female predominance than males, and the progression would be less than what it would be in the albuminuric kidney disease. Pathophysiology is a macrovascular involvement as compared to microvascular involvement in a diabetic nephropathy or albuminuric kidney disease. So to sum up, diabetic kidney disease would encompass diabetic nephropathy, which would be proteinuric diabetic disease, vascular and tubulointerstitial disease, or a non-proteinuric diabetic kidney disease. So most often when a patient walks in my clinic, the obvious question they have on their faces is, they have diabetes, they are well aware of that, and the question they want an answer from me is whether I'll end up with the DKD or not. So the answer lies in the following statements. Not all diabetics will develop diabetic kidney disease. DKD progression is variable. There are modifiable risk factors like hypertension, glycemic control, dyslipidemia, proteinuria, and smoking. There would be non-modifiable risk factors at all ages: age, race, and genetic profile. Then there are certain races which are more predisposed to develop diabetic kidney disease. These would be African Americans, Mexican Americans, and Pima Indians. And there have been a role of certain genes which predisposes one to develop DKD. Talking about the South Asian population where we currently are. So South Asians are at a higher risk for diabetic nephropathy. We are 4 times more likelihood of having albuminuria than our counterparts in the West. The rates of estimated GFR is 1.5 times higher. The decline is 1.5 times higher in our population. We have more individuals in CKD stage 4 and 5. And there have been hypotheses that RAS, inflammatory cytokines, dopamine, rage, oxidative stress all have been implicated in the pathogenesis. So before we go ahead and talk about the treatment, I'll like to speak about the pathogenesis of diabetic kidney disease. So we all know that the most important factor for diabetes to progress to diabetic kidney disease would be a state of glycemia. So hyperglycemia induces renal damage. This can be through a direct or through an indirect path. So direct path would be activated protein kinases C, increased AGEs, diacetyl glycol synthesis. Indirect would be through hyperfiltration, microalbuminuria, or stress. So direct pathogenesis would be by there is an alteration at the level of the resident renal cells which lead to production of more TGF beta 1, which leads to increased glucose uptake 1 molecule receptors, and then this leads to increased glucose uptake. This glucose uptake 1 receptors increase the formation of TGF beta, which in turn has an effect on extracellular matrix deposition. So coming on to this figure, this essentially shows an EM, which is commonly known as EMT. This is an epithelial mesenchymal transition. I think many of us would be well versed with this picture, which was taken from Robbins pathology. So TGF beta would lead to loss of epithelial adhesions, disruption of basement membrane, induction of mesenchymal markers, and de novo synthesis of SMA synthesis. So coming on to the direct pathogenesis, this is just to highlight the mediators which are acting at the level of the afferent arteriole and the efferent arteriole. I'll just come back to this after this slide. So talking about the indirect pathogenesis, we all know that there is going to be a nephron loss at some level. Remaining nephrons are made to work harder, and this is through the mediators like prostaglandin E2 and RAS. So coming back to the previous slide, so we know that at the level of the afferent arteriole there was action of prostaglandin. At the efferent level there was an action of the RAS system. So via the prostaglandin and RAS there occurs a hyperfiltration at the level of each glomerulus, which leads to more mesangial, tubular and glomerular injury. This leads to further nephron loss. This is again a vicious cycle, and existing proteinuria and systemic hypertension adds fuel to fire, and there is again a progressive nephron loss, and the vicious cycle keeps repeating itself until someone reaches the stage of advanced kidney problem. Coming on to the natural history of diabetes, for the moment I'll like everyone to just concentrate on the highlighted figure. So from a stage of no nephropathy to a stage of microalbuminuria, since this has been adapted from KI to NTE03, the nomenclatures from microalbuminuria have now been replaced by moderate amount of proteinuria and macro by the severe amount of proteinuria. So I'll stick to the older nomenclature for the time being. So no nephropathy to microalbuminuria, almost 2% of the patients per year would progress to microalbuminuric stage. From microalbuminuric to macro, again 2.8% of the people would progress. From macro to end-stage renal disease, again 2.3% of the people would progress. So by this figure, it's clear that almost 2 to 2.5% of people are going to progress every year from a preceding stage to a successive stage. However, on the extreme right-hand side, it depicts the death rates in all the stages. When a person has no nephropathy, then 1.4% of people are going to die of this cohort. Once someone enters microalbuminuria, the death rate rises to 3%. At a stage of macroalbuminuria, the death rate is 4.6%. But look at the alarming number: 19.2% of the people are going to die in the end-stage renal disease cohort. Type 1 diabetic or type 2 diabetic, 40% of the people would end up being a diabetic kidney disease. So now comes the question, we all know that diabetes is a menace. Since you can't get diabetes out of the system, getting the complications out of the system is impossible. So we know that prevention needs to be done, and it needs to be done at the earliest. That's what the role is of primordial prevention. You prevent diabetes and diabetes-related complications. Primary prevention, try to prevent the progression from a normal albuminic stage to moderately increased proteinuria state or a microalbuminuria. Secondary prevention would be from a stage of moderately increased proteinuria to a stage of macroalbuminuria or overt nephropathy, and tertiary prevention would be progression to an end-stage renal disease status. So this was classical Mogensen staging, which was described for type 1 diabetics. It showed that the life cycle of a diabetic kidney disease patient can be emphasized in 5 simple stages. As per the Mogensen, the stage 1 is where the ultrastructural changes happen. Stage 2 would be a moderately increased albuminuric state, which was then known as microalbuminuric state. Stage 3 would be an overt nephropathy stage, wherein the proteinuria would be more than 300 milligrams per grams of creatinine. So stage 3, stage 4 would be that zone. Stage 5 would be obviously when the EGFR reduces to less than 15. So again, coming back to the prevention, primordial prevention would mean you educate your patient well, you ask them to monitor their sugars in a better way, control their blood pressures, avoid smoking and weight reduction. Primary prevention would take all those considerations in primordial prevention. You have a better glycemic control, you ask for a better BP control, you ask for quitting of smoking, you ask for regular screening of microalbuminuria. Secondary prevention would be where we left in the primary prevention. You ask for a better sugar control, BP control, avoid smoking. Here comes the role of dietary protein restriction. And then there would be some role of treating hypercholesterolemia in secondary prevention. And the same would apply for tertiary prevention. Glycemic control, this is a major factor where we have to emphasize. So direct evidence of glycemic control comes from the beneficial effect of achieving euglycemia from isolated pancreatic transplantation and diabetes, wherein the study showed that 10 years after restoring euglycemic status, the ultrastructural changes in the kidneys got reversed. So these are all landmark trials which emphasized better and an intensive glycemic control. So DCCT, EDIC, UKPDS, Advanced Accord, these are all landmark trials. I will not go in detail. But all these trials did emphasize that intensive control is better than standard glycemic control. There were few complications and few extra mortality in Accord trial. Apart from Accord trial, every single trial did emphasize that there is a survival benefit to all these patients. Blood pressure optimization. So systemic hypertension augments intraglomerular pressure, and this leads to further hyperfiltration, further injury. This is what we discussed in the indirect pathogenesis. So intensive control versus standard control, Accord versus sprint gives us the answer. So verdict is that as per the KDIGO 2021, they derived the conclusion from the sprint and the Accord trial that the blood pressure levels less than 120 millimeters of mercury can be maintained in the non-dialysis arm. CKD5D patients, the BP targets can't be set in. They have to be individualized on the basis of the patient. So drug of choice just on the merit of amount of trials we have with the drugs, ACE inhibitors for type 1 and ARBs for type 2. So this is a recapitulation of what we spoke. Better blood pressure control, better sugar control. So then majorly comes of interest to the nephrologist. So that would be proteinuria regression. So regression from a moderately increased albuminuria to normal albuminuria is common, type 1 more than type 2. Regression of albuminuria is reassuring, but one must remember that once the albuminuria happens, the absolute risk of EGFR never cuts down. And why are we so much interested in reducing proteinuria? This comes from this study, wherein it showed that the rise in, there was a linear progression of mortality with the rise in UACR levels. There are multitude of trials which have been published for proteinuria regression. Again, these are all landmark trials. I will not go in detail. Other supportive measures would be diet and lipid control. So reversal of diabetic nephropathy has been suggested by one of the studies by following a ketogenic diet, but this needs multiple RCTs to put into action. Coming on to the novel interventions, so Carmelina and Carolina trial is something which instills confidence of using linagliptin by the nephrology community at least. So they were Carmelina and Carolina trial pulled in more than 13,000 patients, one compared with the placebo and one compared with the sulfonylureas. And the results were that they help reduce the proteinuria, offering no adverse cardiac and renal events. SGLT2 inhibitors, I don't think they need much of my attention. I think they must have been spoken in depth in this conference. However, these are the molecules who have taken they have taken everyone by storm. So these were two landmark trials for the nephrologists, which forced them to change their practice at least. So DAPA, CKD and Credence, both had around 4,000 patients. The estimated GFR in one inclusion GFR was 25 in one and 13 in one, and they all show such emphasizing brilliant results that primary endpoint reduction was 39% in DAPA CKD and 30% in Credence. Secondary endpoints were 44% reduction as compared to 34 in Credence. And definitely this instilled so much of confidence that it has led to a paradigm shift in the prescription, the way we wrote our prescriptions. Between these two, a head-to-head trial would be warranted before we say one molecule is better than the other. EMPA kidney trial, we just finished with the EMPA kidney trial in March 22. The results are not yet out, but it still lowered the inclusion EGFR to less than 20, which is why everyone in the nephrology community is interested and excited to know the results. Recently, the Bayer has launched its molecule finerenone. I'll just like to scan through 2 or 3 things. So MRAs, we all know that overactivation of the mineralocorticoid receptors can lead to inflammation and fibrosis. It has been determined that it's a key driver for progression of CKD. Phase 3 trials, Figaro for the cardiovascular and Fidelio for the nephrology community. So this was a trial wherein the primary benefits of the primary endpoints of the Fidelio became the secondary endpoints for Figaro, and the primary endpoints for Figaro became the secondary endpoint for the Fidelio. So the inclusion, this is one molecule which excitedly we have started offering to our patients. This is one molecule which can be given to even people for primordial or primary prevention, I would say. More than 90 GFR also people can be given this drug as per the package insert now. So as per this trial, type 2 diabetic and CKD people, more than 25 GFR were included. The inclusion criteria was robust, that potassium level should be less than 4.8 at the time of inclusion, and the maximum RAS dosage should be given. So around 10 or 20 mg depending upon the potassium levels were given, offered to these patients. And look at the results. I'll straight away come to the results. So in terms of cardiovascular composite, there was a 14% risk reduction as compared to 23% risk reduction in the kidney composite. Hospitalization due to heart failure was reduced by 22%, and dialysis population 20% risk reduction. So when we compare the forest plot, we see that non-fatal stroke crosses unity. Else in all cardiovascular outcome, it doesn't cross unity and it favors the drug. In unity, few touch unity, but again, in totality, it offers kidney benefits. GLP-1 agonist, I'll just go quickly through these. So GLP-1 agonist, I'll skip these. So the ideal patient for GLP-1 would be someone who has atherosclerotic heart disease, overweight but warrants a reduction in HbA1c and needs significant HbA1c lowering. This to be avoided in people with pancreatitis, medullary carcinoma, thyroid and gastroparesis. So I just wanted to highlight that all the GLP-1 molecules which Dr. Vinod did mention in his talk, they all have indirect evidence of decreasing albuminuria, and that's what excites the nephrology community again, that there is something to look forward for in the coming days. With the availability of semaglutide, we believe that again there would be a paradigm shift in the way we treat our diabetic patients. So these are all experimental modalities which have had no conclusive role from the trial. I'll just name them: brodoxolone methyl, psilocybin, pirfenidone, vitamin D receptor activators, endothelial receptor agonists. There was a belief that this is going to make a good change, but the SONAR trial and ASCENT trial, SONAR trial presented in 2019 in American Kidney Week, showed that we still have to work really hard in getting this drug to prove some benefits. So to summarize, diabetes and its related complications, if not managed timely, can result in significant morbidity and mortality. Prevention is always better than the cure. Triad of protein, sugar and blood pressure control forms the backbone of management at all preventive levels. Every effort should be made to stop progression of DVKD. Drugs which you should look to add in your prescription are probably after ACE, ARBs, and SGLT2, MRAs and GLP-1 agonist. And thank you everyone for a patient listening.
Just one question, Dr. Sahil. Is there any role of cystatin and NGAL, or would you like to wait for albuminuria for a patient to happen?
Sir, currently cystatin has not been standardized in all the hospitals. We, of late, they have been used in calculating EGFRs, and there are now upcoming modules wherein cystatin C has been made. Absolutely, sir. But as per now, sir, nothing has been standardized, and they don't give us a. I mean, we want an earlier answer, and for us, NGAL and cystatin C don't give an early answer. I think still we have to bet on serum creatinine. So I think we are still far away from biomarkers in helping us, at least in the nephrology.
In our day-to-day practice, we see two types of patients where the only evidence of the CKD is raised potassium. And second presentation is the urea is not very high, but creatinine is very high.
Yes, sir.
So how do you explain all those conditions?
Because so the whole essence of the talk was that there has to be a prevention. So once someone sees a patient with a slight increase in the creatinine, or even if you don't have a deranged KFT, but you have not screened your patient for microalbuminuria, but you have a diabetic patient who has been for many years been diabetic. So start screening. That's the lesson for all of us, that we
are not at that primitive stage as you are thinking.
Definitely.
No. We are not at that. We have screened the patient. We have done everything. We have found persistently high serum creatinine. Say, for example, creatinine is 3.3 and urea is 59.
Yes, sir.
And I am following this patient for the last 8 years.
Yes, sir.
So how do I explain? I can't understand.
So, sir, so urea is amongst the two, if I have to put my money on, creatinine is going to be the marker can be altered because of multiple factors. So you take in steroids, you take in tetracycline, you have a GI, these can get altered. So this would give you a false high urea levels. You have a muscle wasting, the urea levels can come down. So can creatinine, but disproportionately urea would be coming down more than the creatinine in these cases. And as far as the potassium you said, so the type 2 diabetes...
Isolated potassium or phosphorus level high?
Type 2 diabetes is a cause for distal RTA. So if your patient has a persistent hyperkalemia and the renal functions are normal, I would believe that distal RTA should be ruled out in these cases, because normal GFR and hyperkalemia persisting, either it has to be drug induced or it has to be related to your distal RTA.
And in addition, Dr. Sahil, in addition what you saying is low urea and relatively higher creatinine generally means poor nutrition. We advise too much of protein restriction where patient is already perhaps malnourished. Most of us take protein intake, which is advised for kidney patients. Most of our protein intake will most of the patients will not be requiring protein restriction because their already existing protein intake must be less than 0.8 gram per kg. And this poor malnutrition and this setup, low urea and relatively high creatinine, is a very poor prognostic marker. These people die earlier than people with higher urea and perhaps good creatinine.
These are patients which are being for 8 to 10 years and persistent
GFR check here.
Due to paucity of time, maybe we can just move on to the next session.
Thank you
and
so
we
much.
can, Dr. Sahil, if is available, would be happy to take more questions during in the tea time. Okay. So the next speaker for the session is Dr. Jasmine Parihar. She's consultant neurologist at Yatharth Hospital, Noida. She has done her post-graduation from LHMC, so she's back home, and her DM neurology from AIMS, and has also done her SC in neurology MRCP from UK. With 31 publications in her bag, she has also had awards like International Scholarship Award, Bursary Award, and Junior Traveling Fellowship Grant. So over to Dr. Jasmine for diabetic nephropathy. And I'm sure the residents sitting at the back are having a wonderful time with NASH, then diabetic nephropathy, and now diabetic neuropathy. All of them are topics which would be of interest to all postgraduates.
Yes, ma'am. Thank you for the kind introduction, and thank you, organizers, for having me here. And yes, my target audience is the residents, and my talk will be very, very clinical, and it will not be too much into the into the literature. So it will be very, very clinical, what I see and what I interpret and what I want to do with my patients. So my talk will be under these following headings, and as we proceed, we will just see. Diabetic neuropathy is one of the most common chronic neuropathy that is seen in India, and it is most common complication of diabetes mellitus, and it is seen that almost 50% of the patients are affected by 25 years of disease. There are various studies, and the incidences and the prevalences that have been reported are variable. In the landmark studies that have been conducted in England, more than 15,000 patients were included, and they found that the prevalence of clinical neuropathy means only on the basis of signs and symptoms, not including the investigations, other than, yes, presence of diabetes. So the prevalence was found to be 49%, and the prevalence of painful neuropathy was found to be 21%. In another study from UK, including more than 6,000 patients, the prevalence of diabetic neuropathy was found to be 28.5%. Incidence studies are very less, and in one study by Sanz et al., the incidence was found from 2 to 6, in diabetes mellitus type 2 was found to be 6.1 per 100 person years with diabetes mellitus. This was the incidence. Prevalence of diabetic neuropathy is related to the disease duration, the glycemic control, and presence of other complications like diabetic retinopathy and nephropathy. So in the Indian studies, the prevalence has been reported ranging from 10 to 32, and this has been compiled by Trivedi et al. In 2017, and there are various studies that have been done from various corners of India, and the prevalence have been reported in the wide range. But these studies are mostly hospital based. The prevalence would be even higher, and we would be picking up less people with diabetic neuropathy. So coming on to the classification of diabetic neuropathy, the diabetic neuropathy, as we all know, we generally feel that diabetic neuropathy is distal symmetrical polyneuropathy, but there is much more to diabetic neuropathy, and there are multiple types of neuropathies that patients with diabetes can have. These can be symmetric or asymmetric, and DSPN is the most common form. In the symmetric form, we have those with relatively fixed deficits and those with episodic symptoms. And in the relatively fixed, as we have discussed, DSPN is the most common. And there are some uncommon variants of DSPN that have been described in reports, and these include DSPN with that occur in acute severe form in early onset diabetes, pseudo-syringomyelic form of neuropathy, and the pseudo-tabetic form of neuropathy. And the other one is autonomic neuropathy. In those with episodic symptoms include diabetic neuropathic cachexia, hyperglycemic neuropathy, and treatment-induced diabetic neuropathy. In the asymmetric form, the form one which we commonly see is diabetic lumbosacral radiculoplexopathy. Then truncal neuropathies are commonly seen, and limb mononeuropathies are reported with diabetes, but we are not sure if they are actually associated with diabetes. So among the symmetric ones, DSPN, as we know, is the most common. I will not go much into the details. It is the most common form, length-dependent, sensory more than motor, and the earliest symptoms are patient will present with decreased sensations, tingling sensation or burning sensations in the distal part, because the terminal part of the neuron that is most away from the nerve cell body is affected first. That is why the most distal part of the body, that is the toes and the fingers, they are affected more than the proximal part. The earliest signs is decreased distal vibration, touch, pain prick, or loss of ankle sensation, ankle reflexes, and the symptoms generally progress from ankles to knee and then to fingers, and by the time the elbows are involved, there is a wedge shape of area of sensory loss that we can see in the trunk. And in severe cases, the patient can develop atrophy of the toe extensors and flexors. So here is the picture of one of my patients who have severe diabetic neuropathy, and as we can see the distal part, there is thinning of the skin, the nails are also getting thinned out, and in some part, in the proximal part, the patient also had loss of hair. We examine the patient, and as we have discussed, we'll find abnormal sensory examination, absent reflexes, and mild motor deficits. Motor deficits are less when examined, but on the NC we find age, and there is a profound weight loss of up to 60%. Patient can have associated symmetrical sensory neuropathy and painful dysesthesias of the limbs and trunk. And in this type of cachexia, the positive symptoms, like along that patient is also very thin, they have very severe positive symptoms of pain and tingling sensation, and the negative symptoms of sensory loss, like on examination we might not have much findings. Weakness is less prominent, and the patient may also have contact hypersensitivity, and this is associated with poor glycemic control. So this will be more common in the picture as we see in patients who have type 1 diabetes mellitus. And generally there is no correlation with diabetic nephropathy or retinopathy, and as the diabetes control is started, this process is reversible, and generally it doesn't leave any residual deficits. Then asymmetric diabetic neuropathies, among which the most common one is the Brun-Garland syndrome, which is also known as the diabetic lumbosacral radiculoplexopathy. And the other forms of asymmetric neuropathies include truncal neuropathies, which can be thoracic or abdominal, cranial neuropathies, or limb mononeuropathies. So Brun-Garland syndrome is also known by proximal diabetic neuropathy, ischemic mononeuropathy, multiplex, femoral or femoral sacral neuropathy, diabetic amyotrophy, and multifocal asymmetric neuropathy. If we are suspecting a patient to have any of these syndromes, like this syndrome with multiple names, we should be aware that this might not be picked up on, if this is the only thing that the patient is having, this might not be picked up on the routine NCV test, because on routine NCV test, we are examining the distal nerves. We are examining the common peroneal and the posterior tibial nerves. But this, as the name suggests, is involving the proximal part. that is the femoral and the sciatic. So we have to be very particular in writing when we write our NCS form that we want the proximal muscles to be examined. So we write NCS neuropathy protocol, diabetes neuropathy protocol plus lumbosacral plexopathy protocol, so that the proximal nerves are also involved when the technician does the NCS studies. This mainly affects the older people more than 50 years and affects 1% of the diabetic population, more common in males, more common in type 2 diabetes mellitus, and it is often unrelated to the glucose tolerance. The patient might come with very good glycemic control but with such symptoms. Patient can have weight loss, and this can be the presenting manifestation of diabetes, and this can be the first time we find out the patient is also diabetic. Generally the presentation is with unilateral lateral thigh pain, and this may spread to the other side within weeks, and this is followed by proximal weakness, which is mostly unilateral or asymmetrical, but the involvement of the other leg can go on and happen if the process is uncontrolled. And proximal arm weakness is involved in, proximal arm involvement is there in 1/3 of the cases, which is known as cervicobrachial radiculoplexopathy, and thoracic involvement has been reported in 12% in one series. Respiratory involvement is very rare. This form of neuropathy has stepwise or gradual progression. So this is in one of my patients. If we can appreciate the lateral thigh muscle mass loss. So you have to strip the patient. It is very important that you just don't pull up the lower part of the pants and tell them to show the toes. You have to strip the patient to see the proximal part if the patient is complaining of symptoms in the proximal part, to see the atrophy. And it has been found that this is like the pathophysiology is related to the ischemia of the nerve, and later on the muscles that are supplied by that nerve may go atrophy. So there will be on examination weakness of the hip flexors, adductors and extensors. Later on the knee flexors and extensors may also get involved, and if the disease gets severe, the ankle dorsiflexors and the plantar flexors can get involved to varying degree. There will be profound thigh atrophy, and the distal part of may get atrophy if the disease is progressing. Then weakness occurs in the distribution of multiple roots and plexus rather than the single nerve distribution, and the cases are mostly asymmetrical, though symmetrical presentation has also been reported, and this is known as diabetic amyotrophy type 1. Type 2 is the classical one, and the type 1 is associated with the patients who have type 1 diabetes mellitus. And further on examination, we'll find the absence of knee and the ankle reflexes. Sensory loss is less common, but the patient can have associated DSPN, which will contribute to the sensory loss. So there are two types of diabetic amyotrophy, type 1 and type 2, and as I have told, type 1 is more common in patients with type 1 diabetes mellitus, and type 2 in those with type 2 diabetes mellitus. Type 1 is generally bilateral and symmetrical, type 2 is asymmetrical and unilateral, and the pain is more common in those who have type 2. Other symptoms like weight loss, spontaneous improvement, all these are common in these two. So in nerve conduction studies, the femoral CMAPs have to be advised, as I have told, and EMG is not required in all cases, but if we do, then we will find the spontaneous activities like fibrillation potentials in the proximal muscles, and CSF may show mildly elevated protein, but it is not too much elevated. And MRI, if done, can show nerve root enhancement. Nerve biopsy is not essential, but if done, will show the focal ischemia of the nerve. As I have told, that some patients may have upper limb involvement, that is known as cervical brachial radiculoplexopathy. I will not go in detail. And an important part, CIDP in a patient with diabetes mellitus. It has been variously reported that CIDP and diabetes mellitus are related, but this has not been proven yet in multiple studies. And identifying CIDP in patients with diabetes mellitus is challenging. And why it is important that we identify? Because CIDP is reversible and it is treatable. Unlike the other forms of diabetic neuropathy, which may not be treatable. And since the CIDP treatment requires steroid therapy, giving steroids in diabetes is a dicey decision for the clinician. So here is a CIDP score, which will tell us like whether the patient goes more in favor of CIDP or diabetic neuropathy. Now this score incorporates the clinical, electrophysiological, as well as some other supportive studies. And in clinical, generally the progression I will not go too much into details, but generally it has to be seen that a CIDP patients will have progression over a shorter period of time. A diabetic neuropathy patient will have a more slower course and more longer progression. And a CIDP patients will have more proximal involvement, whereas more distal involvement may be found in patients who have diabetic neuropathy. And in electrophysiological studies, I have underlined the most important things, that there will be distal latency prolongation, because the CIDP is more of a demyelinating type of neuropathy. So distal latency progression will be there, reduced conduction velocities will be there, and prolonged F wave latencies. These are the markers of demyelination. So these will be more common in patients who have CIDP and less common in patients who have diabetic neuropathy. And motor conduction block is also a marker of demyelination. In other supportive studies, CSF protein may be more elevated in patients who have CIDP and less elevated in patients who have diabetic neuropathy. Now, this score has been, these are the supportive parameters which will give us positive score, and those are the negative score which will be contradictive scores. And on the basis, the CIDP score can be -18 to +24 points. And if the patients have more than 11 points, then the definitive diagnosis of CIDP can be made. If the score is less than 2, then the diagnosis is unlikely. And in between, we have possible and probable certainties of the diagnosis. Then mononeuritis multiplex is, we are not very sure whether it is just a coexistence or it is actually related to diabetic neuropathy.
Dr.
Again,
Jasmine, you have to sum up fast.
Yes. Cranial neuropathy. So cranial neuropathies, the most common cranial neuropathy that we commonly see is third cranial neuropathy. Please don't forget to examine the pupils. If you examine the pupils, if the pupils are spared, then you are more in favor of it being a diabetic neuropathy. But brain imaging may be required to rule out the other complications like stroke, and management of diabetes is the only thing that you have to do in such patients. I will skip these isolated mononeuropathies. And in treatment, strict diabetic control is what is required. And it has been found the patient that who have strict diabetes control have a neuropathy. Neuropathy occurs in 5% of such patients, whereas if the patient is just conventionally controlled of diabetes, it has been found that the diabetic neuropathy occurs in 13% of such patients. Symptomatic treatment of pain is helpful. And here we have list, multiple studies have been done on each and every of these drugs, but overall conclusion is that the first line is tricyclic antidepressants, gabapentin, tramadol may be given, duloxetine and pregabalin. Then in second line we have many anti-epileptic agents which should be reserved only if the first line do not work. And here we have more anti-epileptics in the third line, in which we don't have too much of evidence, but have been tried in patients who are resistant. A few newer drugs which are under research have been put in the list, but the research is still going on. There are multiple topical agents that have been approved. Diabetic autonomic neuropathy is treated as any other autonomic neuropathy. Orthostatus is treated with fludrocortisone, midodrine, NSAIDs, brufen, and indomethacin. For gastroparesis, we have metoclopramide and erythromycin. For diarrhea, we have clonidine, and for impotence, we have sildenafil. For management of DL-SRP, we do not have any extra thing, but the thing is that control of diabetes is very important. And various therapies, various immunomodulatory therapies, immunoglobulins, plasma exchange, and azathioprine have been tried, and it is the clinician's perception what they want to try depending on the patient's other risk factors. Like if the patients have cardiac disease, we would not like to try IVIG first. And immunotherapy has been repeatedly studied in various systematic reviews. And this systematic review was done first in 2009, then 2012, and then finally 2017. And the author's conclusion is that there are no randomized trials in support of immunotherapy, and neither they are against the immunotherapy, so it depends on the clinician's perception. I will skip this diabetic muscle infarction. Can I just take 2 minutes on this? This is for the residents.
We can have it later. You know, they can talk to you later on
All
because we
right.
are already late. We're
All
already late by 1.5 hours. So please sum up.
Thank you. That's all.
Thank you. So anybody want to ask any question? Just one question, sir. Yes.
Guidelines for the negative symptoms, say loss of sensation, which is very patient says पैर सुनना है उसके लिए what do you do?
Topical agents they may give them the symptomatic relief, but it is not that.
Loss of sensation.
Yes, even for the loss of sensation, that abnormal feelings that they get with the loss of sensation, because loss of sensation is mainly an examination factor, but the patients themselves feel some heaviness in that area because of loss of sensation when they sit or when they touch that area, they feel some heaviness in that area. So those symptoms can be controlled with those topical applications of the agent, but otherwise we don't have anything that we can offer for them. Like lidocaine, like capsaicin, all these agents can have some relief. Yes, these non-nasal things can definitely be tried, and patients themselves say that they do not remove this oxygen line because they feel better. Not.
Jasmine, wonderful talk.
A very good evening, everybody. I am Dr. Soumya Sagar, and I am an assistant professor in medicine department here at Lady Hardinge Medical College. So we have come to the end of 2 very illuminating days of this week, and many congratulations to the organizers, and very thankful to the eminent speakers. I think I speak for everyone when I say that we have gained a lot, and it was great to be a part of this informative pool. This is the last session of this DIABCON 2022, and it's a panel discussion with the topic as newer vistas in managing diabetes and its complications. And for this, I would like to call upon stage our panelists, Professor Rohit Saxena, sir. Sir is an ophthalmologist and working in AIMS and with a special interest in pediatric ophthalmology, strabismus and neuro-ophthalmology services. Second, I would call upon Dr. Gunjan Agrawal, ma'am. Ma'am is an senior consultant in internal medicine department at Maharaja Agarsen Hospital, Delhi. Thirdly, I would like to call upon Dr. Archana Gupta. She is a clinical nutritionist and dietitian, and she is working as a consultant dietitian at Chandra Lakshmi Hospital. Diabetes is an ever-growing branch, and the cases have been on rise since the disease was discovered, and it will continue to do so until and unless a miracle occurs. But every cloud has a silver lining, and so does this. The silver lining here is that the rate at which diabetes is spreading its wings, the similar pace has been observed in the advancement in the management of the diabetes and its complications as well. So without wasting any further time, I would like to start with the discussion.
First question is for you, sir. Please opine about the recent anti-VEGF studies comparing bevacizumab, ranibizumab, and aflibercept.
Thank you. This is a very important aspect of managing diabetic retinopathy. Essentially, just before I answer this very specific question, I'll just give you a background about these three drugs. Bevacizumab, originally introduced as an anti-cancer drug, comes in a multi-dose vial because obviously the doses we require intraocularly are very less. So the vial costs about 28,000 or so. And we are able to actually dose almost 20 people or 20 patients. So the cost is somewhere around 1,000 to 1,500 per dose. Ranibizumab was a specific targeted intraocular anti-VEGF first time by Roche. And currently it is marketed at about 18,000 or so. And of course now biosimilars are available, which still also cost about 15,000 to 20,000 in the range per dose. And aflibercept is a very, very specific and introduced as a very potent drug for diabetic macular edema, and currently costs somewhere close to 40 to 45,000 per dose. So this is a huge cost range. So before I actually opined about their efficacy, I thought it's important for us to know the cost factors. Each is important. So the effect for diabetic macular edema is if the vision is moderately good, as in 612 or better. All these three have been seen to perform equally good. So you could use either, depending upon the cost that you can. Just that medico-legally it has been sometimes of an issue that some patients have actually written and said that cancer ki dawai aankh mein dal di, and that has created a lot of headlines in the newspaper. Other than that, if you're looking at a more affected eye, less than 612, then aflibercept has performed definitely better than bevacizumab, but is comparable to ranibizumab. So essentially, I would say cost does have a role to play in our decision making, but effectively all of them are relatively equal in their efficacy.
Okay, thank you, sir. Sir, while going through the literature for this question, I too came across a similar study which has been published recently in the NEJM, and it is an original article comparing aflibercept and bevacizumab. And it also shows the similar results that while they took two set of populations with similar ophthalmic conditions, and the results were also similar. So due to such a difference between their costs, we can always go ahead with bevacizumab, and next we can change into aflibercept if required. Thank you, sir. Ma'am, next question is for Dr. Gunjan, ma'am. Ma'am, what are biosimilars? And please tell us something about the latest approved biosimilar Semglee.
Yeah, biosimilars are the drugs which are actually they are same in the structure and the biochemical structure and the functioning as their biologic molecule. And biosimilars, as sir told, it is used in many diseases. And if we talk about biosimilar, it is actually an interchangeable biosimilar, Semglee, that is glargine YFGN. There is some structural change. Why it is known as interchangeable biosimilar is that even a chemist or a drug provider doesn't need to ask you for changing it. It's absolutely same drug. Why it has been developed is because it is of the less cost. So in the countries where glargine was sold at a very high price, like US, this drug will actually decrease the will be a cost-effective drug in that scenario.
Okay, thank you, ma'am. So the gist is that in long term, biosimilars are expected to ultimately lower the drug cost, improve upon the affordability and accessibility. And with Semglee in the market, we have moved a step forward. Thank you, ma'am. Next is a very, how much calorie reductions are recommended in a patient of type 2 diabetes mellitus, and what types of fats and carbohydrates should be prioritized for this?
See, calorie reduction is depending upon the patient's weight actually and the working condition, like he is a sedentary worker or moderate worker, the type of work he is doing. So if he is obese, then we can go for the reduction in the calories, like we can suggest 20 kilocalories per kg body weight. If the person is in the regular normal BMI, then we can suggest 25 to 30 kilocalories per kg body weight. And if the person is underweight, then we have to increase the calories up to 35. In the same way, we have to add on the food ingredients what they are going to use in their diet, like proteins, carbohydrates, and the fats basically. If we talk about the carbohydrates, then because of the type 2 diabetes, and if triglyceride is high, then definitely we have to cut down on the carbohydrates as well. If triglycerides are high and the lipid is irregular, then we can reduce up to the 10% of the calorie through the carbohydrates. Normally, for the normal people, we suggest around 50 to 60%. Here we can cut short to 50% only the calories. So we can go ahead like the 50% from the carbohydrates, 10 to 15% from the proteins, and the rest from the fat. And then we come to if the carbohydrate portion, it should be like high fiber and complex carbohydrates, not the refined one. Because everything is available naturally, less processed or least processed food is permissible, because there is the carbohydrate is easy to digest, it is going to reduce the your sugar level, like insulin sensitivity is going to be reduced, right? Insulin response is going to be increased, this lipid profile is going to be changed again, and fat content is going to be reduced. So for that, we will reduce the carbohydrate for the complex carbohydrates. And then the fat content, if we talk about that, then fat content should be 30% if we are saying, then less than 7% should be from the saturated fats. Otherwise, we can go up to the 10%, but for the diabetics, we can say up to 7. It can be reduced up to 3, 4, 5%, again the requirement of the body of the patient. And then rest of the thing, 50-50, we can divide like the MUFA and PUFA. In that way, we can go ahead.
Okay, thank you, ma'am. So it basically depends upon the BMI of the patient when he presents to us, and then we can act accordingly. And studies too show that even with just the medical nutrition therapy alone, the reductions of HbA1c which can be achieved in type 1 diabetes are 1 to 1.9%, and in type 2 diabetes mellitus patients are 0.3 to 2%, which is a significant number. So this will definitely help us in reinforcement of dietary changes in our patients. Thank you, ma'am. Next question is for you, sir. What role does DEXA implant has in diabetic retinopathy?
So thank you. This is again a rather important question, and for quite some time before these implants came in, we were being forced to give systemic steroids to patients who had macular edema, because it has been seen that macular edema was coming down, and it was such a challenge to maintain blood sugars in these patients. And when this DEXA implant came, we did find that it significantly helps to reduce the macular edema and therefore improve vision. Now, with the coming of the anti-VEGFs, the utilization or need for DEXA implants has considerably come down, because anti-VEGFs have been very effective. So these are now essentially restricted to those patients in whom the anti-VEGFs don't work, or there is persistent macular edema resulting in subnormal vision, or in patients who have a reason that they may have some cause for inflammation, like a diabetic patient with macular edema, necessarily requiring cataract surgery so that the media clears and we can do lasers and things like that, or they have some other inflammatory cause like uveitis or a systemic inflammatory reason. So that's the conditions where these DEXA implants are more likely used. Unfortunately, they have a higher complication or problem rate, because they are relatively strongly associated with raised intraocular pressure and glaucoma, which can be very refractory to manage, and sometimes we've had to actually do a surgery and remove those implants. So currently they have their role in non-responders, in those in whom there is an associated reason for inflammation, but first line is now anti-VEGFs as our intervention.
So, sir, is there a role of this DEXA implants in pregnancy as well, since or we can go ahead with anti-VEGF?
Yeah, so no, anti-VEGFs are definitely contraindicated in pregnancy. There have been reports of changes or damage to the fetus, developing fetus with anti-VEGF. So yes, in pregnancy, DEXA implants in patients who in GDM or in diabetics who become pregnant and see a rapid proliferation of their diabetic retinopathy, DEXA implants would have a good role. Yeah, thank you for highlighting that. Yes.
Thank you, sir. So in a gist, DEXA implants are basically an option for those patients who are not suitable for anti-VEGF therapies and for subpopulations like pregnant females. So there it's a promising drug delivery system. Thank you, sir. Next question is, ma'am, for you, Dr. Gunjan, ma'am. Ma'am, can you tell us about newer point-of-care devices for diagnosing diabetic neuropathy? We just heard that how diabetic neuropathic patients can present in so many ways, but if we could pick these patients before these even have symptoms, so can you please elaborate that?
Yeah, these point of care, there are some point of care devices. Those have been, I mean, they're not in the commercial market right now, but they are in the pipeline and have been developed by, there are DPN check, there are pseudo scans, there are other things which are actually they can diagnose and they can tell you the progression of the disease and even the severity. These are like, there is one DPN check. This is a diabetic polyneuropathy check, wherein we have a instrument which we put on the sural nerve, that is behind the lateral malleolus, and that detects the conduction and the voltage of the muscle after giving it a stimulus. So depending upon how much amplitude and conductance is there, we can grade the severity of neuropathy. Other will be a pseudo scan. Pseudo scan, as name signifies, it is for the autonomic neuropathy, wherein there is an electrode and where patient keeps their hand and feet, and the current is passed through the electrode. The sweat chlorine is counted by that thing, and the amount of chlorine that is there, depending upon that, the neuropathy. And third is there is an adhesive that is being put, that is neuropad, and there we see the change in the color, and the time taken for that color change is measured to see the severity of neuropathy.
Okay, so thank you, ma'am. Do you want to? So that was a very interesting thing to know. So these devices will basically in diagnosing a subclinical neuropathy. So even the patient who has not yet had symptoms, it will help to diagnose them. But there have to be more studies with stricter endpoints to know how beneficial it will be practically with patients. Thank you, ma'am. Next again is an important question for you, ma'am. How fiber-rich diet helps in management of diabetes mellitus?
See, fiber plays a very important role in the diabetes, as we need to focus on the sugar level, right? So fiber is helping all the patients to reduce the sugar level, as well as managing the lipid profile again, reducing the cholesterol level, reducing the triglyceride level, and help them to reduce the LDL level as well, and increasing HDL. Because when the patient take the high fiber diet, gastric emptying delays, and in between they are not able, feeling to have the to munch here and there and to eat any other things. So this is going to be help them to manage the sugar level in their stream, and as depending upon the medication they are on the thing, like 1/5 of the breakfast, lunch and dinner, 5 meals or 7 meals plan or 3 meals plan, whatever is required. So fiber is going to help in that. And along with that, fiber is also help in the constipation. Most of the time patient is having so much of medication, then this fiber is again going to help in the movement of the electrofoci and everything. And afterwards, fiber is helping in like fiber-rich food. That is again rich in the minerals, vitamins and everything. So that is going to be helping all the way.
And ma'am, does it help in regulating the glycemic index?
Exactly. If the patient is like taking the fiber-rich diet, definitely 0.4% of the this HbA1c can be reduced easily with a high fiber-rich diet. And so we have to like suggest the patient like take a less processed food, because the natural food is always available with rich of fibers. Less of this grinding or processing or the cooking.
Okay, thank you, ma'am. So it is around 15 to 35 gram of fiber. How much do you advise,
Yeah.
ma'am?
Like fiber, if I ask minimum of the 14 gram per 1000 kilocalories, otherwise we can say 20 to 45 or 50 gram we can go up to the fiber content.
Okay, thank you, ma'am. So other than adding bulk to the meals and helping with the satiety, it also helps in regulating the glycemic index of the meal. And and we know that glycemic index is how important the glycemic index of a food is in diabetic diet. So thank you, ma'am. With this, we have come to the end of this panel discussion session. And thank you all our dignitaries for sharing this information. And thank you to the listeners. Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, panelists and the moderator. Now we will proceed with the valedictory function.
तुम अनाउंस करोगे क्या? तुमसे दिलवाता हूँ. Good evening to all of you. After the hectic schedule of this academic event for long 2 days, now we come to end of the event. Now we are proceeding for valedictory session. So as you all know, we have conducted over the period of 2 times many activities for postgraduate students, like paper presentation. We have 18 free paper presentations were conducted during our conference for 2 days. Also, we have conducted 2 workshops. One is on insulin therapy and other is diabetic food workshop by Dr. Ashok Damir and insulin workshop by Dr. Nitin Sinha and Dr. Samir Gulati. So approximately 40 students in each workshop has participated and taken the benefit of these workshops. We also conducted yesterday in the evening DIABCON quiz 2022, in which there are 6 medical colleges from Delhi and NCR have participated and enjoyed the arena of diabetic quiz. During our conference for 2 days, we have enjoyed the academic sessions delivered by eminent speakers from all over India, and multiple deliberations on the various aspects of diabetes has been covered. As you can see, the whole program which is available in the brochure. We have covered almost each and every aspect of diabetes without any biasing and any special prescription to any molecules here. So now I invite our finance secretary, Dr. Piyush Jain, who is the master in organizing the quiz here, to announce the results of the quiz over here. also to mention, yesterday we had slight glitch in technical aspect, which has been not seen today. So we are now more acquainted with the AV system over here. So today's conduction was very smooth and uninterrupted conduction was there. So we have some, Dr. Piyush, I think, having some more secrets in revealing the quiz answers. Yes, Dr. Piyush, come.
So as Dr. Ashok told, yesterday we had the diabetes quiz and there were 6 teams, including MAMC, UCMS, Lady Harding, Santosh Medical College, ABVIMS and VMC. So 6 teams were there and we had around 4 rounds. It was mastered by Dr. Kansha, Dr. Rosmi, Dr. Rashmi, the quiz masters. And the first team was from the host institute, Lady Harding Medical College. Dr. Manas Dua and Dr. Rohan Sharma. Are they there? Please come up. Rohan Sharma. Dr. Kalra sir, please. Get on.
May we request Dr. Kalra sir, our founder president member, to kindly come on the dais and
hand over the
certificate to our winners of the team, quiz team. Yeah,
The second team was team MAMC, Dr. Anchit Garg and Dr. Rajat.
Are they here?
No. And third was team VMC. Third was team VMC and Safdarjung Hospital, Dr. Aditi Tripathi and Dr. Priyas. Are they here? No.
Very good.
Thank you, sir. We had around 18 paper presentations and we are divided into them into 4 categories. So from the category of diabetes and metabolism, the first prize was given to Dr. Suman Saurabh.
And we request Dr. Rajiv Gupta sir, past president and founder member, to kindly come on the dais and give the certificates to the winners, sir.
Dr. Suman Saurabh is there? No. Second goes to Dr. Prabjot Singh. Third, Dr. Akshay. Dr. Akshay is there? Dr. Akshay D. Dr. Akshay D from ABVIMS and Dr. RML Hospital. In the next category of diabetes and complications, Dr. Akshay. In the second category of diabetes and complications, the first prize goes to Dr. Prabhat Kumar Singh from ABVIMS and Dr. RML Hospital. Second prize goes to Dr. Nitin Rana. Third, Dr. Rahul Kumar Bairwa. Dr. Rahul, and there were one more prize in this, Dr. Prateek. Yeah, Dr. Rahul. In the next category of women and diabetes mellitus, the first prize goes to Dr. Astha Jain. Is she there? Second prize to Dr. Purnima Kiran. And third to Dr. Anamika. I think all 3 are not there. In another category of diabetes and risk factors, the first prize goes to Dr. Bhavna. Second to Dr. Ankur Verma. And third to Dr. Akshay Fasalkar. Dr. Akshay. He's there. Come. In glycemia and diabetes mellitus category, the first prize goes to Dr. Apurv Oja. Is he there? And second to Dr. Manas Das. Dr. Manas Das. Oh, sorry. Manas Das from Lady Harding. Come. Thank you, sir. Dr. Ashok to continue.
So I congratulate to all the winners of the quiz and paper presentation. So it must have been really boosted to you that you have presented paper over here and you got the certificate of appreciation from here. Thank you to all of you. So, as a secretary, it is my proud privilege to offer vote of thanks for this wonderful academic feast, DIABCON 2022. And you all must have realized that it has been a wonderful experience of conference for all of us that we have enjoyed each and every session with great enthusiasm. First of all, I would like to thank all the founder members and past president of the Diabetic Forum, Dr. Jeevan Prakash sir, Dr. Rajiv Gupta sir, and Dr. S.P. Kalra sir, for their constant guidance and blessings for organizing event of this repute. Thank you very much too, sir. I also thank all the senior members of the Diabetic Forum for gracing this occasion and making this event successful. I feel privileged to thank all the faculty who has deliberated wonderful academic lectures, chaired the session, and conducted workshop and paper presentation sessions, quiz sessions, for such an exemplary manner to make this conference successful. It is my privilege to thank all the organizing team members for their immense contribution to organizing this event of this repute. I thank Dr. Sachin Jain, Dr. Vinod Mittal sir, as a scientific chair for designing this academic event and designing the scientific program, so that we have enjoyed a lot. I also thank our Dr. Anil Kulshesh sir, Vice President, Delhi Diabetic Forum, Dr. Ramesh Agrawal, Joint Secretary, Delhi Diabetic Forum, our Treasurer, Dr. Piyush Jain. I also thank former Secretary, Dr. P.K. Saxena Madam, Dr. Rohit sir, Dr. Ashok Damir sir, Dr. Anwani Nigam Madam, Dr. Gunjan Agrawal, Dr. Shubhlakshmi, Dr. Hemant Saluja, and Dr. Anand Sethi for their valuable contribution to making all the event of this conference as well as whole of the activity of DDF throughout the year making successful. And and Ms. Kanchan Khanka also, as a DDF executive, thanks to her. I also thank all the faculty of Lady Hardinge Medical College for their active participation and support in organizing this event, especially Dr. Director Professor and Head of the Department, Dr. L.H. Gotekar sir. Our conference is made successful by the equal participation of all the delegates who has came across all over the Delhi NCR and nearby areas, who has made this conference very successful. and I also thank Director Professor Dr. Anupam Prakash sir, our dynamic president, the vision of and the thinking of which has made this conference very successful. I also thank the event management team led by Dr. Anand Sethi, Mr. Ravi Mahendru, Mr. Rajesh Sharma, Mr. Pankaj, the technical assistant. They all has taken care all the audiovisual, all the things which we have observed here very successfully. I also thank the participation from the pharma company who has given the contribution to Delhi Diabetic Forum to support this event. Novo Nordisk, Aris, Torrent, Abbott, Intas, USV, Sun Pharma and Lupin Metabolics. I also thank Mr. Avdesh Kumar Yadav, the office staff of our Delhi Diabetic Forum, who has, you must all know him because he has been the key member of our Delhi Diabetic Forum, who is communicating with all the members of Delhi Diabetic Forum in the all sort of purposes. So thank you, Avdesh. And I am sorry if I have left out some name. Dr. Amit Sharma is also here, my colleague. And Piyush, you want to say? And also thank technical staff of the Lady Harding Medical College who has given the contribution to this platform here and maintaining this conference in the digital format very well. And I thank on and all, if I forget some name, I am sorry for that, but thank you all, one and all. Thank you very much. With this, we close this conference. Thank you very much to all of you.
सही बात है, बिल्कुल। चेक काटने वाले तुम हो यार, तुम्हें खाना होता है। तुम्हें बताना है कि खाना ठीक है, चेक काटने लायक है कि नहीं।
आ जाएंगे सर।
किसे बंद करें?
ये दे दे रहा है,
ये कोई इसका है ना, मैम सी वाला लेवा देंगे।
सबको तो सर्टिफिकेट है क्या?
हाँ था तो आओ जल्दी फोटो खिंचाओ, जल्दी आओ तुम।
मैम एक वो प्रेजेंटेशन का वो सर्टिफिकेट नहीं है, 5% का